my. A very good morning to one and all of you, and I'm so glad to have all known friends sitting here, and I'm sure a lot more would join us shortly. And this was a dream which has come true. I think we've been working on having an ARC physical meeting at Kolkata for the last 1.5, 2 months. And the minute I requested OSWE, Dr. Subhash Nag, I had Dr. Sugato Paul immediately getting in touch. And it was just continuously planned, and in no time the program was ready, everything was ready, the tickets were bought, and we were just waiting for when we would be here with you all. I'm sure in another couple of hours this whole hall is going to be full. So let's not delay the process because there's so much of learning which will accrue over the day. So we shall start off with day and ARC and my whole team, Dr. Satyajit Sinha, Dr. Harshul Tak, Dr. Srinivas Joshi, Dr. Anaga Harur, and Dr. Rohit Saxena are all with me, some in person, some will present through the Zoom. And we all thank you for this awesome moment with you all today. Um, and I'm truly lucky to have Dr. Sugato Paul and Dr. Satyajit Sinha moderating with me through this course. Yes. Is Dr. Sayanto? Yeah. So we shall now start with our inviting our expert panel. I would request them to sit on that central table with Dr. Sandeep Mitra, who's a senior consultant at Silver Line Eye Hospital and Research Institute, Calcutta. A very warm welcome to you to take charge of the questions which are going to bombard you over the course of this session. I look forward to calling Dr. Arup Baumik. He is not yet joined us. He should come in shortly. And he's again a senior consultant, a versatile surgeon in cataract, cornea, and refractive services from Disha Eye Hospitals and Research Center. I call upon Dr. Pankaj Rapohila Liha Rupalia. He's not yet come. I request Dr. Love. Thank you very much, Dr. Love. He's one person who has studied many of my webinars with his amazing video pearls, and I'm sure he needs no introduction. He's a senior consultant pediatric ophthalmologist and director of the Netralayam, which is amazingly beautiful hospital, which is coming with a lot of futuristic directions. Joining us for an expert panel is Dr. Swaroop Pathak, and who's again a senior consultant and surgeon from Renuka Eye Institute, Calcutta, and Dr. Rajesh Mazumdar Chaudhary, who's here to join us, who's again a senior consultant in oculoplasty, orbit, and cataract surgery from Netralayam, Kolkata. And once he joins, we would ask him to share his seat with us. We have also with us Dr. Professor Rajesh Sinha would be joining us soon, who is the honorary treasurer of AIOS and has shown great commitment and drive to take AIOS forward, and is also the professor of ophthalmology in cornea, lens, and refractive services. And we have another young dynamic surgeon, Dr. Debashish Datta, who had me truly amazed a couple of weeks back when I saw some of those amazing surgery pearls he told us, and I immediately went forward and asked him that we definitely could not do without him on the panel. And he's from Disha Eye Hospital. Moderating with me is Dr. Satyajit Sinha. I'm sure he needs no introduction whatsoever. He's one is a member ARCE zone, but he's a chairman and the director of ABI Hospital at Patna. This is the second term of member ARC. He's specialized in cataract, refractive, and glaucoma services. And I think we all know, he's not just a figure in the East Zone, but a national figure of great reckoner, great friend of one and all of us. And Dr. Sayantan Ghosh is also our co-moderator, and he practices at S7 Opticals in Newtown, Kolkata, and I'm sure he's going to add his pearls to this meeting. Without delay, we shall go on to our first speaker, Dr. Satyajit Sinha, who is going to take us in this session on VAST, which goes from basics and advanced. And he is going to be talking on tips for centered Rexes, the challenges which come forth. On to you, Satyajit.
Showing about Rexes. I'll be speaking on tips to achieve centered curvilinear CCC of right size and the challenges which come along in doing it. Now, I want to show you from the beginning of what I do in my day-to-day operating room. And I think if memory doesn't fail me, it begins from Kolkata itself. Our friend Dr. Ajay Paul, he had designed a marker which we can put on the cornea, which I use every day in my operating room. And even though there are advancements like Varion and Callisto, in which you can have a microscope overlay and make the Rexes, but this simple instrument can help you a lot in guiding you going about making this Rexes. It's very important that you fill the viscoelastic properly. And even before filling the viscoelastic, proper incision making is very important. If the incision is too small, then there'll be leakage of viscoelastic and there'll be pressure on the Rexes when you are making it, and it may get extended. When you have adequately filled the anterior chamber with the viscoelastic, then you go ahead and start doing your Rexes, and you can follow the marks that you have made with the Rexes marker, which I showed initially, and then you tangentially go and pull towards the center and complete your Rexes. There are times when you can do nothing about it. It goes on extending, and that is the time you may want to not put stress on the zonules. And once you think there's nothing more that can be done, it is best to go and use Vanna's scissors and remove that part of the anterior capsule. And with the newer machines that have come, you can make the parameters lower and you can still do phacoemulsification in all these cases. Now, when are the times that you can get into trouble? When you're doing anterior capsulotomy, as we do in all our regular cataract surgery cases, or when you're doing posterior capsulotomy, as in pediatric cases, and in pediatric cases, and also sometimes now when there is a PCR, then it's being preferred to convert that PCR into a posterior capsulorhexis so that you can still put the IUL in the bag in the equator. Now, what are the types of CCC that you can be making it with? One is manually, which all of us are well versed with. With practice, it becomes easy. Either you use a Utrata or you use a cystotome. Zepto came in which nanopulse technology was used, in which you put it into the anterior chamber, nanopulse is used, and especially in cases like Morganian cataract, this Zepto is very economical, safe, and repeatable also. And then we have the Femto, which is very costly, but it gives good results. But its limitation is that if the anterior capsule is too thick, then you will not be able to make it with a Femto, and we are not using it for posterior capsulorhexis also. Now, one thing is a predictable runaway and one is unpredictable. In predictable, if you are not careful in the pediatric rhexis that you are making, the anterior capsule is so tense that if you are not careful, it will run away. That is predictable. And also, the unpredictable one is like the Argentinian flag. When you begin your cataract surgery, you're not very sure. You put the first nick and boom, it gets extended even before you have the time to put a high molecular viscoelastic and things like that. So there are ways of handling that, but that sometimes becomes unpredictable. And two of the major reasons of why that happens is increased lenticular pressure and increased vitreous thrust also, especially in hypermature intumescent cataracts. And as I said earlier, when there is a faulty primary incision, that is also the time when there is more leakage of viscoelastic and it can make your rexis more vulnerable. Also, situations like wherein the patient is uncooperative or there is poor visibility through the cornea, that is the time also you may lose your rexis. Some of the challenging situations in making this rexis can be seen during Marfan syndrome when there is subluxated lens, where you have to use additional techniques before making the rexis, in pseudo exfoliation syndrome, in small pupil, and in floppy recurrent prolapsing iris. You have to be extra careful while making these rexis. The rexis, once you have made it, also can get accidentally torn when you're entering with your paracentesis knife, when you're inserting or removing iris hooks and iris expanders, or the phaco tip itself touching the rexis margin. And if you have made a beautiful rexis, it may get damaged if the phaco tip touches. So it's very important that you always keep in mind that such an eventuality can happen. And for that, to deal further with it, you should have a high molecular viscoelastic device in your operating room at all times. You should have a Ostrata forceps so that you can pull it inside if it's getting extended. And it's a good idea to use Trypan blue initially to stain the anterior capsule. Sometimes when the anterior capsule is fibrotic, additional vena scissors may be required. And I'll show you one case in which it was very, very difficult to do this anterior capsulotomy. While we are doing anterior capsulotomy, CCC with much ease every day in every other case, in this one particular case, I found it extremely difficult to make an opening itself. Forget about initiating the rexis. It was so thick that I could not make a nick with the cystotome. I could not make an opening so that I could use a Vanna's scissors to cut open or initiate. So I tried multiple techniques, and then I thought I was putting too much stress on the zonules. And at one point of time, when I tried everything, then I thought it may be best to convert to SICS and then proceed instead of having a nucleus drop and things like that, and not bringing my ego in between that I have to complete it somehow. I tried from the periphery also. The anterior capsule was so thick that it would just not open. So then I converted to the SICS, and then I made multiple nicks. Then I was more confident. And at this point of time, you will see that even when I'm trying to hold the anterior capsule, it would still not help me in initiating the rexis. So now, with much effort, I was able to manage and see the lenticular pressure that is there. Once I got the rim margin, then I started doing the rexis, and the capsule was flexible in the periphery. And then I was able to manage to complete the rexis, and that also at one point of time it came and got stuck. And so then again, as I said earlier, sometimes we have to use Vanas. So I used Vanas and completed it, and the patient got good vision at the end of the day. The rexis was completed and the IUL was in the bag. So one of the primary reasons of making the whole idea of making a rexis is that you should eventually be able to put the IUL in the bag so that the patient doesn't have trouble in future. For beginners, it's good to use a peribulbar block. It helps in softening the eye and it helps in easier management of complications also. In additional, the vitreous thrust, it softens the eyeball with, if there is vitreous thrust, you can soften the eyeball with mannitol. And it's always good to use a high molecular viscoelastic. Decompressing the intumescent cataract to make a rexis. First, many ideas are there, but one of the ideas is to use a 26 gauge needle and remove the milky fluid which is there. It's important that you use Triffen blue when you are doing a hypermature intumescent cataract. And initially, it is good idea to make a small rexis and then enlarge later, as is shown in this picture. I'll skip this one. Starting from the other direction when suspecting uncontrolled extension of CCC, in this video you will see that the rexis is getting extended to one side, so you simply go with the venas and make a nick from the other side and then complete the rexis. Because if you keep continuing from this side, it will get extended and then it will be, and then it will go. I'll just one more slide is there. So take extreme care throughout the rest of the procedure. Complete the procedure from the opposite direction. Undue pressure on the posterior capsule. Even if you have made a small rexis, make sure you are not doing too much forceful hydrodissection. That will put pressure on the posterior capsule. The posterior, even after the rexis has run away, hydrodissection has to be done carefully. Prolapse the nucleus into the anterior chamber and phaco is done in between the layers of the viscoelastic. And some advocate changing it to can opener and capsulotomy. You should not bring your ego in between that. I have to do phacoemulsification at some point. If you think you're not able to going to complete the CC and it's going to be a threat to the procedure, convert to SICS. I'll skip this video and thank you for your patient hearing. Thank you so much.
Thank you very much, Satyajit, for giving us a good insight about CCC. I would request that I'm sure each of us know who's the next speaker. So please have your thing connected there before the end of the previous talk so that we can sail smoothly. So I have a question for the expert panel at this connection. Could we start with, hello, Dr. Love, I'll ask you this question. Now, when it comes to these intumescent cataract, do you believe it makes sense using a syringe, or do you think you can decompress with an IA probe, or would you do it with a phaco probe? I think we need one extra mic for the expert panel, please.
What I do is make a nick, and I generally use a syringe. And more importantly, I would say chondroitin sulfate helps a lot in preventing extension of the intumescent cataract.
Yeah. Would you try to decompress by going into multiple levels, multiple planes, or just take root in one central point?
One central point, then initiate, once you have decompressed that point, initiate the rexis a little bit more. When it opens, then again aspirate from there and then continue it like that.
Is there, to Dr. Debashish, I'll take this question. When would you think of making a large rexis in our routine cataract surgery? Which is that the one situation which you might wonder to make a little larger rexis?
It is only when the nucleus size is very big and there's no epinucleus, but the nucleus itself is the cataract entire. Then only I would like to go in to err on the larger side. A little bit, maybe for more than 5.5. Otherwise, 5.5 is fine.
I also believe that I would try to make it a little larger in pseudo-exfoliative cataract too, because of the chances of phimosis occurring in these eyes. I'm sure all of us do agree on that. Similarly, Dr. Sandeep, I wanted to ask you, when do you think you would want to make a little smaller rexis? I'm sure there are multiple situations. I just want to get our mind totally focused onto this.
Yeah, there are situations where we really need a good centration and good overlap of the IOL, especially all the premium IOLs, all the toric IOLs. And in situations like PPC, where we know that we may have to use the entry capsule for positioning the lens, then a little bit on the smaller size is preferable. We try to keep it little smaller.
Dr. Adu, anytime when you would want a little smaller rexis, I mean, smaller and big should not be too much because we don't want capture.
Yes, that's I want to mention that that should not be smaller than 4.5 or it should not be more than 5.25. So in smaller rexis, yes, definitely if it is, I prefer to do less than 5. It should be premium lens. I don't take any chance so that I want a one and in case of subluxation, I always try to make it smaller. It should not be so that CTR implantation will be more.
I would also keep in mind the cases of phaco traps, because there is a possibility of a post-operative shallow chamber and a little hypotony. So
Yeah.
if I make a little smaller axis, the chance of optic capture is less. And
Yes.
maybe if there is a posterior capsule dehiscence you're suspecting, and you think that the rhexis would be the support for an IOE,
Yeah.
maybe that again, you would have either
Yes.
an ideal rhexis or a little smaller rhexis.
Most of the cases we do capture the optics, so it should not be even less than 4.8. So
Pankaj sir, I would have a question for you. That for the beginners, like immediately after completion of their PGT, they go to the periphery and start with doing brown cataracts or mature cataracts. What did you like, or what did you suggest? Should they try for Rexis 100%, or should they go for Tomy, or sometimes, many times the Rexis goes haywire? So should they immediately convert to Tomy, or?
No, no, no. See, if we are doing the phaco, Rexis is mandatory. So number one, if you are doing phaco, Rexis is mandatory. But definitely, even if you are doing the SICS in the beginning, then also definitely they should try to do the Rexis, number one. Because if they are learning, they have to learn the Rexis well. Rexis in a hard cataract, Rexis should be large enough where you can prolapse the nucleus. And by any chance, if you feel that it may be difficult to prolapse the Rexis, prolapse the nucleus, then you can give the releasing incision. Definitely, like capsulotomy is not the answer.
Thank you. We shall now go on to our next speaker, Dr. Siddharth Ghosh, who again needs no introduction, a senior consultant surgeon and director of Global Eye Hospital, who has given us all an amazing meeting maybe just a couple of weeks ago, and is also a visiting consultant in Apollo Glen Eagles Clinic. And he's going to talk on something very quintessential for all of us to know, how to achieve a perfect chop across all grades of cataracts. Thank you.
Thank you. Thank you, Chitra ma'am, for this opportunity, and good morning, everyone. I'm going to talk about achieving perfect chop across all grades. This topic is a huge one, but we'll try to limit within 8 minutes. And as we all know that all size doesn't fit, like there cannot be one size for all. So it needs to be decided beforehand, like what kind of cataract, what kind of chopping technique is good for what type of cataract. Well, we all know that chopping is a maneuver used to crack the nucleus. This cracking actually requires less phaco power. It does lesser damage to the endothelium, and zonular stress is also less. And the chances of iris and capsular damage is also decreased because the phaco tip is employed only within the central zone. So these chopping techniques are very important to master for all kinds of cataract. Now, there are basically two types of chopping techniques. One is the techniques that use ultrasound energy, and the other kind of chopping techniques that uses manual maneuvers or maybe femtosecond laser to the head. Now, coming to the most important one, which we are going to really discuss in detail, is the ultrasound-based chopping methods. And they are, we all know that divide and conquer, stop and chop, horizontal chop, vertical chop, and also we'll talk a little bit about multi-level chopping. Well, we'll stick to the basics and the most important ones. There are many, many types of chopping, but we'll stick to the basics and important ones. And to start with, this was actually proposed, divide and conquer was proposed way back in 1991 by Gimbel. And here, it is one of the safest and, but it is one of the slowest methods. I think the video is really not visible. Screen brightness is maximum. Oh, there. Screen brightness. Projector brightness. Projector brightness. Slightly more. Maximum brightness go. Maximum. Yeah. This is maybe better. Okay, here we do make two trench and crisscross trench 90 degrees apart. So, it's a slow process, but it is a very safe process. And but this needs a very high FECO time and a lot of power is consumed. So here it's a very basic step and a very safe, as I said. Now, what is the end point of making the trench is that we need to see the red glow more brighter. So as you can see here, I don't know, but a normal screen would show a very bright red glow there. And using two different instruments, we can just initiate the crack which extends to the posterior plate. And this is how we can make four pieces, four quadrants, and each of these quadrants can be individually emulsified after. Like it's very simple, easy to practice. Right. Now let us go to the next type of chopping. It's stop and chop. Stop and chop is, again, it was introduced by Koch, and this technique utilizes a trenching again, but we make one long deep trench, and as you can see here, and it actually helps us to crack the nucleus into two. Like we can rotate and take it to the other side and extend the trench further to make it further deep. As I said previously, like we need to make it deep enough so that the red glow is more visible, and then make a crack. You can rotate the nucleus again and to extend the crack thoroughly. And it may look a very basic step, but I think these are the this is how chopping all started about. Now and then each hemisphere can individually be cracked and cracked by chopping. So that is why it's called stop and chop. And after the two halves, we crack individually each one, and then go ahead to emulsify the small pieces. Well, let us go to horizontal chopping. Horizontal chopping is again, that is a very important technique, very simple and elegant technique described in way back in 1993 by Nagahara. Herein, we actually pass the chopper across the endonucleus from the equator, as you can see in this animation, and bring the chopper towards the embedded FECO tip horizontally in the same plane. And that is how it cracks, and then we separate laterally. To look at the video now, it is important that to achieve a good horizontal chop, you need an adequate size capsulorhexis, at least 5 millimeters. It should be adequate, and a good hydro procedure needs to be done. You should see the fluid wave going across, so that we know for sure that the nucleus can be chopped easily. Now, this is a blunt chopper. You embed the FECO tip and pull the chopper towards the tip, and then separate. So this is horizontal chopper, and this is good for softer cataracts. Softer cataracts, it's really good, and it doesn't give any stress to the zonules. Now let us come to the vertical chop, wherein it is just the opposite. Here we embed the FECO tip in the center, and then we make a downward movement of the chopper, sharp chopper, into the lens, and we move the nucleus with the embedded FECO tip upwards, whereas the sharp chopper goes downwards. That creates a fracture line which needs to be separated by lateral separation. Now, this is how it is done, and this was actually described by Fukasaku and Dillman both. Now, this really helps in, see what it's done is, we go embed, and very near to it, a sharp chopper goes down, and then with lateral movement, we separate it. And these are useful for, when there is a small rhexis or a small pupil, when there is a subluxated cataract, or in pseudo-exfoliation syndromes, it's easy to use. And another extension of this part is multi-level chopping, wherein, as you can see, you have done the cracks, but we can move the chopper or the FECO tip deep down to separate the crack. We are going deep down to extend the crack to the posterior plate. Like how it is done is here we separate the fibers by multi-level chopping. We go into deeper planes to separate the fibers or the pieces to extend the crack to the posterior plate. That is how multi-level chopping is done, and these are really helpful in hard and leathery cataracts. Well, now the main difference between horizontal and vertical chopping are, horizontal chopping is good for eyes where the zonules are weak, like in high myopia and in traumatic cases, and vertical chopping works best for firm and brittle nuclei. In horizontal chopping, we need a blunt tip so that we don't injure the posterior capsule of the fornix of the bag, and vertical chopping, we really need a very sharp chopper. Yes, the non-ultrasound based techniques I'm not going to say in detail. So Akahoshi pre-chopper helps, and microfilament snare, those MyLoop, these also helps. They actually reduce the amount of phaco energy that is required later, and also femtosecond helps. So femtosecond,
Siddharth, if you could
yeah.
conclude.
This is the last slide, and nothing to say much. Femtosecond laser is used to pre-chop all the nuclei, and we can just separate and take out each piece. That is how it reduces, and it's all not very much dependent on surgeon factor. The cracking is predictable and accurate. So much less energy is used. Thank you.
Thank you so much.
Thank you very much. That was very elegantly performed surgeries. Our next speaker would be Anaga Harur, who is going to be talking on the Zoom link. Before I introduce her, I just have one question because I think we'll be running late. So I take the question with Dr. Love. Now, what would be your methodology change when you're chopping if you've had a rexis extension?
See, we would be lucky if the rexis extension is in a slightly softer cataract. If it is in a very hard brunescent, then what I do is first lower the parameters and multiple small chops, because then your separation, horizontal separation is less, and the chances of rexis extending to the posterior capsule is much lesser.
Yeah. Also, maybe you would not like to chop in the direction of the rexis tear and keep away from it, and also have to keep a constant look on the flap, whether it's inverting or
Flap,
inverted,
yeah, flap
which also
motility.
tells you that it is better to change over to an SICS and remove the nucleus. It's a wonderful talk, and we shall now go on to our next speaker, Dr. Anaga Haru. She is medical director of Anil Eye Hospital, Thane, and is a member ARC West, an extremely dynamic woman who is going on to 3-4 centers with her own capability and skill, and entrepreneur with a great future. So, and she is going to tell us about pupil expansion devices. On to you, Anagha.
Thank you, ma'am. Good morning, everyone. Am I audible, ma'am?
You are.
Yes, ma'am. Can you see my slides, ma'am?
Yes.
Yeah. A very good morning to everyone. Thank you so much for this opportunity. So when we talk of pupil expanders, first of all, the definition of a small pupil is actually different for different individuals. And it will depend on the surgeon's skill, his expertise, his experience, the intraoperative situation, and the iris tissue properties. We all know that this is extremely important because the technical challenges of a small pupil is basically because of reduced visibility. And in every step of cataract surgery, this can cause a hindrance, causing poor visual outcomes and an unhappy patient. So if you need to fine-tune the surgery, even before you go on to pupillary expansion devices, it starts with preoperative screening, making the phaco settings optimal, and also optimal use of materials. So you have a stepwise approach. If the patient is not really dilating for whatever reason, many times you may have pupillary adhesion, so a good synecholysis needs to be done. You can use intra or cameral mydriatics and viscodilatation. And yes, expansion devices are the go-to technology and the strategies which can help you give very good visual outcomes. So I would be speaking basically on iris hooks, the Melugan ring, and the BX ring, which are most commonly used. Now, the video on to your left basically shows that you may not necessarily use a pupillary expander in all the small pupil cases. You can go ahead with a little bit of experience without using expansion devices, but you have to take care that you need to be in the central safe 4 mm zone so that you don't catch the pupillary margin. Otherwise, as the pupil comes down during surgery, you can easily catch the pupil and it will keep coming into the phacoprobe. So you need to be extremely careful and gentle, especially during hydrodissection when the anterior chamber really um, the chamber reduces, and in during phaco chop, all the maneuvers need to be in the center. On to your right, we have a similar patient with a mid-dilated pupil, but if you feel that the cataract is hard or some other complications, so it's always better to go ahead using a pupillary expansion device. So these are basically iris hooks, which are bright blue polypropylene flexible hooks with a stopper, which is silicone. So here you introduce it through the 4 side ports that are made, along with the 2 side ports for irrigation and aspiration. And they are introduced gently through the side port. And as you can see, we are putting the silicone stopper. It gives us a very good opening, and you can go ahead with the hydrodissection, phacoemulsification, and other procedures. It is important not to pull the iris retractors too much towards the limbus, because that can cause excessive damage to the sphincter. Once the intraocular lens has been implanted into the capsular bag, the stopper is then gently removed by stabilizing the iris hook. You should not just pull it out, and then gently you turn it laterally and then remove it. Otherwise, it can get stuck in the side port wound. Once the iris hooks are removed, then irrigation, you can see how the pupil is still round and there is no damage to the sphincter. It's very important to know where to insert. If it is inserted too anteriorly, then it can cause bunching up of the iris or hooking up of the iris. And if it's too posteriorly, it can cause bunching up at the angle. So it is very important to know exactly where to insert it. Again, as you can see here, too much of sphincter damage can cause irregularity of the pupil. It's more time consuming and yes, multiple incisions, but for beginners, it works well. Next, we have the Melugan ring, which as you can see, it's a biplanar device, which comes with an injector. So you hook it on and then you use it, and then you can inject it into the anterior chamber during surgery. There are 4 scrolls which are then put aligned onto the pupillary margin. Now, this is a case of a Melugan ring, which we have used in a one-eyed patient where trabeculectomy has already been done. As you can see, the pupil is extremely small. Now, we can inject it with the injector, support it with the other instrument, and the 4 scrolls are then aligned, the proximal, the distal, and then the nasal and temporal. You can do it one at a time, or you can do it many times, even 2 together also. It gives a very good opening, and especially in rigid pupils, it works very good. And it gives a good exposure to all your phaco maneuvers. Once the intraocular lens has been implanted into the capsular bag, you can detach or detangle the Melugan ring, and then you use the same injector, hook it on, and then remove it. And this gives a very good outcome. Now, the BX pupillary expander, which has been innovated by our very own Dr. Suven Bhattacharya, is basically a hexagonal ring. It has 6 notches that engage the pupil and 3 flanges with the hole, 3 flanges above the hole, which are alternately above and below the iris. So first, you just look for whether there are any synechiae. Push in a little viscoelastic underneath the iris. I'm using a 23 gauge microforceps through the main incision. You can also use it through the side ports because it's very thin. The first flange is put underneath the iris, and the side ports are used to put in the other flanges, the one with the hole underneath the iris. So you can use a bimanual technique where you're using the microforceps to hold the flange and the Sinskey hook to gently retract the iris so as to release the flange underneath the iris. So you get a nice hexagonal opening. So you can continue your rexes and the other procedures very, very easily. Many times it happens that you feel that the ring may come in the way of the surgery, but with experience, you can do it very easily. You can see how each of the procedures is being carried out meticulously. Again, here, once the intraocular lens is in position, you hold the flange with the 23 gauge microforceps, detach the flanges from the pupillary edge so that it's not pulled, and then you can just gently hold it and remove it. It's very, very easy to explant. And final irrigation and aspiration. Even in cases of IFIS, I have found that BHEX works very well. There are some people who believe that it may not work so well, but this was a patient of IFIS. As you can see here, there's billowing of the iris. and you can see how the iris is trying to prolapse up through the main wound. But it still gives a very good result. Removal again is very easy. Just detach it from the pupillary margin and hold on to one of the flanges, and you can just pull it out. The advantage of this is it's a very thin profile and it can come out even through the side port or through the main port. So once this is removed, irrigation and aspiration is being done. You can see the billowing of the iris here. 6 hours post-op, you can see perfectly round pupil and no damage at all to the sphincter. This was a very interesting patient. We did the capsular access, and even before I went ahead with the hydrodissection, you can see the pupil came down. In spite of using intracameral epitrate and phenokin plus, it did not dilate at all. So we had no choice but to use a pupillary expander. So I chose the pupillary expander for this as BHEX. Now the challenge here is to put in an expander without damaging the capsular excess margin. So you have to be extremely gentle, and each time you are tucking in the BHEX ring, you have to make sure that it is not engaging the capsulotomy margin, so that there is no tear and no extension. So this was the end of the surgery. Again, removal is very easy. However, there can be some challenges and struggles in this, especially for beginners, because of the uniplanar nature of the BX ring. Sometimes, aligning the edge can be a little challenging. So sometimes when you're trying to put one flange underneath, the other flange may actually slip underneath the iris. In such cases, it's better to remove it and then insert it again, like how I'm doing here. So with time and over multiple cases, you can actually go through it easily. Here you can see how the phaco tip has just got engaged into it. So you need to be a little careful. So we need to engage it again. So these are just a few struggles, but many times with experience, you can overcome these challenges very easily. And this is the last case. Yeah, this is a femto patient where the pupil came down, and the femto capsulotomy is also on the smaller side, as you can see. Again, we are using a BHEX ring and expanding the pupil, going ahead, removing the capsulotomy flap. Actually, this was a multifocal IOL patient who had opted for femto as well as multifocal IOL. After the lens has been removed, we are expanding and extending the capsulotomy also, and then removing the ring. So to conclude, if you compare the Melugan and the BHEX, definitely BHEX is jointless, more economical in the Indian scenario, and it can be used with 23 gauge forceps, doesn't need an injector. So to conclude, in today's world of increased patients' expectations and use of premium lenses, the optimal use of devices like pupillary expansion devices can help us to overcome challenges and give good visual to outcomes to our patients and happy patients. Thank you so much for your kind attention. Thank you.
Thank you, Anagha, for a very elegant display of surgeries. I'm sure they were all a great learning pearl for all of us. One question which you could answer, or I would request anybody on the expert panel to take this question. Which is the situation where you would be, especially in a shallow antechamber, what precaution or caution you will take to get the Malyugan ring out? Any tips for these eyes?
Ma'am, if it's a very shallow anterior chamber, then first
Yeah.
is you should need to deepen it with good viscoelastic, so like Elon or chondroitin sulfate with hyaluronate, so that you have a good space to introduce as well as to remove it. With the Sinskey hook, initially you can first detach the scrolls and then remove it. Many times if it's just pulled, then it can pull onto the pupillary margin. So that's one thing that we can
So
do.
basically, she wants the anterior chamber to be more distended. You have anything to add?
Shallow is very difficult to introduce Malyugan ring.
Yeah.
First tip, it is preferable to use 6.25 device rather than 7. Then it is much easier. Because 7 millimeter Malyugan ring is difficult to engage in the iris because you have to stretch more. And it is better to use some amount of viscoelastics, preferably if you have a visco under the iris, slightly, at least first three cases, first engage the distal part, and the side way you can put some amount of visco, and then you can engage it. But even then, if you have a small AC, a shallow AC with EPP syndrome, then there is a chance of mid-brachial iris prolapse. You have to be careful to construct your wound also.
There is some challenge. Who's the next speaker? I don't know whether this guy.
Naga, in the meanwhile, beautiful videos. Just very briefly, what was the worst complication you have had with the iris expanders and how did you manage it?
You're asking me? Okay. Worst complication I remember with the iris hook, as I was introducing it, it actually tore the anterior capsule. It can cause. So, the tips can be a little sharp. We need to be very careful. So it is best to put it laterally, and only when you come onto the pupillary margin, you turn it like this and then take it. Second thing is, initial few cases, we are more aggressive and we try to actually get very good pupillary expansion. So you tend to pull more on the pupillary margin. So I think that should be avoided, because at the end of the surgery, the iris becomes very floppy and you can actually damage the sphincters. For Malugan ring, it's quite simple. I mean, sometimes it can be a challenge to hook on to the scrolls. And for BX, yes, sometimes it can slip on underneath the iris. So if that happens, it's better to just remove it entirely and then push it like you're doing it for the first time. There could be a little challenges and struggles for beginners, but with time you can easily overcome.
Thank you very much. We'll move on. Thank you very much, Anaga. Thank you very much for the beautiful presentation. We'll move on to the next speaker, Dr. Pradeep Mohanta. Sir needs absolutely no introduction. He has some of the highest number of teaching videos on YouTube, and he has a big fan following amongst postgraduates of his teaching videos. Dr. Pradeep Mohanta will be speaking on rocking the rock hard cataracts. Dr. Pradeep Mohanta, sir.
So, hello. Thanks, ma'am, Chitra, Ramamurthy, and brother Sugatu, Paul, for having me here. So this. So this is a rock hard cataract, and my technique in such cases is going through the substance of the nucleus and use high energy, high vacuum to keep the nucleus stable and divide the nucleus. First thing I do is a large rhexis. I use the utrata forceps, make a capsular tag, hold this tag, go anti-clockwise all around, and do a large rhexis in hard cataracts. Size of the rhexis is about 6 millimeter, not less than 5.5 millimeter in hard cataracts. Now, hydrodissection is done at multiple points. Small amounts of BSS is injected at multiple points. The nucleus is tapped gently. We cannot see the fluid wave going from one side to the other side. So we have to be very careful. And now, after injecting visco, the phaco needle goes in. After aspirating some superficial lens matter, the handpiece is turned. The exposed part of the phaco tip is little more than routine cases, routine soft cases. Now the tip of the phaco needle goes in just in front of the main wound into the substance of the nucleus. The chopper supports the anterior surface. The phaco needle goes through the nucleus towards the opposite equator. As it reaches the opposite equator, near the opposite equator, the chopper is used to get a good crack. 180-degree rotation, 2-3 scalps, one heminucleus is held with the phaco needle, and the nucleus is divided into 2 heminuclei. And now this heminucleus is a little larger in size. We're going to divide this heminucleus into 3 pieces. This is one. And then the larger piece is subdivided into 2 smaller pieces. This time also the phaco needle goes through the substance, get a good hold of the nuclear mass, and it is cracked. And now each triangular nuclear piece is tilted and emulsification is started from the apex of the nuclear pieces. Vacuum 450, flow rate 45, and ultrasonic energy about 80%, 80 to 85%. And after emulsifying 2-3 pieces, I come out, inject some visco to protect the corneal endothelium, and again go in. In such cases, we have to keep an eye on the movement of the posterior capsule as the nuclear pieces become less. This is the smaller heminucleus. It is divided into 2 pieces. And whenever there are some air bubbles, we have to remove the air bubbles to get a good view of the nuclear pieces. And then emulsification is carried out. If there is any to and fro movement of the posterior capsule, we have to be very careful. We can even avoid emulsification of the last piece and use IOL as scaffold in such cases, because after such hard work, if there is posterior capsular rent, we have to repent a lot. But in this case, there was no trampolining of the posterior capsule, and I continued with the phaco needle. And during this time, I decreased the vacuum to 250, flow rate about 25, ultrasonic energy about 60%. And very slowly, very carefully, the piece is emulsified. And now, what if this technique fails? There are some cases where the submarine chop technique may fail. What to do in those cases? This is a cataract nigra, very hard, and the size of the nucleus is huge. So in this case, what I did, I got a flap with the needle, then used the utata forceps, and now I do the rhexis, which is always large in hard cataracts. Size of the nucleus, size of the rhexis, as I said, is about 5.75 to 6 millimeter. And now, after hydrodissection and aspiration of some superficial lens matter, as I try to do this technique, the submarine chop technique, I find that the phaco needle didn't go deep enough. It is at a superficial level, and this didn't happen. I could not get a crack. So whenever this happens, when the nucleus is rock hard, black cataract nigra, when the submarine chop technique fails, we can do this. Make a deep crater at the center, really deep, about 80 to 90% depth. And then we can go at the edge of this crater, go again, advance a little bit, and we can get a nice crack. And we can get many pieces going through to the edge of this crater. At least 6 pieces have to be obtained, and then we can start emulsifying the pieces. Once we get in this case also the ultrasonic energy is about 85%, flow rate is 45 ml per minute, and vacuum is 450 millimeter of mercury. No financial interest. This is not a high-end machine. This is
a mid-range machine from Oatly. It is Oatly Cataract 3. And now the pieces are tilted and emulsification is started from the apex of the nuclear pieces. And as usual, during emulsification of the last piece, we bring down the vacuum to about 250 and flow rate about 25. And very carefully, we emulsify the last piece. Thank you very much for your attention.
Thank you so much, Dr. Pradeep Mahanta, sir. I would like to ask Dr. Pankaj Rupalia, because this is a cataract capsule meeting, it's not totally about phacoemulsification. Between SICS and phacoemulsification, why is it so important that even for a cataract Niagara, a black cataract, and like specular microscope is not available at all centers, isn't it putting more stress on the endothelium, and you have to repeatedly use high viscoelastics? Would you not prefer to do a SICS in these cases rather than phacoemulsification?
It's going to be the surgeon's choice, number one. If you are comfortable with phaco, because moderately well done phaco is better than beautifully done SICS. That's what the basic concept is. So if you have a good machine, if you're comfortable with this thing, you can go ahead with that. But if you feel cornea is compromised, if you don't have the good machines where you can feel, probably you can harm the eye. I'll definitely, yes, nothing harm in doing SICS or even the ECC IOL if you're not comfortable in these kind of cases. So, yes, ma'am.
No.
So it's better to be safer and not to be sorry. That's all.
Correct.
What is your thoughts? Anybody in the expert panel, have any of you had used a MyLoop? And which is a situation when you think a MyLoop should not be used? I don't have an experience. So again, you have Dr. Arup? Yes.
I did 5-6 cases MyLoop,
Yeah.
but I think it is more suitable where is a cataract hypermature Bunsen cataract.
Yeah.
It is where there is a already fluid cortex in between the capsule and the nucleus. If you want to negotiate where the whole bag, but there is no space in between, you can end up with a zonular problem. So I did 6-7 cases, all the cases in hypermature Brunesen cataract.
In this modern day with the modern machines which you have, anybody can tell me when a wound burn can happen? Anybody in the audience too? Yes, doctor. Can you give the mic to him? Yes.
If you are going on to the foot pedal 3 without, being on the foot pedal 2 for some time in order to aspirate the viscoelastic around the phaco tip, and directly you go to the power setting, and then you might end up in wound burn.
Basically, visco can go and clog the
Phaco tip.
phaco tip, and then it could happen. So it's always important to go in with the infusion, wash off the viscoelastic, and then you go on to foot pedal 2. I might be a little stuck with this new laptop. I'm very sorry.
Let me introduce you. Thank you, Dr. Pradeep, sir, for that beautiful presentation. Now, our next speaker is somebody who again needs no introduction, our Academic and Research Committee Chairman, Dr. Chitra Ramamurthy, the most dynamic person, ARC Chairman we have had. She's a super mom, super professional, super commitment to ARC. All the things that she does, she's an absolute 200% commitment. She has put her heart and soul into organizing this meeting, and she is doing it pan all over the country. And she's contributing so much to the development of ophthalmology overall. We wish her success for all her future endeavors. Dr. Chitra Ramamurthy will be speaking on capsular bag stabilization, different ways. Dr. Chitra, please.
So that's Satyajit for you all. The generosity with which he introduces, that tells what kind of person he is. And thanks so much. Actually, ARC has become like a family for me. I don't know how I would ever be able to relinquish it and move on in my life. And Dr. Pradeep, your talk was amazing. I was a little caught up with my thing, but you are just a class apart in your the kind of videos and the ease with which you do the most complex surgeries. So without ado, I shall going on to telling you about on managing subluxations. Basically, I think that is one of the most challenging parts of the phacoemulsification surgery. Very briefly, a subluxated lens is when the lens is displaced from its normal position but remains in the pupillary area, and it is dislocated when it is completely displaced from the pupillary area anteriorly or posteriorly. Again, it's very important for us to assess the amount of dialysis, whether it's mild, moderate, severe, based on the clock hours, or whichever way you're going to try to define it. That would help us plan as to how you're going to go about your modus operandi. But then again, what you see on the slit lamp may be quite different as to what you would see under the microscope. So you may still not be prepared for the challenge which you're going to face. The other important thing for us to know is whether the zonulopathy is a progressive or a non-progressive entity, which will again guide us. And of course, the experience of the surgeon. And if it is going to be a lensectomy approach, are we going to do a limbal approach? Are we going to do a pars plana? Are we going to put an iris AC IOL, an iris clip, or an SF IOL? Or if you're going to conserve the capsular bag, then it's all about CTRs, iris retractors, capsule retractors, Ahmed ring, or the Sioni string. Essentially, what is most important for us to know is if there is laxity, as you can see in this particular case, and an elastic capsule, there is no counter traction there, and we need to get a round rhexis on the lens surface. So it makes sense that you inject a cohesive viscoelastic, aim for a smaller rhexis, ensure that the anterior chamber doesn't get shallow. Actually, if you after initiating the rhexis, it makes sense to use capsular hooks on the side, which would give that counter traction and would ensure that you complete the rhexis. And always the rhexis should be started away from the area of zonular weakness. All these challenges are obviated if you're on a femtocataract platform, but that doesn't mean that a very grossly subluxated cataract, you can use a femto. Then comes the stabilization of the capsular bag. With an iris hook, you would do an anteroposterior stabilization. With a CTR, a more equatorial support and the buttressing of the entire capsular bag. An Ahmed segment would give that focal area and rather added on a scleral support. Now I'm going to run you through a few videos. Now this is a fairly large area of subluxation, more than 3 clock hours. Capsular hooks are being used. It's a dense cataract and a CTR is going to be placed. I would prefer to go through the side port, nudge the CTR, ensure that the anterior chamber is not shallow, nor would I want a shallowing of the anterior chamber during insertion or during the course of the surgery. Use my second instrument to ensure that the end of the CTR is within the capsule of the bag fornices and it is not in the angle abutting, then the encirclage would not be effective. Now you can see it's a dense cataract. So now I'm going to make a small trench. Of course, Pradeep Mohanta would handle it even more superbly. And I start making my first split, but that is not very effective. It's very important in a subluxated cataract for any degree that you do a good hydrodissection so that the nucleus is mobile, because you should not use any extra stress on the zonules and increase the area of zonular weakness. I go back here and again do my chop and then separate. And in a leathery cataract, it's important that you completely separate those leathery fibers. Now the advantage is you have a CTR there, you have the capsular hooks there giving the equatorial support, and you have the nucleus in the capsular bag, which keeps that very lax posterior capsule well away. So till the nuclear fragments are there, so you might as well make sense to chop it into multiple pieces, ensuring that you're very gentle throughout your maneuvers. And then till then, once you've got all your pieces, then you can go and approach in getting that first piece forward. But as the pieces become less and less, the bag support becomes less because the nuclear content is going to get less. And that is when you really need to bring down your phaco parameters so that because a posterior capsule can easily get trampolining into the phaco probe if you are not careful. This is again another case of a significant subluxation, but a traumatic cataract. So you could be a little more conservative here, not very radical in approach. And much of the nucleus is soft and it's removed. And you go about peeling off the cortex from the area of weakness as the last step. And in this particular case, I'm brave enough to just place a CTR, ensuring that the long arm of the CTR comes to overlie the area of maximum dialysis, and then I place my IOL. This is just a little bit of vitreous which is coming here. I just do a focal vitrectomy, which is coming from the area of weakness. But then this patient has been coming to us for the last 4 or 5 years and has remained stable. Now, this is a scenario from the word go, the capsular bag is looking lax. So I'm not sure there's any weakness. It's a centered looking rhexis. So I believe that maybe I'm over imagining it. So I get my nuclear fragments into the pupillary area and try not to work into the capsular bag itself, as there is a doubt about the stability of the capsular bag. But having said that, there is no other indication because the nuclear fragments are coming forward. If there was a frank dialysis with vitreous, I would have lost the followability of the nucleus fragment. But you can see that the bag is actually very lax, but there is no evidence of zonular weakness. If I were an intelligent person, I could have placed a CTR there. But sometimes you think that CTR will prevent you from removing the cortex in great ease. But actually, once you get used to it, if you just use your tangential pressure, you could get away with it. But here what I'm doing, I keep injecting the viscoelastic, keep deepening the capsular bag, and then going and removing it. But a time comes when I realize that no, that has to stop. And that is when I go in and inject my CTR, which I'm not going to show you, and complete the case. Now, this is a particular, I'm not going to show you this case. This is another case wherein again, a fair amount of dialysis is there. So again, now the action plan is different here. You need to center your rhexis on the lens surface, mind you. And again, good hydro, as I said, multi-quadrant hydro. And then I make incisions and insert the capsule retractors to ensure a good support of the capsular bag. No CTR is going to be placed here. I inject viscoelastic, and the plan of action is a sutured Sioni ring. Now, I would insert the Sioni ring such a manner that the eyelet comes to overlie the area of maximum dialysis. And once that is done, I remove the retractors, inject the IOL, and then this is a very old video of mine. I make a triangular flap and then go ahead and do a railroading procedure and anchor the back. Now, a capsule tension segment is what we need to understand. It is actually a partial ring with a 5 millimeter radius of curvature and holes for iris retractor or for suture fixation. Now, this is a case of a lenticular coloboma. A Hoffman's pocket is being created. Now, this again could be a area of zonular weakness, need not be progressive. So you are allowed to just use a CTR alone. You need to make your rhexis well away from the area of zonular weakness. A gentle hydro. Remember, these are the cases which you could have a fluid misdirection, and it could really make your surgery a huge challenge. But I could have placed a CTR then, but because the cataract was so soft, I let it be. And then after removing the soft nucleus, I go and position my CTR. I would be justified to place my IOL at this point of time and conclude the case. But then the reason why I'm going to place an Ahmed segment here is because I believe that there is an asymmetric rhexis. There could be a bag contracture, and I want a young guy with a centered IOL. If there is the last video, a severe subluxation as this, a microspherophakia, then the action is totally different. Away from phacoemulsification, go ahead and do a SICS. Keep my, place 2 side ports, because the plan of action is to place an iris clip IOL in this particular case, do a gentle anterior vitrectomy. A pilocarpine is not needed here because the pupil is quite small. And then I insert the iris clip lens and position it and go in through the side ports and hook it and thus complete the case. And this is the last tiny video wherein the patient had an initially good surgery elsewhere, came back with diplopia and a displaced intraocular lens. So the only tip here is you just don't remove the IOL and go ahead and do an iris clip IOL, because these are eyes which could have a CTR, and you can't leave a CTR dangling in the pars plana region. So after you remove your IOL, you need to look whether the capsule regment is there. Quite likely there would be a CTR along with it. So I go back in and remove that regment, and along with it, the CTR comes, and I place an iris clip lens and get done with it. This again, a late IOL bag subluxation, which I'm not going to show, wherein a good posterior vitrectomy is done, and the IOL is brought in from the anterior incision, and an iris clip SF IOL is done. So I would like to conclude stating that an 8 to 10 minutes is not enough to discuss managing subluxation.
but I believe it's just a bird's eye view for us to decide how you would do it. Today, after having done all of it, if there is a significant subluxation, believe me, I just go back, place an iris clip lens and get done with it. Unless there has been a trauma to the iris itself, when it would be a glued IOL of choice. Thank you very much.
Thank you for that wonderful presentation, ma'am. I'd like to ask Dr. Arup, for a senior citizen who we are doing a cataract surgery, all the parameters are absolutely all right. And if we opt to put a premium IOL in that patient, do you propagate the idea that using a CTR, even if it was not warranted, would be a safe thing to do, keeping future in mind when the patient becomes 80 years old or 90 years old, when there will be zonular weakness? Is it a good idea to put a CTR now so that the premium IOL remains stable in its place? Hypothetical question.
Some doctors routinely implant CTR in case of toric IOL and the premium IOL, toric multifocal, trifocal IOL. So, see, definitely CTR can reduce the capsular incidence of capsular phimosis little bit. Not that the capsular phimosis happened for a different reason, but it can reduce the contracture of the capsule. Even when if there is any general inherent problem, it will not reduce the general problem. Whereas we have seen a lot of cases that the capsule with the CTR back complex is dislocated in the vitreous. So it will, if there is any generalopathy which is progressive, that capsule CTR will not prevent that generalopathy. So even if you put the CTR, that the back can dislocate it, the lens can dislocate it. But even then, the centration of eye will be better if you put the CTR. Definitely.
We shall now go on to our next speaker, Dr. Sugato Paul. I don't think I have any rights to introduce him when all of you elected him as the chairman scientific committee of OSWB. And I realized what kind of a chairman he was when I had to relate with him in the last 1.5 months. I was just amazed at the kind, I could call him at any time of the day, bother him with the most trivial questions. And he was always there with extreme level of efficiency. I do hope he has a great future with you all, because I believe he's one who has a great future in Indian ophthalmology. He's a consultant at Amri Hospital, Salt Lake City, Kolkata, and he's going to tell us about the most challenging situations in cataract surgery, a white cataract. On to you, Dr. Sugato.
Yeah, thank you, ma'am, for the kind introduction. So I'll be speaking on whitewashing the white cataract. Sorry to start the play. And I am attached to Amulyajyoti, Amri, and Sunetra Eye Care. So white cataract is treacherous sometimes. It looks easy, but can be treacherous. So we have to have definite strategies for managing these situations. And the most important is to how to distinguish between the two types, the intumescent cataract and the Morganian cataract. If you distinguish them, because management strategies are different, and two difficulties we quite often encounter. One is compromised visualization, so staining is important, and other is decompressing. Here you can see my staining is poor, and as you understand, it has extended, and it's very difficult for me to pick out the extension because I was lazy and I stained it improperly. So staining is very, very important. You have to stain the cataract properly, the capsule. And I ended up cutting the capsule with Venus. It's not the end of the world. You can still do phaco in this situation, but again, it becomes an uphill task. You have to be careful whether it's extending posteriorly. You have to be careful whether you are dropping the nucleus. So in the first place, you could have prevented this happening by properly staining the capsule. The cap extension was only because I didn't stain the capsule properly. So the first take-home message is to stain the capsule properly in white cataract. So here you can see the extension there. and I managed to put the lens in the bag. Next thing is decompression of the capsule, which Dr. Satyajit Sinha has said in his talk that in intumations cataract, because there are things, so you have to decompress. This is an old video. I didn't decompress the lenticular fluid, and the moment I started the Rexis, it went off and I got an Argentine flag sign. Again, that is not the end of the world. Depending upon expertise, you can do SICS or you can carry on with your phaco. I decided to carry on with my phaco. And if you are doing phaco, few things which you have to keep in mind is making sure you are noticing the flab motility sign, and you have to get past your ego. At any point, if you feel, no, it's better to convert to SICS, or if required, convert to ECC even. So this was the second point. You have to decompress intumations cataract because of the high interlenticular fluid pressure. So how we decompress? There are several ways of decompressing. What I do is use a needle, and you can see how much fluid is coming out. And the capsule is going down. But at the same time, you will notice there are pockets of fluid here. So you have to be careful. If you are doing Rexis, even after decompressing, the decompression happens in the central part mainly. So if you are doing Rexis and you go over that peripheral, it can extend. So here it was extending, and you have to recognize that if you go further, it can extend. So prevent that. How to prevent that? Go in with visco and put viscoelastic over this extension, not in the center, over the place where it is trying to extend. So that you press that part down, and then with the micro Rexis forceps or Rexis forceps, you pull the Rexis. If you have noticed, pull the Rexis centrally, get hold of the control, and then do the Rexis. So how can we do it better? So what I normally do in this situation, after decompressing the central part, I don't try to go to the periphery. So what you need to do after decompressing the central part, you can do a small Rexis in the center. And that's what I'm going to do, because that part is decompressed. There is no chance of the Rexis running out there. So I'm doing a small Rexis there. And then what I'll do, I'll go and decompress and take out the pockets which are there in the periphery. It takes little bit longer time, but definitely it's a safer, much safer procedure. So you can go it with an hydrocannula and break the pocket of intumations in the periphery. And once you have done that, you are much safe, and you can extend the Rexis to your desired size. Now, while extending the Rexis, either you give cut with a venous scissor or with a needle, but remember, give a cut obliquely. Otherwise, there might be a tendency of running out. If you give an oblique cut like I have done here, it will be much easier to get hold of the Rexis, and you can increase it accordingly. Now coming to Morgagnian cataract. Morgagnian cataracts are a different ballgame. They're slightly easier to manage. There, the intumations is not there. Only thing is the fluid coming up after the nick. Here you can see with the keratome, I have nicked the capsule and the fluid is coming out. You can wash the fluid, or you can put little bit of visco to move the fluid away from the part of you want to see, and then carry on with the Rexis. So here I have injected little more of visco to move the milky fluid out, and then I am carrying ahead with the Rexis. And this is another video. Again, I am nicking the capsule to release the milky fluid, and then you go ahead and do the Rexis. And regarding the nucleus management, mostly nucleus in this white cataracts are brittle. They're quite easy to manage, apart from some special situations like rock hard cataracts under white fluid, which Dr. Mahanto has shown so beautifully how to tackle those. But otherwise, normally in white cataract, the nucleus is quite brittle and is easily manageable. So you can do the procedure which you are comfortable with, divide and conquer or chop. I normally do a vertical chopping, and you have to ensure complete separation of the nucleus. Otherwise, if the beads are attached at the posterior plate, again, it becomes slightly difficult to manage at the end. So you have to ensure complete separation. At the same time, you have to be careful that you are not putting too much of stress on the zonule while you are separating it laterally. Once you have done the separation, other thing to remember, there is no posterior epicortex support. So you have to be careful that the sharp tip is not damaging the posterior capsule or not tearing the posterior capsule. This is another thing which you have to remember. And in special situations when there are capsular fibrosis, which Dr. Satyajit Sinha has shown so beautifully, here I missed this fibrous part. So I started after taking the fluid out, I started for a small rhexis, and you can see I'm stuck here and it's not going through. So in this situation, you can use Vannas scissor to cut the thing, or you can do it from a different side. So what I did in this situation, just extended the tear superiorly, trying to go around the fibrosis there. Or I could have started from here again afresh, but I thought I'll start from there. And you can see the fibrous area, and I was trying to go around it and manage this successfully. So in fibrous capsule also, you have to be prepared that you might have to cut the capsule with Vannas scissor and go ahead and doing the phaco. But here I managed to do the small rhexis around the fibrosis, and then later on I extend the rhexis. So take home message, use good OVD, decompress the capsule, stain the capsule, and get over your ego to convert, be ready to convert when required. Thank you so much for your patience here.
Thank you very much for very elegant execution of surgeries. There's going to be just a tiny change. I'm very sorry. Dr. Srinivas Joshi would be going on the Zoom link at the next presentation, and then we would go on a line. I'm very sorry. Could you connect Dr. Srinivas? And before Dr. Srinivas starts off, one question for the expert panel. Can you tell me one sure technique, any one of you on the expert panel, one sure technique where you will get 100% chances of getting a good rhexis in these intermittent cataracts? Can anybody tell? Yes.
What I do is, I usually use the side port for the rhexis.
Yeah.
If I am comfortable with the rhexis and the rhexis is complete, I go on with phaco. Otherwise, if there is adjunct flex and all that, I convert this ICS.
No, yes. Femto, of course, I don't want Femto answer.
Yeah.
I would have asked Ajay Paul, no.
Yeah, that's one. See,
No.
it's beautifully covered. Only one thing what I am trying, I have done in 7-8 cases. I just did most of the time I forget actually. I just did one small yak laser just to have a puncture in the entire capsule. And after 1.5 hours, 2 hours, morning before entering the OT, and that becomes like AC becomes a little bit messy, white and all that thing. But as of now, 7-8 cases, it did not give me any surprise.
I just heard one very good presentation in one of my ARC webinars that one of the doctors said that he makes a small nick and a C, brings it down, and that once that curvature starts off, he claims that he doesn't get it. He showed us different challenging cases. It made me wonder. Or I think if the rhexis is likely to run off, does it make sense to, I'm just asking a theoretical question, does it make sense to do multiple nicks which would hold on the rhexis extension, or it would split in multiple ways? I'm asking you. No, I want a secret.
Madam, the most problem in the inflammation cataract, not
Yeah.
the Morgan-Gingney cataract.
no,
If you have to drain the one puncture in the Morgan-Gingney, the whole liquid will
Yes.
come out.
Yeah,
But even in the intermittent cataract, there is a localized pocket of fluid.
yes.
So it is very difficult to assess where actually you have to puncture.
Yeah.
So it will not solve to be multiple puncture. I think that the
Inverted
C
makes sense.
technique or Dr. Rajendra Prasad has shown as the needle, the tip of
Cruciate.
the needle is as Shugoto shows, there is a needle which has a edge. It can create a 1-2 edge and it can extend from the edge.
Yes.
So that needle can a needle type that can puncture and create a flap. So that chance, even then the technique of Shugoto is very good. You put little bit of vacuum when you just enter. Then it create little bit of fluid, and once the some amount of fluid will decompose, then it is much easier to break the bridges of the localized pocket of the water.
Thank you. Can you connect us to Zoom link to?
Just another hypothetical question. With a high bottle height, AC maintainer, if you're anticipating that there will be an Argentinian flag, will a AC maintainer equalize the lenticular pressure and prevent an Argentinian flag? Will not come. Visco will be, high molecular viscoelastic will be there, but I was just asking question.
Yes. So we shall now go on to our next speaker, Dr. Srinivas Joshi, who is visible there. He's the member ARC South for all of you, but to me, he's one dynamic young surgeon who could operate in any extremes of situation. A great, one of the directors of the Joshi Group of Hospital, and I truly believe he belongs to the future of Indian ophthalmology. On to you, Srinivas. You better live up to all that I have said.
Thank you. Thank you so much, madam, for that kind introduction. And I agree with what Dr. Satyajit said. She is so passionate and compassionate about, though father is not feeling well, but Chitra madam is here with you all in Kolkata. I think that really shows her passion for the ARC that she has been doing. So thank you very much, madam. And thank you, Dr. Satyajit Bhai. And thank you, Dr. Sugato Paul, for this wonderful opportunity. I'm really sorry I had to come there personally. But because of I'm recovering from the bad sore throat and fever, that I couldn't be with you all, my humble apologies. So I'll be speaking on do's and don'ts in sutureless IOLs. It's not a glued, but it's a sutureless IOLs. So this is the memory which brings back to me. I was there in Kolkata and IIM Joka for nearly 7 to 8 days, just 2 weeks back. So I really missed coming to Kolkata this time. And we had a wonderful time, and we had spent a long time with all our friends and colleagues in Kolkata, with the IIM colleagues there. So I have very sweet memories with Kolkata, and I'll definitely be there for the next further meetings. So I'll be quickly showing the set of videos. It is 8.5 minutes. So this was the case where you can see there is the bag with the lens has fallen down. So how to handle in such situations? Nothing but just removing it completely out. And then you can go ahead with the sutureless SFIOL. So I'll be describing about various kinds of the sutureless SFIOLs. This is how I initially used to do it, but now I'm started doing it with 25 gauge or 27 gauge strokers. So this is a 23 gauge stroker where I'm using a 26 gauge needle to make a pocket, that is a scleral tunnel. And then you can just insert a 3-piece lens inside and then externalize it and just tuck it under the scleral tunnel. So this is either you can suture it or you can just glue it. Either of the one you can do it. If you have the glue available, then you can definitely do it. But all care has to be taken while externalizing, because these tips are very, very fragile. And I have found that the Sansar 3-piece are really little better as compared to the Alcon 3-piece. They are slightly more flexible. So this is the another case where you have a decentered IOL. So you can see there is a CTR along with that. And in these cases, it's always better just to remove the CTR. And instead of removing that lens, I just thought that let me go ahead and try to externalize the same 3-piece lens. Now you can see I'm just externalizing it. And again, I'm using the ILM forceps. And then once you externalize it, and again, as I showed in the previous video, you can make a small tunnel. And it's always better to make tunnel with as little gauge as possible, the needle size. If 27 or 28 is available, then I think that's much, much better because the slippage won't happen. And after this, you can see we just glued it and then we close the flap. Now, these are the another set of videos where you have this traumatic cataract. And definitely in these cases, as you people do phaco in the anterior segment, and vitreoretinal surgeons, we love to do phaco in the posterior segment. So this is the Yamane's technique. I'm using a thin board 30 gauge needle. And after putting the 3-piece IOL, I'm just docking it. in the 30 gauge needles is very, very important because the longer the gauge, again, you are creating the larger track size. So there are chances that it might slip back. So the smaller gauge of the needle is always better when you are doing sutureless SFIOLs, especially when you are externalizing these and tucking it under the sclera. Now you can see here, I'm just using a Bowie cautery and just doing a flange. Doing a good flange is very, very important. Now you can see the stability of the lens, and you can just cover the conjunctiva. You can tuck it under the sclera and cover the conjunctiva. So this is another technique where I use phyoprolene. It's the called as the dumbbell technique described by Sergio Canabrava. Now you can see here, I'm again using a 30 gauge needle. And since the trab site was there superiorly, so I use the temporal site. And now you can see here, I'm just externalizing the proline suture out of that scleral tunnel. And again, on the other side, I'm just putting that 30 gauge needle. I'm again externalizing that phyoprolene. So once you externalize it out of the scleral tunnel, just put it inside the eyelet of the SFIOL and just flange it. Once you flange it, make sure that you check it, because sometimes if it comes out of the eyelet, then the whole procedure will have to be repeated again. So after checking it thoroughly, just put it in, insert it inside, pull both the sides, centralize it, and then flange it externally. So now you can see we have just flanged both the sides. So this is another video where you can see there is a dangling IOL. So it was a SF suture was done long back, 10 years back. And unfortunately, one piece had, one side had fallen down. So instead of removing the whole lens in toto, we thought let's suture that dangling part itself. So here you can see I have put one suture inside, and in the vitreous cavity using sorry, using a bimanual technique, using the chandelier light, I just threaded it through that eyelet. And once you thread it, then externalize it through another port, and then just tie it under the flap. So now you can see this was a very simple procedure and technique, and it got finished just in 10 minutes. So this is another case of dangling SFIOL, where you can see another part, the one part of the SFIOL has fallen down. So here I'm doing a Sergio Canabrava modified technique, where you can see here I'm just externalizing that phyoprolene and try to bead it inside in the vitreous cavity and take it out. You have to be really gentle, and once you bring it out, then you can flange it externally, and then internally I'm just checking it if it comes out of the eyelet or no. And once you check it and you know the stability of it, then you bring back the other end of that proline suture and just do a cautery, make a flange. And here you can see it's sitting nicely and it's quite stable and centered. So this is another case of subluxated SFIOL, where you can see here the suture eyelet was still there. I just tried to remove that suture. And 2 mm long needle track is made with a 26 gauge needle, around 1.5 to 2 mm away from the limbus. And now you can see I'm just using this phyoprolene and try to dock it in that 26 gauge needle. So this 6-proline suture is passed inside the lumen of this 26 gauge needle. And the other part you can see here is just brought up into the vitreous cavity. And then it's a kind of, again, as you thread the suture, thread in the needle, how we do it, similar way, threading it in the SFIOL and bringing it outside. And you can just try to flange it. And once you make the centration properly and cut it adequately and flange the other end. So this is a post-op day 1. So a well-centered. And this is my last video showing anaerobic SFIOL. It's just a 30-second video. Similar way, I'm just trying to flange it on both sides using the dumbbell technique. And once you insert one end, I bring out the other end. So cut it. And now you can see here, instead of flanging it and putting it back into the suture, I think it's now, I feel it better to make it under the flap, even though, so that there will be no conjunctival erosion. Even if the flange is exposed outside, there'll not be a conjunctival erosion. So making it under the flap, either you can glue it or suture it, or you can just leave it. Either of the way, I think that holds very good. Thank you very much for the patient listening. Thank you, everyone.
Thank you,
for the
Srinivas.
nice-
We have a full audience and very amazing videos you have shown. Just stay
Thank you.
connected. I would ask our next speaker to get connected, Dr. Surojit. You could get connected. One question to you, Srinivas, because you're mostly posterior segment surgeries. One basic tip to how to ensure that the IOLs are centered. Can you hear?
Yes, madam.
Yeah.
It's very feeble, but
Could you ensure that, yes, Srinivas?
yes,
Very
madam.
basic tip for the anterior segment surgeon. How do you ensure that your IOL is centered? What are the steps which you take to see that your IOL is well centered?
Very good question. See, ideally, when you're doing this sutureless SFIOLs or with the suture, I think 4-point fixation is very a good technique. This what I have shown in the SFIOLs they're all 2-point fixation techniques. I think 4-point fixation, the stability of the lens will be much higher, and you're sure that there will not be any tilt of the lens. The tilting will most commonly be there either if we take at less than 1.5 mm, or if we go more deeper. Then there'll definitely, if you go like 3 mm, I have seen some surgeons doing it. Definitely, I've seen a significant amount of tilt happening. So the best I would consider is doing a Gore-Tex kind of SFIOLs, because you can have a 2 sutures on the left side and the right side, and you have a very stable SFIOL without any tilt or anything.
I think also making diametrically opposite side
Yeah,
port.
of course, that
entry
has to be
points.
done diametrically. That's why I use this Mendes marker,
Yes.
so that you don't lose that diagonally out. Making diagonally opposite, taking a equidistant. If you take 1.5 mm, please use the caliper. I know we are all, many of you all are experienced surgeons, but to avoid these kind of tilts, having the equidistant, using the calipers, both the sides from 1.5, exactly opposite end, that kind of reduces the angulation or the tilting of these SFIOLs.
Thank you, Srinivas.
Thank you,
We
madam.
shall now go on to our next speaker, Dr. Surojit Chakraborty, who is a consultant from Priyamvada Birla Arvind Eye Hospital, Calcutta. And he is one person in this crowd who can talk in Tamil besides Bengali too. So that was a change for me. So he is going to talk to us about posterior polar cataracts and the challenges here. On to you. And we would be very particular about time because we've really gone off. Yes.
Thank you, ma'am. And thanks to the whole team of ARC for inviting me on this podium. And coming to the topic, posterior polar cataract. First of all, let us think why this particular topic is so important to us. Why does it take a special mention? Because it worries us. And what are the worries? Like if there is a pre-existing posterior capsular dehiscence, there is a chance of nucleus drop. So these are the real things which worries us, and we so far we did not have much of an option to understand which cataract is going to create problem and which is not, till we have the imaging techniques. And with the help of ASOCT or UBM, it is I mean, things are getting clearer. What are the PPCs which are really attached to the posterior capsule, which will give you trouble, and which are not really attached to the posterior capsule, which are relatively safe. But as we, as a routine, do not do imaging in all the cases. We follow some simple techniques which keeps us safe. So going to that. those techniques and those usual conventional methods. Let us, yeah.
Screen has gone.
Yeah, it is there. Let us start a video to see how we tackle those cases. Let us look at a normal posterior polar cataract with the usual incision size and everything. Regarding doing capsulorhexis, we should be vigilant that the size is maintained, as we had a discussion in the morning, that the size is important in the it's important because, and so that we can do a capsule optic capture if required, and no dissection, only hydrodelineation is done with the golden ring. And every time we come out from the anterior chamber, we need to replace it with visco so that minimum fluctuation occurs in the depth of the anterior chamber and minimum fluttering occurs with the posterior capsule. Because in what kind of, whatever cataract you are dealing with, be it type 1, type 2, type 3 posterior polar cataracts, the central part of the posterior capsule is always thin. So next important key for removal of this, even the softer epinucleus, is to stay safe, do a slow motion phaco, never be too enthusiastic to remove that innocent looking posterior epinuclear plate and all that, because the moment there is some fluctuation, the thin central posterior capsule will give away and you'll end up in trouble. So just stay safe, be gentle in doing all the steps to minimize the anterior chamber fluctuation and fluttering of the posterior capsule. Even during doing a cortical wash also, we need to be very careful while removing this. Again, just to minimize the anterior chamber fluctuation, and everything else will fall in place. Please remember that even after placing the intraocular lens, please don't feel safe, because I have seen somebody doing posterior polar cataract, and after doing the lens placement, the moment she went for a PC polish, just the visco removal got into trouble. So the things drastically changes when it comes to a nuclear cataract coexisting with a posterior polar cataract. You cannot get a golden ring as in soft cataract because nucleus is hard, and for this case is NS3 to 4. Here, if you try to rotate, that will put enough stress on the posterior capsule. So no rotation phaco is the key for this kind of cases. You need to really somehow take a pie out without rotation or with minimal rotation, whatever is required, at least to do that. Take all your time, there is no hurry, because again, anterior chamber fluctuation is the problem. So we are doing a multi-layer chop, multi-level chop here, just to take one pie out. And then what will happen, because the rest of the nucleus will not rotate. So we'll just complete the central separation here by separating the two pieces, and we'll turn the phaco tip with the bevel on the side of the remaining nucleus, just to occlude it, and with full vacuum pull the nucleus out of the bag and have it there. So no rotation, because this kind of PPCs are very tricky. The moment you try to rotate, it will fall off. So this is the other technique, and these are the usual things. So if we make a list, what we should be careful about: an adequate size rhexis to facilitate optic capture in case there is a PCR. No hydrodissection, only hydrodelineations is the key. Avoid chamber fluctuation in all possible ways, refilling anterior chamber with visco before coming out every time you come out of the anterior chamber. Slow motion phaco and gentle aspirations are important. Visco dissection of epinucleus may be helpful. A layered approach of cataract removal, just to keep the posterior plate as late as possible, so that even if there is a pre-existing dehiscence, even if there is a thinning, least stress is put on the posterior, on the weakest part of the posterior capsule. And no rotation phaco for nucleus sclerosis. And please avoid hitting the thinned out posterior capsule with leading haptic also while IOL implantation. Avoid PC polish. Thank you so much.
Thank you very much. Thank you very much. While Dr. Love connects his laptop, one question for the expert panel, Dr. Sandeep Mitra and or Dr. Debashish, both of you could answer. How would your technique differ in a posterior polar cataract based on the presence of the nuclear component of the polar cataract, or if there is no nuclear component, that is minimal?
That has been clearly shown in this video.
Yes.
Because if we can do hydrodelineation, the situation is something. And if we can't see the fluid wave, or we cannot, do hydrodelineation is not possible, then we do manual separation with spatula in all quadrants as far as possible. Then small hydrodissection at multiple areas, taking care that the fluid wave does not go towards the back. And the option is there, you start doing the chopping and take out small pies as much as possible. Then you angle your bevel towards the shelf of the remaining nucleus and try to take it out, and just do it lightly and slowly. Go one by one, you try to take small pieces out. That is for a dense nuclear cataract. And for a softer cataract in younger patient, the scene is much more easier.
Yes, Dr. Debashish, anything different you have to add?
Nothing much, almost all the same. Maybe for a nuclear cataract, which is a larger upside, you can make it about 5.5. And if it is vision, it's a soft cataract, you will keep the rexus a little bit smaller.
Dr. Arup, would you ever consider doing hydro at all in a posterior polar cataract? It's a total no-no to my thought. I did hear one of your Calcutta
So,
surgeons saying
we
that.
should
so-
follow the standard dictum, no hydrodissection, the hydrodelamination.
negotiation.
Now, the technique depends on the two part. You have to remove the nucleus and you have to remove the epinucleus.
Yes,
If your lens is soft,
yes,
then the most trouble in the epinucleus part, not the nucleus part.
yes.
And when the cataract is hard, most trouble in the cataract part, not the epinucleus. So you have to be very careful, and there should be the chopping force, stretching force in the back. So if the nucleus is hard, the best technique is a femtocataract surgery.
Yes.
If it is not available, it is better to debulk of the nucleus as much as possible, so that you need a very little force to divide the nucleus.
Yes. Thank you very much. We shall now go on to our very popular Dr. Love Kuchave, who's a senior consultant and director of Netralayam. I've already introduced him, and he is going to tell us on something all of us need to know with full attention: anterior vitrectomy during cataract surgery. He's going to take us through different case scenarios and tell us how to be careful.
Thank you, ma'am. And I think with that we mean the most important fear what we have in cataract surgery, which is posterior capsular tear. So just to start with, as we all know that posterior capsule is much thinner than compared to the anterior capsule, and that is why we have to preserve it most. And how do we see that the tears what we face is, one is already covered just now, which is the pre-existing, which is in adult cataracts, it is posterior polar cataract or a traumatic cataract, and in pediatrics, it is the posterior lenticonus. Spontaneously during hydro procedure, if we have a large nucleus and a small rexus and we do a hydro procedure, if the PC is weak, it will just tear apart, and intrasurgical during nucleus removal, cortical aspiration or IOL insertion, we can face it. Risks, as we all know, the corneal edema, hyphema can be due to the increased manipulation what we have during these surgeries. Cystoid retinal complications can have a cystoid macular edema or retinal detachment, AC reactions, especially if you have left some cortical matters behind, and a decentered IOL. So let's come to how we identify and some of the important points. And in this, what you will notice is that it is brunescent cataract and the rexis size is small. And why I erred and why I didn't enlarge the rexis, because I was quite aware that this is a small rexis for this kind of cataract, but this was a combined surgery with a VR surgeon. So I got more complacent that anyway, VR surgeon is there. So let us try like this. And this is what I ended with. So what you have when you see a small rexis with such a hard nucleus, there is problem in rotation. It moves towards one side. And once we initiated the chop, what you see here is that the posterior plate is still intact. And one of the tricks is small thing, but what you see, the lateral separation was large and that gave way and the posterior capsule gave way. And after this, the lens started behaving abnormally. The rebound is lost, it got decentered. And this is a point, I'll just hold it. This is a point, it is in a no man's land. I know that I have lost it. So I have to keep waiting till it falls back. If you call a VR surgeon at this stage, he will tell it is not in my area, I will not do now. So best is just keep trying. And if you want to shorten your own torture in managing this case, just push it back. So, but still I kept trying and the nucleus has actually started, it's not rotating at all. So at this point, I tried what I should have done at the first stage itself. I tried enlarging the posterior anterior capsular rexis. And this would have prevented the zonular, PC tear if I had done in the first stage itself. But by that time, it was a bit too late. And finally, to end to my misery, the nucleus has gone down. So this is one stage when we have. Second is during cortical aspiration. And in this, advantage is that you can identify it almost instantaneously. And if in this case, as you see, the AC was unstable and there was a problem in the main incision. That is why the iris is coming out. And at that point, one of the instruments hit the posterior capsule and we have a PC tear here. And highest incidence is when you have the last nuclear piece, and that time there are chances that during the turbulence of the AC, the phaco probe may hit the posterior capsule and lead to a PC tear. And this is what happened in this. You have a posterior capsular tear here. So the mistake, what you see, I just came out with the handpiece. It should have been first stabilized with the viscoelastic and then I should have come out. So how do we manage it? First and foremost is to avoid nucleus drop. And most of the times we are able to do that. Then avoid damage to the endothelium so that the healing is faster, prevent the enlargement of the PC tear, preserve the anterior capsular rexis, removal of all the cortical matter because post-op inflammation will be less in that case, and maintaining wound size with a well-centered IOL. So management strategies is depends on the extent of the posterior capsular tear and the status of the anterior hyaloid face, whether the vitreous has come to the anterior chamber or not, location of the nucleus, comfort with anterior vitrectomy, and availability of VR surgeon, which is most important. So early nucleus management after PC rent, what you see here, this is a continuation of the video I had shown in which the PC tear happened in the last segment. And at this stage, first a visco tamponade is done, plugging of the, and preferably with, here I'm doing with viscoelastic, but it is always preferable to do it with a chondroitin sulfate. And then if the vitreous has still not prolapsed, then we can try phacoemulsification. And for that, AC turbulence has to be minimized. So what you see here is first I'm doing this, but there was AC turbulence. So I switched to viscoelastic from the side port. So while handling the nucleus, I'm just pushing viscoelastic so that till the nucleus is out, we could preserve the, we could avoid the vitreous in the anterior chamber. And then finally, the last piece comes out. So this is one of the favorable outcomes when you have a PC tear during the last piece when it has been removed. Vitrectomy, again, the debate is whether we do it with a pars plana route or a limbal route. Definitely a pars plana route will be better, but as most of us are anterior segment surgeons and we don't want to prolong surgery, we end up doing vitrectomy with the limbal route. And better is to prevent hydration of the vitreous and do through the posterior, the PC rent itself. And using the cutter itself, many times we can aspirate the remaining cortical fibers. And end point, either we use triamcinolone, or if we have many times without using also, we can conclude that it is the vitreous has come out from the antechamber. And always put a 3-piece IOL in the sulcus. If it is a small rent, we can even put in the bag. Whether to convert to ECC or refer to a VR surgeon, if it is a small piece, conversion may not be required. Low parameters, chondroitin sulfate helps. IOL scaffold is one thing what we can try. If you have a PC rent, just put a IOL in the sulcus and then eat the remaining pieces. IOL, last slide. IOL placement, it is a 3-piece IOL in the sulcus, single piece IOL in the bag in case small PCR without vitreous loss, and clear the vitreous from AC while doing the IOL placement. Thank you so much.
Thank you very much. While Dr. Ayan Mohanta connects, I want one question with Dr. Love itself. Supposing it's a case of a small zonular dialysis, what are the parameters and there's a little vitreous presenting there on the table. So how would you set your phaco parameters?
Just lower down the vacuum and aspiration flow rate. And what I do, if the vitreous has come through the zonules, first tackle the vitreous. First tackle the vitreous and put a CTR and then go ahead.
You will go into full cut rate and then lower the vacuum and the flow rate and you will do the cutting.
Yes.
Can you tell the audience if you have a machine has a facility of cut IA and IA cut, what it means and how you use it?
See, if there is a vitreous prolapse, it is always better to use a cut IA because once you have, that is mainly to prevent traction on the retina. It cuts the vitreous and then aspirates.
Yeah, I would also go further and say that when you're doing cut IA, you would first do vitrectomy and then you can press further down on the foot pedal and then you're able to even in the same sitting remove the cortex. If you feel there is no vitreous, you are doing just an aspiration, that is you are doing IA. And then while you're doing IA, you feel there's a little vitreous, then you can go further down on your foot pedal and then you can do vitrectomy in the same sitting instead of removing each time your instruments doing vitrectomy with one and then doing IA and then going back, because multiple times we are required to go and do vitrectomy even when we have thought we have cleared it. And I think triamcinolone should be used even for the smallest of vitreous loss without fail. Our surgeries would have brilliant end outcome. Thank you very much, Dr. Love, for wonderful videos. We go on to Dr. Ayan Mohanto, who's again a senior consultant from Disha Eye Hospitals and Research Centers and has been another major asset in all our ARC webinars. And he is going to be telling us on a complex topic, managing iris and cataract surgery. On to you, Doctor.
Thank you, ma'am.
This would be followed by just a brief lighting of the lamp, just a very small token for coming here and being amidst you all. We have to celebrate this ARC moment. And for that, I would be inviting Dr. Rajesh Sinha, Dr. Shekhar, who's the president OSWB, Dr. Kajal, who's the past president, Dr. Paris, who's the past president, Dr. Subhashish Nag, and Dr. Ratish Chandrapal, and of course, Dr. Sugato too, to just briefly do that token inauguration of the lighting of the lamp. On to you. After you.
Good morning, all of you. Thanks, Chitra ma'am, for giving me this opportunity. over the next few minutes, I'll be
Parag.
talking on managing iris in cataract surgery.
Dr. Parag, yeah.
So I'll be covering mainly two topics. One is the LIDRS and the iris repair different techniques. So what is LIDRS? It's lens iris diaphragm retropulsion syndrome. Usually while operating a myopic patient, when we introduce a phaco probe, the chamber suddenly depends, causing a considerable amount of pain to the patient due to the extreme stretching. So how this can be managed? You just take an instrument, go to the opposite end, and just lift the iris up so that the pressure difference between the anterior and posterior chamber gets balanced, and the chamber becomes more stable and less deep. So this is the mechanism when you are entering with a phaco probe and your fluid is gushing out and is pressing the iris downwards, leading to a deepening of the anterior chamber. And if you are using another instrument to lift the iris up, then the fluid comes below the iris plane and the pressure difference equalizes. So while I'm operating in a Centurion machine, though I have no financial interest to disclose, so if we are using a very low IOP, see, this deepening doesn't happen at all, as if we're operating on a normal patient. And there's no deepening. There's hardly any deepening. So then I'll come to pupillary sphincter tear repair, and the technique is 4-throw pupilloplasty. So when you are operating such a patient, at first, better not to dilate the patient, take it in your table and see if the extent of the repair you have to do. Over here, there is a tear. So I'll be repairing this area only with the help of 4-throw pupilloplasty. So now after assessment, you put some Phenocan Plus in, the pupil starts to dilate. You complete your phaco, fill the antechamber with a cohesive viscoelastic. Take a long needle, 16mm needle with a 9 Prolene suture. And a microforceps on the left hand. Channelize the needle through a 26 gauge needle. And then take it out. Then you take out this loop out through the wound, main wound. And this end, pass this suture 4 times through that loop. And then you take both the ends. And then pull it in order to complete the knot. Then you trim the ends with the help of a micro scissors. Now coming to a pupillary circlage. This was a patient I operated some time back, and with the help of iris hooks, there was a lot of stretching and the pupil was widely dilated with a lot of synechia. So I started off doing the synechialysis first. I could have done a 4-throw pupilloplasty on both sides, but the iris seemed to be very friable. So I decided to do a circlage instead. The iris tissue was very friable and the patient was complaining of extreme glare and halo. So I had to do something. And 4-throw pupilloplasty was not the choice. So I started off. And at this point of time, you have to be very careful not to engage the corneal stromal fibers. And if you do so, the whole endeavor will be lost. You have to redo it again. So you have to go in through multiple points and then come out at least in 3 areas in order to cover the whole pupil. So this was my second area. The needle was passed through the pupillary margin once, then twice, and then thrice. Come out through another opening, the third opening, and then again from the third opening, we have to engage the pupillary margin and then come out to the first opening. And then the suture ends were trimmed, brought in, and they were tied. Though the pupil didn't look good, look like flower petal, but the patient's symptoms were alleviated. Now I'll come to the third thing, that is the iridodialysis repair. Again, you have to note down the extent of the iridodialysis that's present over here. And take another, do the phaco. After doing the routine phaco, before doing the routine phaco, you put iris hooks at the dialysis area. Otherwise, this iris is going to interfere and come to the phaco tip, and it might get damaged. So after completion of the phaco, take out the hooks, note the extent of the dialysis. And sometimes the iris tends to roll at this at the root. So you have to stretch it, then do a localized peritomy over there at 1.5 millimeter from the limbus, place marks. Then do a partial thickness scleral groove, bend a 26 gauge needle beforehand, do a paracentesis on the exactly opposite end, pass a 16 millimeter long needle with a Prolene suture. You can either use a curved or a straight, and then use the 26 gauge needle to pass through the root of the iris. And then this needle is again put inside the 26 gauge needle and then is brought out. Sometimes this sort of backlash is there, but don't worry, might cause some iris bleeding, but nothing more than that. Again, repetition of the same thing. Take the 26 gauge needle in, go through the iris root, put the needle through the 26 gauge. Then it's brought out. The more you put the needle in, the less are the chances of that whiplash kind of a thing. And then this, the ends are tied. Sutures are trimmed. And then the conjunctiva is cauterized. And each of the pupil was pulled in towards the center. And it's fairly acceptable. Thank you.
Thank you. Thank you very much. While I request all the respected elite members to come for lighting of the lamp, one question to you, Dr. Ainmata. If there is a case where there is both traumatic mydriasis and iridodialysis, which would you attend first? And
in case
if
of,
there's an iridodialysis also.
I'll do the
and there's a
repair of the dialysis first, because
dialysis.
otherwise, yeah, it's not stable from the base. Then you
Hmm.
won't be able to actually finalize the size of the pupil.
Yes, thank you. Thank you.
Dr. Rajesh Singh, please, Dr. Shri, Shekhar Da, Parag Da, Kajol Da, Dr. Satyajit Sinha is here, Dr. Subhashish Na, Subhashish Da, Rotish Da, Dr. Rotish Pal, Arvind is here. Rotish Da, Subhashish Da,
Thank you very much. We should have taken a photograph of the last session. We shall. Yes, I know. There's no tea break. I would want all of you to be seated and we shall now start with the next session, which is again a very interesting session. I invite expert panel, Dr. Mohammed Yasin, who heads the Mohammed Yasin Eye Clinic at Kolkata, Dr. Ajay Paul, who is the director of BPI Foundations, Calcutta, to take the place on the center stage for the expert panel. Dr. Anshuman Goswami, who is a senior consultant cornea and external diseases from Ambri Hospitals. Dr. Kushal Chaudhary, who is a senior consultant, Ambri Medical Center in Southern Avenue, Calcutta. And Dr. Pankaj, again, who is senior consultant from Rotary, Narayan Netralaya, Kolkata. I would want all of you to be seated at the expert panel. And I invite Dr. Sneha J. join us here, who's a senior resident Vitreoretina Services at Regional Institute of Ophthalmology. That I'm wrong. Huh? Senior resident from a hospital at Calcutta, and Dr. Satyajit Sinha would be co-moderating with me. We shall go on to our first speaker, Dr. Rudra Ghosh, Prasad Ghosh, who's a senior consultant from Fortis Hospitals, Anandpur, Kolkata, who's going to talk to us all something very basic and essential which each of us need to know, role of immersion biometry in today's world. I would want all of you to be seated. The teas will be brought inside. I would want the next speaker, Dr. Saurabh Sanyal, to also keep his laptop connected. We are running quite late and I'm sure all of us want a Sunday evening back home. So please, the next following speaker should have connected the laptops. We would keep the questions also brief. On to you, Doctor.
Good morning, Chairman, sir, esteemed panels, and dear friends, seniors and juniors. Today, after a very interesting video topics, I have come to some basic things with theoretical discussion, the role of immersion biometry in today's world. I have no financial disclosures and no conflict of interest related to this presentation. So achieving an optimal refractive outcome, we now have two things. One is removal of the media opacity, that's included in all in this surgery. And another thing is the analytics and the calculations, which addresses the refractive components. Addressing the refractive components can again be divided into correcting the refractive spherical errors and the astigmatic errors, where the spherical errors can be corrected by proper calculations, by IOL calculations, and astigmatic error by LRIs and toric IOLs and other methods. That will give rise to a desired refractive outcome. Now, three components of IOL power calculation. Number one is the axial length measurement, which is biometry. Number two is the corneal power measurement, it's keratometry, and next is the formula. Now, some basics. In the two different methods, in ultrasound and optical, the distance from the anterior corneal surface is measured from ILM in ultrasound, and in optical is from the RPE. And contact biometry has some issues like corneal compression issues. And if you compare with the contact method, immersion is more accurate. In ophthalmic ultrasound, we use 7.5, 8, and 10 megahertz, whereas in abdominal ultrasound, 2.5 to 3.5 megahertz. What's interpretation? That more frequency, better is the resolution and less depth of penetration. Now, A-scan biometry sonogram, there are the peaks that represents the different interfaces. We can see the peaks comes from the cornea, anterior lens capsule, posterior lens capsule, retina, sclera, and orbital fat. Some physics, distance equal to velocity into time by 2. Through cornea and crystalline lens, it around 1.6 kilometer per second, and in aqueous and vitreous is 1.5. Whereas through PMMA and acrylic lens is 2.7 and 2.1 kilometer per second. And through silicon oil, it goes 980 meter per second. Now, contact biometry, ultrasound probe directly placed on the corneal surface where we can't avoid a compression issue. It's around 0.14 millimeter to 0.28 millimeter, resulting in an error of 0.25 to 0.75 diopter. Now, the benefits of immersion A-scan biometry, it's more accurate compared to contact method. It determines axial length within 0.12 millimeter, and probe does not touch the cornea, and it avoids problems associated with the contact methods. These are the, in briefly, I will tell you about the immersion technique. A machine is used along with an ultrasound probe and a shell with a sterile tubing. Patient looks straight forward. The shell is advanced onto the sclera and eyelids released. Patient is asked to bring hand up to cover the other eye and to look directly to the red light. Fluid is released into the shell until the probe tip is fully immersed. Remove shell from the eye and proceed to measure the other eye. Now the spikes, see, look at the spikes. Tall spikes come from the cornea, anterior and posterior lens, and retina. No spikes from aqueous and vitreous. And some important points are retinal spike should be perpendicular without any staircasing at the origin. There must be a separate retinal and scleral spike and separate spikes from the anterior and posterior corneal surface. Now, spikes from the anterior and posterior lens surface should be of equal height. Medium intensity orbital spike should be present, absence indicating that the beam is hitting the optic nerve. Gain should be as minimum as possible. Higher the gain, weaker echo is visible and resolution decreases. Gain should be lower till the retinal and scleral spikes and anterior and posterior corneal spikes are separated. But denser cataracts require higher gain. This is a graphical sonogram. You can see here it is misaligned to the optic nerve. You can see that the scleral spike is missing. The scleral spike is missing, which indicates that the beam is not aligned to the macula, but rather with the optic nerve. We have to repeat it. This is another non-perpendicular retinal spike. You can see the ultrasound beam is not perpendicular to the macular surface. You can see the red one. In this case, the rise of retinal spike will be shallow and not rising at a 90-degree angle relative to the baseline. So you need a repetition of this process. What are the checklist of an immersion biometry? It always measures both eye in every patient, remeasure both eyes. If there is more than 0.3 millimeter difference between the eyes, axial length is less than 22 or more than 25. Axial length does not correlate with the glass power, problems with cooperation or fixation, and B scan can be done to document any anatomical difference between the eyes. You can have a second biometrist perform measurement and have them record in a chart with a separate note. Now, briefly, optical biometry is a gold standard nowadays because it's easy, accurate, and reproducible. Higher resolution up to 0.01 millimeter, and subjective foveal alignment give rise to more accurate result, and it's less operator skill dependent. It utilizes a beam of light, very quick, easy to operate, non-contact, very accurate, not suitable for mature cataract, corneal scar, and axial opacities. There are some advantage. It's non-contact, hence no cross-contamination, ease of use and speed of testing, more accurate in silicon-filled eyes and post-astaphylomas. Disadvantages are axial opacities of cornea and dense grades on nucleus give inaccurate result. Needs a vision of at least 6/60 for fixation. Patient with nystagmus, tremors, or lid abnormalities cannot fixate well. Hence, error can occur. So, why immersion biometry in 2022? Since optical biometry measures to the center of the macula, it gives the refractive axial length versus the anatomical axial length achieved with ultrasound biometry. Optical biometry also incorporates actual thickness of the retina, whereas ultrasound adds a standard 20 micron to the axial length. Additionally, there is a third advantage of optical biometry over ultrasound because optical biometry uses light instead of sound for measurement. It produces a more accurate result. The wavelengths used in ultrasound are many times longer than the wavelength of light. The shorter the wavelength, the more precise the measurement. To conclude, we have to judge affordability versus precision. Ultrasound biometry is very popular among ophthalmologists, especially in the third world. The biggest advantage of ultrasound biometry is its affordability. It's 1/8 to 1/10 cost of an optical biometry in India. Technically also, it's preferred, for example, to measure axial length in presence of a very dense cataract or corneal opacities where optical biometry is not that helpful. Ultrasound does not require the patient to fixate on a target. To that extent, patient cooperation is not that material. Ultrasound A-scan is more than sufficient for majority of patients with normal eye anatomy. However, A-scan requires well-trained operators to ensure consistency and higher degree of accuracy. We all know 6 is seen as 6 from one side and 9 from the other side. Just because you are right does not mean I am wrong. You just haven't seen life from my side. Thank you for your patience here.
Thank you very much. Thank you very much. I'm sure many of us do have immersion biometers in our practice. So Dr. Ajay Paul, I would want to ask you, supposing you have entered the K value of the optical biometer and you have entered the actual length from the immersion. So which A constant should you use when you're doing your calculation? Ultrasound A constant we would use. Yes, because
axial length is the what that
what
determines,
decides-
because
yes.
the lens thickness and the A constant of that you use for optical biometry, it depends on the other parameter, the axial length, where the lens position is there.
So one next question to any of the expert panel. Supposing we have taken readings from the immersion biometry and you want to do a toric ion implant with the online Barrett's formula. So what would be that extra thing which you would add when you are making your entries? Huh? Why do I? No, we would also mention the acoustic factor of the intraocular lens, which is going to be planned, which comes on the IOL packet. We would enter that also along with the axial length K readings and everything. And then we can go on to that online site and choose the whichever formula we want to use and go ahead and do the calculation. We shall now.
Thank you very much for that wonderful presentation. We'll move on to the next topic by Dr. Saurabh Sanyal, sir. He is a cataract pediatric ophthalmologist and oculoplasty surgeon at Purva Eye Care in Kolkata. And he will be talking on current optical biometers in practice.
Yeah, I'm not associated with Purva. I have my own practice and my own hospital. It's okay. It's okay. Thank you, Dr. Chitra and AIS for giving me the opportunity. And the topic is one of the very important topic because we are now started thinking beyond monofocal. Most of our practitioners are started thinking beyond monofocal, going for higher premium lenses with toric and multifocal. So the role of optical biometry comes there. So I have no financial interest because I'll be mentioning many machines, name of the many machines, but I am not sponsored by any of these companies. So you know that surprisingly, when I was given this topic by Shugoto, so my first, no, Madam and Shugoto decided the topics. I don't know. So my first this thing in exposure in ophthalmology, when I started my MS, my topic was predictability of spherical correction in pseudophakia in 94. So now in 2022, we are still discussing the target emmetropy. So much, so many years have passed, but we are still on the search of the perfect situations of getting in post-op refraction. So biometry journey usually started with ultrasound, and then this optical thing came, the first optical biometer, that partial coherence interferometry, and then the swept source optical biometers have come. So today's biometry is not merely measuring the axial length, because the recent formulae need many more inputs, like only from the cornea and the anterior chamber. So all these things are basically important for getting into the newer formulas. So that's why we need more informations rather than only axial length. So ultrasound biometry, it's a variable corneal compression, broad sound beam without precise location, limited resolution, incorrect assumption regarding sound velocity. When I was doing my thesis, that time Kenneth J. Hoffer was classifying the velocity in different medias in ocular structures with this ultrasound. So there were formulas, they were correcting the velocity factors. There were some formulas were there. So an inability to use new formulas in ultrasound biometry. So acoustic waves actually replaced by light to measure the distance. Easy to measure, non-invasive instrument, high accuracy without contact, and good repeatability. Evolution of optical biometer introduced late 1990s. It was the first optical biometer was introduced by Zeiss, that is ILMaster 500. That was based on PCI, or the partial coherence interferometry. A decade later, the Hackstreet introduced LensStar 900 that depends on the optical low coherence reflectometry. Then Carl Zeiss came with ILMaster 700. That is the swept source based. And then Alcon came with the Argos, which is yet to come in our country, but they are coming with that. And the Hackstreet came with the iStar. These are all SS OCT based biometers, but the cost is so high, I don't know how many people will be able to afford in their own individual practice. So different light sources and technology are used in optical biometer. As I said, that PCI was that partial coherence interferometry, then OLCR and OLCI, this is Aladdin by Topcon, and then swept source. These are the, as I already mentioned, the swept source biometers. So commonly used in the market, what we see in our day-to-day practice, we have three biometers basically in practice. This is Aladdin, this is LensStar, and this is ILMaster 700. ILMaster 500 is replaced by ILMaster 700. Basically, there is a difference between this optical source. The physics behind is that in PCI, the source is multimode laser diode. And difference is that almost 2 decades ago, PCI revolutionized the cataract surgery, but providing accurate measurement of the axial length. Please remember that ILMaster 500 was only giving the axial length, nothing else. And optical biometry became the choice because of that accurate axial length, which we were searching for with the ultrasound. And then came the OLCR biometry, where it's a logical consequence of PCI, providing more information on patient's eye. yet maintaining the level of precision. That was the advantage of this OLCR or OLCI. The light source in OLCR or SLTI is SLD. SLD is super luminescent diode. These are all basically time domain. All these measurements are A-scan method. A-scan mode is a linear mode. So Aladdin and Lenstar are basically based on this SLD. Lenstar 900, it's one scan, all parameters are on the visual axis, 9 measurements. It gives Pachy, axial length, pupillometry, AC depth, keratometry, eccentricity of the visual axis, lens thickness, white to white, and retinal thickness. All 9 in 30 seconds. You do not have to wait longer. You just focus, ask the patient to fix the target, and it gives all your reading. I am using it for last 7 years. In my personal practice, when I was getting some surprises with your ultrasound biometers, I decided to buy. 7 years back, I bought Lenstar 900. It is still with me. All axial dimensions measured. This is OLCR technology. I said all parameters measured on the visual axis. The patient fixes to the measurement beam. Fixation loss is located. This is very important. Only good measurements are taken in Lenstar. So it is just more than a biometer. It measured simultaneously with the axial dimensions, all on the visual axis. It gives you K reading. It gives you white to white, pupil diameter for premium IOL. Lenstar is a device for toric IOL. I need not to send the calculation to the company for giving me the toric calculation chart, because Lenstar gives it is inbuilt in that. It gives a toric calculation with that printout. And Lenstar is the biometer of future, because this estimation of ELP, this effective lens position, is very important for all the newer biometry formulas. Aladdin actually is from Topcon. It has got all the features, but they have 2 separate. This is the Placido-based technology they have used. So they give a corneal topography and corneal wavefront analysis also. Aladdin, basically, I asked them why you have given name Aladdin. So they said that axial length add-in. So there must be something was already existing, and they have put in that axial length measurement methods in that. So that become a optical biometer. So that is Aladdin is axial length add-in. So these are the different different measurements we get from Aladdin. Now we come to the very important, the modern day, the recent are the swept source. Basically, I don't ask me about the physics of swept source. It's very difficult to explain also and to understand for me also. But it is that a type of laser. It is a laser, same laser, in which the output wavelength is adjustable over a wide range of wavelength. It sweeps across the whole measurements, basically. That's why it is called swept source. And please, just to remember that previous biometers were all A-scan based. This is a B-scan based. You get a picture of the whole eye as in the screen also, like a B-scan. That is the advantage of this swept source technology. So the signal to noise ratio, these are all details. The important is that the major limitation of this time domain OCT or the PCI, what I said, is that inability to obtain measurement through denser media. Denser cataracts, they were not been able to measure by this PCI technology. So this swept source technology has come. And remember that SDOCT technology is never used in your biometers. It was PCI and then swept source. So these are 3 SSOCT based biometers. So there are a few important awards. I will skip few slides because it is a long presentation. Wavelength is 1055. That is 1035 to 1095. This is the key factor of that they penetrate the denser media because of this wavelength. And scanning rate is 2000 scans per second. Scan depth is 44 millimeter. 2D scan, K reading, 950 nanometer light source on cornea, 3 zones and 18 refractive points, and horizontal white to white, they also give. So this is the IL Master 500, where this was PCI, and this is the swept source. As I said that this is the A-scan mode you see, and This one is a B scan. Advantages of swept source over optical is the optical biometry often fail in PSC in nodal point. With LensStar also, sometimes if it is a dense PSC at the nodal point, sometimes I don't get. Should I? Okay. So these are the measurement precision and why it is not moving. So I was telling you about the B scan. So they have a very good quality check in that this thing. They have a fixation check there. And 3-zone telecentric keratometry is one of the added advantage of this biometer. And total K value, the TK, they get it from that. And topography also, they get a topography of the cornea in this ILMaster 700. And selecting formulas, they have incorporated all new formulas in that, and all Barrett formulas are incorporated in 700. This is Argos of Alcon. They have the similar. They claim that it is 1.5 times faster scanning speed than ILMaster 700. And let me skip these slides. An iStar from Hag Street. These are also the same swept source. So basically, I refer to these. I'll just take 1 minute for these two important studies, because anybody wants to buy an optical biometric machine, they should go through these two articles. These are published in January 22. So evaluation of 6 biometers. They have evaluated 6 biometers: Aladdin, AL Scan, Argos, IOLmaster, LensStar, and 08 2000 from Tommy. So these 6 biometers in all same set of patients, they have measured the differences and are statistically analyzed. They see that outcome found in 6 biometers showed statistically significant difference between most of the ocular measurement. It is statistically significant, but those were not clinically significant. So they said that each biometer has got its own role. There is no difference in these 6 biometry measurements. This is statistically there is some difference, but clinically there is no difference. And this is an Indian Journal of Ophthalmology, ocular biometry in dense cataract, comparison of partial coherence interferometry, swept source of coherence tomography, and immersion and ultrasound, Indian Journal. They said that failure rate of axial measurement in eyes with dense cataract by using PCI based biometry was 68.5%. Compared to 20 by SS, 20% only by SSOPD, so OCT based biometer. So it is better that in a denser cataract, you do with this biometry. So thank you. This is a photograph I said that I have kept. This is Arjuna's hitting the fisheye. And he asked Sri Krishna that what you are going to do. I'll be hitting the target. He said, "Okay, I will stabilize your water pot. There'll be no ripple." So we need someone to stabilize the measurements so that we can hit the target. Thank you very much.
Thank you very much. Thank you very much, Dr. Saurabh. I think the person who gained most from this talk was Dr. Saurabh himself, because I think he has read a lot on this. And I think what he told us today, I was going to ask as a question to the expert panel. What he has told us is that although there are changes in the different biometers, but even though some of the biometers may not measure the posterior corneal astigmatism, but they have a mathematical way to calculate it, even these formulas are largely acceptable, even though only swept source can directly measure the posterior cornea. So we are still doing clinically well with the other biometers largely. So I think we need to keep analyzing our own surgical outcomes and then come to the conclusion. Thank you very much, Dr. Saurabh, for a very detailed talk. We shall now go on to our next speaker, Dr. Sagar Bhargava, who is going to tell us about, he's a director and senior consultant from Netralayam. He's going to tell us about getting accurate K readings in challenging situations like post-laser vision correction, keratoconus, and corneal transplant. On to you, Dr. Sagar. I think all of us should really listen to him. There's going to be a lot of learning from his presentation. Thank you.
Good morning, everybody. At the outset, thank you, team OSWP and team ARC for this opportunity. So let's get started. So I'll start with this patient who came to me for an opinion, had a cataract surgery about a month back, had a history of radial keratotomy and was extremely unhappy. And the reason for his unhappiness was he had a refractive surprise of +8. When I flipped through the pages, I found that the calculation was done with pure standard biometry without any alterations. So the question is, why do we get this hyperopic outcomes when we do these cases with standard biometry? So there are 3 errors which are inherently associated with these cases. One is called as, when you use a standard K, you get what is called as keratometric index error, because keratometry requires a refractive index, which is basically based on the fixed relationship between the anterior and posterior curvature, which, as we know, in LASIK and RK gets altered. Then there is something, then these common formulas that we use, SRKT, Holiday 1 and Hopper Q, don't work in these eyes because they will give rise to an ELP prediction error. And the third point is that these keratometers measure at 3.2 millimeters. Now, what if you have a smaller zone of ablation? What if you have a decentered ablation? This will not give you a correct idea. So you move on to corneal topography, then you have all these Ks which come up, which K to take for your calculation. So the question mark always remains. So how do you go about it? Let's study this by going through an example. So this is a very common scenario. You have a patient who had a PRK about 20 years back, comes for a cataract surgery. The only thing we know that patient had a -9 myopia. Now this case, you go ahead with the standard optical biometry. If possible, you have topography access, do a topography, and then put the parameters in the ACRS calculator. This is how the ACRS calculator looks like. I think everybody should see this, use this. The lowermost part is where you put in the biometric input. The middle part is where you put in the topography inputs. Now, topography can be anything. The most commonly available to us is pentagram. So in pentagram, for a post-LASIK, we would want to put a true net power at, which is the mean value of true net power at 4 mm zone, which is centered at apex. For a post RK, you need to put a mean sagittal curvature value at again 4 mm zone, which is centered at pupil. Now, where do you get these values? You get these values on the pentacam power distribution map, and they are in the 4 mm zone. Only thing is you need to alter whether it's an apex or pupil. So this is how you get the values. In post-RK patients, Dr. Holiday recommends that you should take readings in the early morning because these corneas tend to have diurnal variation. They are hyperopes in the morning, myopes in the evening. So when we did all this and we done the SCRS calculator for this patient, we found these are the values. So what do you get on the left? On this side, you get basically these formulas take into account the pre-LASIK refraction, and these formulas basically tell us the no history method. Now, based on this, you can see they are all very close by. So these patients, we'll be very sure that you will get a very good outcome. So we chose a 21.5 diopter and patient had a plane of 6/9. Now, remember the first case which I just showed you. This patient, we run the same diagnostic and we got out 21 diopter. Patient had been put a +5 diopter. So the patient underwent an exchange and this was the refraction of the patient. Patient did well. Now, what do you do when you have a patient like this? Post-RK, wearing a cylindrical power in the glasses. Look at the history. The patient is seeing well with this glass. Now, one thing that comes to your mind, can we do toric IOL in these patients? Now, very recently, in 2022, Dr. Douglas Scott came up with these three criteria, which tell us that you can approach toric IOL in these patients. The important thing is you have to do 2 biometries, 2 optical biometries, and you need to have a regular bow tie astigmatism at 3 mm zone. And you need to look at the corneal astigmatism magnitude. It should be less than 0.75 between the two. The difference should be less than 0.75 between the 2 biometers. And the astigmatic axis should be less than 15 degrees between the 2 biometers. I'll show you with the example. This was the patient which I just showed you the biometry. Now see this IL Master 700 lens star. These were in 2 biometers. Here the difference in the axis was just 18 degrees, little more than 15 degrees, but the magnitude was only 0.5. This was the right eye, see the left eye. The axis is just 2 degree differences there between the 2 biometers, and this was 1.5, 1.05, a little higher, but we went ahead with the toric IOL in this both the eyes, and to our surprise, the result came as very, very good. Use this TrueK toric calculator whenever you're doing the calculation for this. The normal toric calculator will not work. It has to be TrueK toric calculator. So we move on to the next point, the corneal scarring. Very common in our general practice. You know, you have scars like this coming for cataract surgery. You have a central dense scar. Don't bother to measure that cornea. Take the K from the other eye or use standard K. Now, the problem comes when these scars are at scattered points, paralimbal, just around the pupillary axis, linear scars. What do? You have to do a topography in these cases. Topography is absolutely essential. I'll show you why it is important. Take a look at this patient. This patient had a IL master 500, 2.63 cylinder at 95 degrees, but the patient's glass astigmatism or refractive astigmatism was only 1 diopter. We did a topography for this patient and it turned out to be 0.8. Now, why did it happen? It happened because the patient had these adenoviral scars, the opacities. Now, when we all know that IL master 500 has 6 points for measurements. So localized elevations, localized problems can give rise to artifacts or increase in cylindrical power. So that is the reason why the newer generation biometers are now capturing more data, more points. In fact, IL master 700 has 3-zone keratometry. The simple scar like this, think about doing a cataract surgery, but do a topography, you will be surprised that you'll see that it is a 4 diopter cylinder and it's a very regular astigmatism. You go ahead and do a toric IL in this patient. This was a patient who had a corneal stethoscope corneal tear repair, beautifully done tear repair, such a nice bow tie astigmatism, did a toric IL, got a plano outcome. Now this is a post pterygium scar. Looks pretty away from the thing, but you will be surprised to see the effect on the cornea. Almost 5 diopter cylinder. But another thing that you see is there is a slight skewing of the superior lobe. This patient can be taken up for toric IL, and it will do well. A dense scar like this patient came to me. This was the appearance. It was a slightly decentered, asymmetric flattening. Here we were not expecting accurate outcome, but we were aiming for reduction in the cylindrical power. We achieved that, and patient had an uncorrected visual acuity of 6/18 with a little residual cylinder. This was an interesting case, courtesy Dr. Vikram Bhutoria. He had a corneal opacity with an inferior corneal thinning. The surprising part is that IL master 700 did not give me K values. It was completely blank. When we did an auto K, it was showing variable results from 10 to 12. So we did a topography, and the classical sign that you see, a kissing bird sign, can be seen here, and there was a 9 diopter cylinder. So Dr. Bhutoria operated this patient with a customized toric IOL, Ultima toric, and the patient actually did very well using these values. So keratoconus, very briefly, I'm going to touch on it. I'm not going to speak much because I don't think so that interests the thing. But the good point about keratoconus is that now we have this Keynes formula, which is online formula, which has a keratoconus input. So what you need to do is, if it's a stable keratoconus, you just have to, these patients tend to have hyperopic outcomes. You just have to target them towards a little myopic side, do the calculation. So if you have a more than 59 diopter K, you have to target -1 to -2.5 on the refraction value, and you will get an accurate result. So just to sum up, that IL power calculation in different corneal conditions needs appropriate K, not the accurate K, it's the appropriate K for that situation. And the knowledge of use of topography definitely helps. Definitely, there's no doubt about it. Thank you.
That was a wonderful talk. And I would take a question with you because you've read up about this. Supposing the cornea is little irregular, I don't know whether you all are doing that. Would you think of doing a topo-guided regularization of the cornea, even though the patient is older, because the level of perfection they want is entirely different nowadays?
Now, this point can be addressed by simple aberration analysis of the patient. If the higher order operation is more than 0.3, and we can pinpoint that there is especially coma associated with that particular patient, this would need a topo regularization followed by the surgery. We typically do this in decentered ablation patients post-LASIK. So other IK, as I told you, if it's a dense corneal scar, there's no other option. You have to go in for the other IK. The other thing which possibly people used to do earlier on was to do an intraoperative retinoscopy at the time of the surgery and then take a call. But other IKs will give you a very rough idea. So idea is not to have a refractive outcome in a scarred cornea. Idea is to just have a nice uneventful surgery. You may have a power ranging, their visual potential will anyway not cross beyond 660. So refractive correction is not what we are aiming for there.
Very good talk. There's, I think, a lot of understanding which he has, and he needs a real good clap. Very difficult to make such tough
I
presentation.
have a question to
Yes.
Sagar.
Yes.
So which formula do you prefer for this? Is it ray tracing that's Oculis also available now? and Barrett or Olson or Kane.
So if it is if it's a decenter ablation, or if there is a lot of variability in the central 3 mm zone, ray tracing is the formula of choice. Unfortunately, it's the availability issue and the cost issue. It's not easily available.
Yeah.
So ray tracing would be definitely choice number one. Other than that, if you have post LASIK, post RK, now the concept has gone towards total keratometry. You combine total keratometry with the Barrett's or
Barrett's formula.
even Haig's,
Yeah.
even EVO. So TK value in those formulas work out very well. There are
Yeah.
papers now in last 1
Biggest
year.
TQ probably the best now,
Yes.
not the Barrett. Let's just go on.
Thank you.
Thank you, Sagar.
Thank you, love.
We would like to invite
Sagar.
our next speaker for today, Dr. Chitra Ramamurthy, Chairman of Academic and Research Committee and Director of Eye Foundation Group of Hospitals in Tamil Nadu. Dr. Chitra Ramamurthy will be speaking on key pearls to address target emmetropia.
After a wonderful talk, I don't know whether I'm going to keep up to it. So I'm going to tell you all in brief what are the key pearls with which you can hit target emmetropia. Now the situation stands amongst our patients that they consider a plus, if you are within plus minus 0.5 diopter of target emmetropia, you have won with the patient. And if you are more, I would rather believe that we have lost that patient. And the other important thing for us to also understand is a success in a surgery is, are you actually giving visual freedom for the patient for the promises for distant vision or near vision or intermediate vision, which you have promised? It also becomes important for us to analyze how well are we actually performing. And this was a study, a database of Warren Hill told us that if you're using till the 3rd generation formulae, 78% of them were within plus minus 0.5 of the target emmetropia. Whereas if you're using the 4th generation formula and more, 90% of them are within plus minus 0.5 diopter of target. And it becomes more important when you're looking at those post-LASIK eyes and those extremes of axial length, wherein the 4th generation formulas actually do well. So then what is biometry? Biometry is just simple arithmetic where there are some measurements and there are certain assumptions. If you feed in your post-op refraction, what is the target which you want? The first thing which comes up is axial length. And now with the way we have our optical biometers, our axial length measurement is unsurpassed accuracy. Then comes the K value, where there are assumptions which are made, where we are not accurate. Then comes the effective lens position. The newer formulas have included so many variables to exactly estimate where the lens sits in the capsular bag. And then there is a variable there. And the final intraocular lens part calculation is calculated with certain exact values and certain variable values. So you may have a post-op outcome like this, where the patient sees plano 6.6. Do you think, pat your back, that this is perfect measurements, or is it that there were 2 errors in that eye which got cancelled out? But then you could have a patient with this kind of hyperopic error, wherein it tells you that you have to do something for this patient. So then comes why, and this was another study done by Norby in 2008, wherein at that time he told us that the effective lens position contributes to 35% of errors, axial length 27, refraction 17, and K value 10. And now we have won over the axial length measurements. So the pearl number 1 is, does one formula fit all? Yes, the way the 4th generation formulas and the other formulas have come up, we are nearly able to stick to one formula in majority of these, in all situations, as against trying different formulas for different situations. What we also need to understand how they all arrived at, like the earlier formulas were the regression formulas, which were based on post-op refractive results estimation. Then came the Vergence formulas, which were based on geometric optics, wherein they kept adding variables like axial length, anterior chamber depth, white to white, and more, kept on adding variables to exactly find where the lens sits in the bag or the effective lens position. Then came the statistical analysis by artificial intelligence and came the ray tracing. Now, what is this I keep talking about effective lens position? That is, it is the distance from the anterior corneal surface to the implant optical center in the bag. So this is what is trying to be measured by each of the formula. And if the lens is little tilted forward, you need lesser power. And if the lens is little tilted back, you need more power. So it becomes very critical to use the formula, which is going to help us exactly estimate where the lens sits in the back. In the normal eye, what you will find if you look here is it is an average value, and in all the formulas, the third generation or the fourth generation are all nearly similar. So that means that in normal eyes, you could use any of the formulas and you can do very well. In long eyes, that is a myopic eye, what you see is it is a small powered eye, like a 2 or a 4. So in this particular eye, there was a difference in the Barrett's and the AMO calculator, but because the IOL powers were small, they did not have much of an impact in the effective lens position. But what happens in short eyes, you have to use a high power of IOL. So even a small shift in the position of the IOL in the bag would bring a huge refractive change. That is why we need to have the right size rexes and the right overlap of the IOL and many more things. If you look at the dimension matrix of human eye, what you understand is that in 73% of the patients, the anterior axial length and the anterior chamber depth is actually normal. When you look in the short eyes, in 9% of these eyes, in 6.9% of the eyes, the anterior chamber depth is normal. But in 1.8% of these small eyes, the anterior chamber depth is small. So you don't know about that. Then if you look at the long eyes, in 15% of these eyes, 13.5% of the eyes, the anterior chamber depth is normal. But in 1.5% of the eyes, the anterior chamber is big. So then it is not enough if you just measure the axial length. You need to know the axial anterior chamber depth measurement too. And that is where the newer generation formulas come in. This was another analysis where the prediction IOL power was measured against the implant IOL power. And the predictive error, it showed that within the normal range, many formulas worked well, but in the extremes, the Barrett's and the Keynes and the other formulas did well. If you look at the toric IOL, what you understand is they incorporate a toricity ratio in the IOL power calculators. And this is the ratio of the astigmatism in the IOL plane to that in the corneal plane. Now, a standard value of 1.45 will not help. If you look here, if the IOL power, if the patient has a K value of 38 and an axial length of 20, it tells that you need a toricity ratio of 1.29, whereas it becomes 1.8 if the measurements are different. So what you need to understand is with the different K values and different axial length, the toricity ratio changes, and these new formulas incorporate that. This is again another case wherein it was +2 diopter against the rule astigmatism. And in the normal eye, it says T5 toric IOL series is enough. But in a small eye, it says T4, and in a large eye with the same amount of astigmatism, it says that the T6 series have to be used. So when you use these newer formulas, what we understand is there are so many factors which are being factored in. That is, it also looks into the principal plane of the different geometry of the lenses. It also looks into whether it's with the rule, against the rule, whether there is a posterior corneal astigmatism is measured. It uses the true K formula, which uses a mathematical model along with the total keratometry measurements and the double K formula to exactly tell you how to do with these post-LASIK eyes. Essentially, when I say it measures the principal plane, in high myopic the IOLs used, you move on from biconvex to plano-convex to meniscus lens. And because of the thickness or the thinness of these lens, it also tells you where the lens sits in the capsular bag. So it becomes important that we do accurate measurements. And as was beautifully alluded, with the immersion, the accuracy is not like with the optical biometers because they lack that kind of accuracy or the depth of penetration. In immersion, if you are to have immersion, you should ensure that all the spikes are equal in length. You should have at least 5 readings which are similar. You should not compress the cornea. The standard deviation should be less than 0.06, and the velocity of the cataract or the phakic eye or pseudophakic eye should be measured. In the cornea, you realize that different keratometers measure at different points, some in the center, some at 3.2, some have 3 rings, some have 2 rings. So it becomes necessary for us to be very, very clear that if you have access to the best of measurements, like a total keratometry, wherein it uses the swept source and also the B scan, wherein it measures the anterior cornea, and also with the help of the B scan, interpolates the values from the posterior cornea and gives us the exact TK value. Now, if these values are incorporated, there's a greater accuracy in measurement. But there are many formulas which have mathematically calculated the posterior corneal astigmatism. And if you enter your TK measurements in that, then please understand you would end up overcorrecting the size. So this is again beautifully discussed. I'm not going into it. The Pearl 3 is also to look at the other eye. Now, this patient, there's a query at axial length. There's a difference in the axial length between the two eyes. And you can see that the IOL power is 22 and 25 between the two eyes. Now, that should make you wonder. Then when you do check on the immersion, you realize that one value is off. So that is causing the error. Then you go back and redo your measurements. In fact, the next day when we did the measurements, what we realized in the IOL master itself, it gave the correct values. So it is so important to look into the raw data. It is also very, very important that we keep in mind that if there is an axial length difference between the two eyes of more than 0.3, K value between two eyes of more than 1 diopter, IOL power values of more than 1 diopter, we should be careful. It is very, very important for us. Like this was a patient, it showed 0.5 diopter cylinder in the right eye and 2 diopter in the left eye. And when we looked the patient on slit lamp, there was so much of dry eyes. See, we went ahead and treated the dry eyes. And then when we did the biometry, it was 0.5 in 2 eyes. And imagine if we had not checked on the slit lamp, how much of error would have happened. So it mandates that we understand that 60% of our routine cataract patients, although they are asymptomatic, they have a tear breakup time of less than 5. 50% have central corneal staining, which was done in a phaco study and which has to be understood. In fact, the impact of dry eye disease is so significant and that can cause refractive surprises. In fact, the hyperosmolarity of the tear could bring on even a 0.5 diopter or more of difference of the IOL power calculation. So it's important that you treat the dry eye disease before you plan your IOL power calculation. It is important you teach your technicians to look at the green light to know whether the values are valid. To look at the standard deviation, it should be less than 30 micron between the two eyes. He should look at the LED lights. Does it have a fishtail appearance? Are they accurate? Are they pinpoint? If the fixation check is right, there's no red flag there. And that is how you go and do it. You need to validate your measurements. Now, this was a patient. The K values, if you look carefully, was 38. And the other eyes, it was 42. And then we went and asked the history, the patient said they had got LASIK done. And now that if you had not asked that history, he had not told you, then there would have been a huge error. Now we went on to the LASIK mode and did our IOL power calculation. It becomes very, very important for us to look at all those validation guidelines, all those red lights which show extremes of axial length, short AC depth, everything has to be taken into account. It is important to treat astigmatism. Like you feed in, it tells you that for a 0.97 with the rule, it tells that you don't have to say it's non-toric. And for a 0.8 against the rule astigmatism, it says that you implant a toric IOL. These are things which you need to understand when you want to do premium with every ordinary patient of yours. And I think that the young generation there should be looking at doing premium surgery in every cataract surgery. It is important, like we do in our setup, we actually do a biometry even before we do an applanation tonometry. Look at how much astigmatism is there, and then decide whether you're going to talk about toric IOLs to these patients or a plain spherical IOL, rather than later doing the biometry and getting all muddled in your discussion. We also need to remember that when it comes to a multifocal IOL, the threshold for toric IOLs is very less. And in this particular case, what went wrong was he had a 0.75 of astigmatism, and we just implanted a PanOptics, and there was a huge residual, there was a small residual error. And the next eye went and did a PanOptics. Again, you need to know your toric IOL calculator, if it has measures posterior corneal astigmatism, centroid values. I'm not discussing all of it. If you have immersion, as I said, feed in all the immersion data and then feed in the acoustic factor of the IOL power, which is written on the IOL pack, and then go on online, use the Barrett formula, and still you could do as well as if you were using the optical biometers. Finally, we need to remember that in extremely 30% of these eyes, you need to do dry eye measurements if the errors are there in standard deviation. You may have to do a topography, you may have to do a tomography, you may have to do an eye trace, you may have to look at the dysfunctional lens index. You need to see whether the topography is symmetrical. You need to be extra cautious of post-laser vision correction eyes, which was so well discussed. But finally, important that even though your technicians are doing all the measurements, don't remove yourself from the system. Be involved to see whether the right formula is being used. Because there's no point doing a right surgery without putting the right kind of IOL. And finally, after the whole story of 10 minutes, which I related to you, what still happens is there is a change in how the IOL shifts in the eye post-operatively, and that is unpredictable. Like 17.6% of the eyes had an anterior chamber shift of more than 1 millimeter. So probably the future would be a way to correct it once this small error has happened, or a breakthrough technology comes in wherein we are doing the right way of effective lens position measurement. Thank you very much.
Thank you so much for that wonderful presentation, ma'am. We would like to now invite our next speaker for today, Dr. Sumanna Chatterjee.
So, a very good afternoon to all of you. And I want to thank Dr. Sugata Paul and Dr. Chitra ma'am for giving me the opportunity to talk on this podium. I want to thank Dr. Chitra ma'am for setting the stage for my topic. It is actually the diagnosing and managing ocular surface disorder in perioperative period. So I will start with the topic and why we are discussing it actually, because what is diagnosed before surgery is the patient's problem, and what is diagnosed after surgery is the surgeon's problem. So this is today's scenario. And as Madam has already spoken about it, the FECO study, it has shown that the 60% of routine cataract patients are asymptomatic, yet 50% had central corneal staining. Another similar study in the following year, they have shown that incidence of ocular surface disease in patients presenting for cataract surgery was over 80%. And in those who were asymptomatic, over 50% had an abnormal tear osmolarity or MMP9 level. And the ophthalmic surgery itself can affect the ocular surface by injuring the epithelium and sensory nerves, disrupting the tear film and local inflammation. So, an algorithm has been proposed for the preoperative diagnosis and treatment of ocular surface disorder. Failure to address this surface disorder proactively potentially result in a trio of adverse outcomes. What are those? Unsatisfactory vision, like refractive misses, fluctuating visions, induced higher order aberrations, new or worsened surface symptoms like foreign body sensations, redness, pain, and postoperative infections such as endophthalmitis. So first, we need to do a symptom assessment. The most important problem is the older patients with significant cataracts either do not have the symptoms or they do not feel compelled to report it. And not every subtype of ocular surface disorder requires delaying the refractive measurements and surgery. So there are two pre-surgical categories: non-visual significant ocular surface disorder and visually significant ocular surface disorder. So non-visuals, visually significant disorders include mild conjunctivochalasis with a normal tear film, non-obvious MGD, pingecula, neuropathic corneal pain syndrome, etc. So patients need to be educated about their conditions and counseled that the potential is there for worsening after surgery, and prophylactic treatment has to be initiated preoperatively and continued post-op to minimize the risk for exacerbation. Now, visually significant What does they do? They lead to reduced visual quality and potential errors in pre-op measurements like topo, kerato, refraction, aberrometry, everything. So the ocular surface disorder that results in corneal staining or hyperosmolarity, like dry eye disease, MGD, neurotrophic or exposure keratitis. Second, irregular astigmatism, EBMD, epithelial basement membrane dystrophy, pterygium Salzmann nodules, and or increases the risk for surgical infections like infectious conjunctivitis, staph, blepharitis, etc. So any combination of fluctuating vision improved with blinking or lubrication, highly elevated osmolarity and MMP9, irregular fluctuating topography and or aberrometry, interblink increases, irregular astigmatism from corneal epithelial abnormalities, significant corneal staining, staph, blepharitis, and infectious conjunctivitis all give rise to visually significant ocular surface disorder. So what do? We should postpone the surgery and delay the final refractive measurements until it is fully treated and resolved. At each follow-up, the algorithm I will talk later should be repeated from the beginning until this visually significant ocular surface disorder is converted to non-visually significant one, at which time the final measurements can be performed and surgery can proceed. So there is a novel questionnaire suggested, that is ASCRS Speed questionnaire, as none of the published one were created specifically with the preoperative patient in mind. So I will show it later. Higher total number of red boxes and higher total scores raise the suspicion for the VSOCD. This is the questionnaire. The higher score from this table and the higher red square should always alert you. The signs. The objective non-invasive tear testing, we do them after the questionnaire is completed. And first we do all these measurements. And if there is any ambiguity in these measurements, as already suggested by Chitra madam. And second, for objective signs of OSD, osmolarity, MMP9, most of us do not have access to this, but other clinical signs are there like redness, pain, and inflammatory signs that can give rise to suspicion. And if any one of the components of the initial screening battery are abnormal, then the pre-surgical patient is at risk for OSD and further diagnostic tests can be done to identify the OSD subtypes. They are optional, non-invasive, objective OSD tests. They include the meibomian gland imaging, lipid layer thickness, non-invasive tear breakup time, tear meniscus height, corneal topo, Sjogren disease antibody testing, etc. And irregular topography pattern, this is very important, especially when highly variable between tests, highly suggestive of dry eye disease in the absence of positive corneal lesions. So this is the algorithm, and this sums up whatever slides I have just spoken about. And we'll come directly to the clinical examination, which gives 4 important keys: look, lift, pull, and push. What is look? We need to look about the blink quality and quantity. Very important, believe me. Then the eyelids for the malposition, lag off, proptosis, exposure, and then we need to visually assess the tear meniscus height. Also for the signs of anterior and posterior blepharitis and interpalpebral ocular surface. Interpalpebral cornea for any surface abnormalities, loss of clarity, pterygium, subepithelial scarring, epithelial basement membrane degeneration, and the Salzmann nodules. The thing that we commonly miss in our OPD is to lift and pull. This is very important. We can diagnose the superior limbic keratitis, superior corneal scars. We can rule out the superior epithelial basement membrane dystrophy and identify eyelid laxity and floppy eyelid syndrome. What is the push? By pushing on the lower eyelid margin, the meibomian glands are expressed and the quantity, quality, and flow of meibum are assessed. Identifying the patients with non-obvious meibomian gland disease, that is a form of obstructive MGD in which classic inflammatory signs are absent. So the final phase is invasive testing with the corneal staining and the tear film breakup time. So this is again the part of the algorithm, and the treatment is initiated and more higher advanced level to maximize post-operative outcomes and patient satisfaction. Anti-inflammatory treatment includes the steroids, the cyclosporin A, doxycycline, lead margin disease treatment, as we know, regular warm compresses, lead hygiene. If it is Demodex confirmed, then tea tree oil. In-office thermal pulsation, you can always take, and omega-3 fatty acids are also there. So corneal staining is the single most critical sign of OSD, and aggressive lubrication with preservative-free artificial tears important. And the superficial abnormalities need the surgical corrections. After initiating the multifaceted treatment, we have to see that the patient has to be reassessed in approximately 2 to 4 weeks' time and should be counseled about the ongoing treatment for this ocular surface disorder in the postoperative period itself. This is again the part of the algorithm that I have highlighted on. We have to limit the use of anesthetic and mydriatic eye drops, avoid the persistent surface irrigation. We should prefer small incision, short surgical time, reduce light of the microscope, and caution with the premium IOLs in DED patients. This is the intraoperative factors, and postoperatively preservative-free artificial tear, and choose the proper treatment to restore the ocular surface and increase the frequency of follow-up visit. The most important, for the unhappy postoperative patient, the OSD should be identified and fully treated before considering another surgical option that we usually commonly do, that is a NDER capsulotomy. So that is all, and thank you for your patient hearing.
Thank you. Thank you for a very thorough talk. I'll just, after all that you have told, one message to the audience. At what level of, like all of us will be doing a Shermer's test and or a tear breakup time. So at what value, is there one value when you would go and do a dry eye treatment for these patients? Like a lot of staining on the,
Yeah, actually the Sharma's tests are not very reliable, so do not rely upon them. The corneal staining is the single most factor that you should give stress on. Yes.
Yes. Thank you very much. Dr. Shreyash Ramurthy was to be giving his talk, but actually my father has turned extremely unwell and admitted, and so he took care, he stayed back to take care of him, so he's not there to talk today, and my apologies on his behalf. I think we lost out on a very good talk. We have our next speaker, Dr. Bhaskar Ray Chowdhury, who's the consultant at Calcutta Medical Research Institute, Calcutta. He's going to talk on a very important talk. Where is he? He is going to talk on a very, very important talk for all of us, nuances in toric IOL path calculation. And I think we should all stay glued to it to learn from him. Thank you. Since there is going to be no tea break, all of us have had tea. We shall go straight to the next session. And please, I beg you all, let's have just a lunch time of 20 minutes and come back, because the next is challenging cases, which is going to be really very, very good. And there's going to be learning for us in that particular session only. So please, all of you, let's respect it and come back. And I would have to leave at 3 o'clock and Satyajit will take on. So let's make the best of me before you send me off. Thank you. On to you.
Thank you, Dr. Chitra, and thank you, OSWB, for having me. So most of what I will be talking has been covered by Dr. Sagar and Dr. Chitra. So I'll just be rounding it up and giving it a flavor for use for the general ophthalmologist. So when we look at the astigmatic cornea, the issues in toric calculation is getting the final net corneal astigmatism that the patient will have after the surgery. So that includes accurate preoperative measurement of the cylindrical power, as well as factoring in the SIAs, that is the surgically induced astigmatism. And we should also not forget the spherical equivalent, because if you have corrected the cylinder and landed up with a spherical error, the patient is not going to be happy. So why is the corneal power so important? Because very simply, it's about 1 diopter of keratometry error will result in 0.9 diopters of error in the power calculated. So an accurate corneal power is very important, and the place of ELP in the calculation of the spherical power has been stressed, and we will be talking about it some in my talk as well. So what are the barriers to assessment of a accurate keratometry reading? And that is, in most systems are Placido based, and they do only anterior surface modeling. And the zone of measurement also varies from instrument to instrument, and there is hardly any interchangeability of instruments that are used to measure the K readings. So the the measurement zones vary from 3.2 millimeters in keratometers, manual keratometers, to limbus in Placido-based and scanning slit like Pentacam and Orbscan. And the advantage of the scanning slit, now Orbscan is out, so Pentacam, is that there is no blind zone centrally and the maximum data points are actually located in the center. So it gives a better view of the central part of the cornea. There are many fallacies of the manual keratometer and I will not stress on it, but one thing that has been repeatedly told is that it assumes a refractive index of 1.3375, which may not be true in all cases, and this is the cause, the major cause of errors in most of the times. Now, why is the posterior cornea important? Because normally the anterior and the posterior cornea, they augment each other. So they cancel out some of the posterior cornea cancels out some of the power of the anterior cornea. But in some cases of ectasia like keratoconus, these two curvatures may not be concentric. So that will give rise to irregular astigmatism. Whereas keratometers mostly assume a front-back ratio of 82%, which may not be true in all cases. So if you look at the posterior cornea, the anterior cornea has a dioptric value of 49 and the posterior cornea has a dioptric value of -6. So usually this augments each other. This is the ideal situation. But posterior corneal astigmatism is often clinically relevant, and one study found that it reduced the total corneal astigmatism by 13.4% in as many as up to 30% of eyes. And the total corneal astigmatism differs from the anterior corneal astigmatism by more than 0.5 diopter or more than 10 degrees in meridian. And as we know that error of 1 diopter in the K will produce a net error of 0.9 diopters in the power calculated. Posterior corneal astigmatism also varies from whether the anterior is with the rule or against the rule. It usually compensates the anterior corneal astigmatism in with the rule astigmatism, and it for cases of anterior against the rule astigmatism, it remains fairly constant. And this observation led to the development of the Baylor's nomogram, and it is also factored into the Barrett's calculator. Posterior corneal astigmatism also changes with age, and a lot of bones were made about it in various conferences. But the fact remains that with age, it is the anterior corneal astigmatism which is the most important factor contributing to the change in total K. So till now, what we have discussed is that the PCA is important in estimation of the true corneal power, including astigmatism. And Placido system measure only the anterior astigmatism, and both Baylor nomogram and Barrett's calculator can estimate the net corneal power without actually measuring the posterior corneal astigmatism. Just few words about SIA. SIA is important because it is one of the parameters, key parameters that you have to feed into toric calculators, and you have to calculate your own SIA or you can use a standard value. So if you are calculating your SIA, then it has to be calculated for each incision location and each incision size, which makes it almost impossible to do. But you can use a standard. If you are using a 2.2 to 2.4 or 2.8, then you can use a standard SIA. So we will skip this. Normally we look at astigmatism as a polar coordinate. That is, it has got a value and an angle. So for calculation, now what we are doing is we are converting it into a Cartesian coordinate so that we can represent it in a circular histogram. We will not go into the details, but these values are called the centroid values, and you should use a centroid value in all the toric calculators that incorporate the Barrett calculator. So the average centroid value to use in most of your cases, if you are doing a 2.2 to 2.4, is a 0.1. Now we come to the toric calculators. The Barrett calculators, I'll just be touching on the spherical calculation as well before I move on to the toric calculation. The Barrett 2 universal formula, it uses a theoretical model. So it's a theoretical model with some regression analysis. So it's all of the new generation formulas like Keynes and Olsen, they're all of the same type. So it's not a pure theoretical formula. But the difference is that Barrett assumes a thick lens model. So it is more accurate in minus lenses and high plus lenses because it calculates the ELP according to that. Now the Barrett's calculator takes in the axial length, K1, K2, optical anterior chamber depth and refraction. These are the mandatory parameters, and the optional parameters are the lens thickness and white to white measurement. What it does, it calculates the height of the corneal dome, and from that it measures the expected position of the effective lens position. Now, the importance of ELP is obvious because if the lens is forwardly placed, then the lens rays will not come to focus on the retina, and it has to be in the correct location for the calculation to work out. So all advanced formulae do ELP calculation. Barrett's is the best accepted. Probably it is more accessible online. Now, Barrett's toric calculator is built on Barrett's Universal 2 formula, and it takes in all the parameters as well as incision SIA and incision location together with lens thickness and white to white measurements. Now, which calculator should we use, the company provided or the generic? Now, if you're using company provided calculators, then you have to look at whether they're whether they're using the Barrett's toric. Like in this case, you have that Alcon second generation features the Barrett toric calculator. So if you're using the first generation and you are using a pentacam to get your K values, then you can feed in the total net power or the effective keratometry readings. Whereas if you are using something that is using the Barrett toric, then you should not feed in the effective K readings, only the anterior K readings. This Dr. Chitra pointed out. The other two calculators, J&J and Hoya, which are most commonly used, they have an option of either include the posterior corneal astigmatism. So if you have this checkbox checked, then you can put in the effective K readings over here. If it is unchecked, then you put in only the anterior K readings over there, and the PCA will be calculated. Same thing with Hoya, you can turn the slider off to not to use this regression analysis, which calculates the PCA. So generic calculators like Barrett's do a better job at estimating the spherical equivalent. So you also have to remember that once again, that toric IOL implantation is not just about correction of the cylinder, but also about correcting the spherical. So the spherical equivalent should be correctly estimated, and in that Barrett's do a better job. Barrett's does a better job. Some company provided calculators use the Barrett toric calculator and can be used. And if you are using the Barrett's toric, then don't feed in the effective K readings. Now, Barrett's true K is for post-refractive eyes. It is not to be used in normal cases. And over here, you can choose the refractive surgery that has been done and feed in the pre and post-op refraction history. If you have, these are not mandatory. If you do not have, you need not use it. It also has an option of using whether you are going to use the predicted PCA or the measured PCA. So Barrett's toric, when you are giving only the anterior and the kind of refractive correction that has been done, it will estimate the PCA in these cases also. However, if you want to input your own measured PCA values from pentacam or any tomography machine, then the option is there in Barrett's TrueK to do that. So when to use TrueK? Post-classic corneas with residual, untreated or regressed astigmatism. I'm talking about astigmatism because we are talking about toric lenses. Now, in scarred corneas and keratoconus, it is best to go for a tomography like pentacam. Use the effective keratometry readings at 4 or 4.5 millimeter zone and feed that directly into first generation calculators. So if you have a topography and you are looking for red flags, then these are the red flags when there is either superior or inferior steepening, or there is irregular astigmatism, or there is asymmetric bow tie. So a toric IOL will work out best when there is a symmetric bow tie. If you are looking at the refraction of the patient, then it is very important that the astigmatism and the cylinder that is there in the manifest refraction, if you can do one, does not differ by more than 1 diopter in the topography calculated astigmatism, because these are the cases where the posterior corneal astigmatism is significant, and these are the cases where you should do a tomography based, like pentacam based analysis of the corneal model. So to sum up, accurate spherical calculation is as important as toric calculation. Barrett's toric is the go-to calculator online. Use Barrett's TrueK for post-refractive surgery scenario and use the EKR values from pentacam If you are using the EKR values from Pentacam, make sure that the correct option is selected in the calculator. And for scarred corneas, ectatic corneas, Pentacam EKR for 4 or 4.5 is advisable. For keratoconus size, there is a debate whether you should use toric, and you use toric with caution, and it is obviously best when keratoconus is not progressing and when it is grade 1 or grade 2 keratoconus, because beyond that, the irregularity of astigmatism is too much. Toric IOLs will not give good results. You can evaluate your SIA or use a 0.1 centroid value in Barrett's toric calculator. Thank you.
Thank you very much, Doctor, for a very detailed, very thorough talk. I think whether the audience learned or not, each of the speakers have read and learned a lot. We shall now go on to our next session, technology and techniques. And we have on the expert panel, Dr. Atish Chandrapal, who heads the Sushrut Eye Foundation and Research Center, a great friend for all of us. Dr. Jayanshu Sengupta, Dr. Bhaskar A. Chaudhary, who's a consultant from Calcutta Medical Research Institute, Dr. Jayanshu Sengupta, who's a consultant Priyamvada Birla Arvind Eye Hospital, Dr. Saurabh Sanyal, who's a consultant pediatric ophthalmology oculoplasty from Purva Eye Center, and Dr. Sudipto Ghosh, who's a consultant in Rabindranath Tagore International Institute of Cardiac Sciences. Nobody's come. I want them all to come and sit here. Expert panel. We shall now go, and I have moderating with me Dr. Priyansha Chatterjee. Thank you so much. Dr. Priyansha Chatterjee and Dr. Satyajit. And there is a minor change in the sequence. We have Dr. Rajesh Sinha, who has to catch his flight, and there are some very sick relatives in the family on his way, so you are here. And I've already introduced Dr. Rajesh Sinha to all of you, but for his sake, I'm going to introduce again. He's a professor of ophthalmology from All India Institute of Medical Sciences, our honorary treasurer, and an amazing individual and a superb surgeon and a national figure. On to you, Rajesh, to talk on cataract surgery in compromised cornea.
Thank you, Dr. Chitra, for the kind words and the opportunity. I would also like to thank Dr. Satyajit and Dr. Sugato and OSWB for having me here. I'll be talking about managing cataracts in corneal opacity and haze. See, the most ideal treatment whenever we have a cataract and a corneal opacity is a corneal triple procedure. Therein, you can have a good visual outcome, good clarity of the visual axis. However, there are many situations wherein a patient has a vascularized corneal opacity, a one-eyed individual wherein a cataract is dense, and the cataract can be managed and the patient can have a reasonably good vision for rest of the life. In such a case, a cataract surgery, good procedure, is something that is advisable. And the basic aim of doing this presentation is to discuss various methods to enhance visualization, because in a corneal disorder, in a corneal scar, the problem is the visibility of the lens, visibility of the area where you have to operate. And that is what we have to discuss. And one of the most important thing is that we should have a well-dilated pupil, so that whatever area, whatever scar we have, if we have some area of clarity through which we can see the lens clearly, we can go ahead and complete the procedure. As far as incision is concerned, it should be given in a clear area. As say, for example, this kind of a corneal scar, you should give the incision here so that you can do everything under direct visualization. As far as further enhancement of visualization is concerned, a prolonged use of trap and blue to have a better staining of the capsule is very useful, because not only for capsular rhexis, but also during chopping, if the rhexis is very well visible, you don't accidentally damage the capsule. And that is most important. And a few steps that we have to be really careful in is that once we have done a good staining and all that, when you're doing a capsular rhexis, it is very essential then that when you are holding it and moving your hand, you leave the capsule only in the area wherein the cornea is clear, because again you have to hold that part of the capsule. So in this case, if it's a scar here, I left the hold of the capsular flap here so that I can see again and do it. Further, In such cases, use of a good viscoelastic to nicely stain, like chondroitin sulfate, to coat the endothelium is very essential, because many times you have to be a little anterior in order to protect the posterior capsule in doing the procedure. And but then many times these use of viscoelastic helps a lot. If you are at a critical stage, use a blob of methyl cellulose on the cornea, and suddenly it improves the visualization, and then you can complete the procedure. As you can see here, the moment you put the viscoelastic, the visualization improves significantly, and that really helps you to improve your surgical technique. Then, of course, as I said, high viscosity viscoelastic plus endothelial protective viscoelastic, something like Viscoat, which contains chondroitin sulfate, is essential to save the endothelium. Sometimes if you have a scar like this in the center, even if the pupil is, say, 5 millimeter or 6 millimeter dilated, you would want to have further dilated pupils so that your area of visibility further increases, so that you can manage a very hard cataract and with a central scar. In such a case, when you are chopping and you are doing the manipulation, it is very useful. As you can see here, you can chop from slightly away from the opacity, because behind the opacity you can't see where you are chopping. So for that, if you enlarge the pupil, even with the help of a ring, with the help of a hook, that is very useful in such cases. Sometimes if you have a central scar, we had done a study using eccentric crater, and then we used to chop from there, and that has had a good outcome. Use of endo-illuminator is very essential, very effective actually in such cases, in cases of bad ocular surface with a healed corneal opacity, healed keratitis. So what you do is that you use the endo-illuminator from outside. Your assistant holds it while you are chopping the nucleus. Now, once you have completely chopped the nucleus, you can see how good it improves the visualization by using the endo-illuminator. But once you have chopped the nucleus and you have to hold the epinucleus, you take the endo-illuminator inside and then take your phaco probe close to the epinucleus. You can exactly see where you are holding. You are holding the epinucleus and not the capsule. So these are a few of the tricks that we all should employ in order to have a good outcome in such cases. And as far as the another technique is concerned, if you have a poor ocular surface, not a scar, poor ocular surface, in such a case, to get a good retro illumination, you can use a chandelier illumination, and you can see with this kind of a glow, you can do all the procedure very nicely and accurately. This is one of the pictures of a post phaco in corneal opacity. Now, you can implant toric IOL as well in a corneal scar if it's a long-standing scar, but in the periphery and not in the center. If it's a central scar, we should not use toric implant. But if in a peripheral scar, something like this, you can implant toric IOL. There's a little bit of zonal dehiscence here, for which an endocapsular ring will be implanted. So, small traumatic zonal dehiscence, you don't expect the zonal dehiscence to progress. So in such a case, you can put endocapsular ring and put a toric implant. Now, we had done a study and published long back, actually, for a central corneal scar. If you do cataract surgery by enlarging the pupil, and then after that, you put intracameral pilocarpine, and then depending upon the opacity, depending upon the scar, you can do small pupillary sphincterotomy. These sphincterotomies are very useful. We should not do optical iridectomy, which we used to do long back, 20 years back. We now do pupillary sphincterotomy, and it really helps because it doesn't reach to the edge of the IOL, and it also takes the IOL towards the area where it is clear. So you have to see which area is clear, and then you can do pupillary sphincterotomy, and it works very well. And in some scenarios, if you have the availability of the corneal tissue, you can do anterior lamellar keratoplasty to improve the visualization. As you can see here, by cutting the tissue, the visualization improves, and then of course you can go ahead and stain the capsule and complete the procedure. Just one more example I will show you, that in a scar like this also, if you do a lamellar dissection and use viscoelastic, you can see how dense is the scar. In such a case, you have to do lamellar procedure. But if you, after doing a lamellar dissection, if you use viscoelastic on the surface, you can see here, I'll just put viscoelastic on the surface and it improves the visualization significantly. And of course, you use strap and blue dye to stain the capsule in order to have a good visualization. You can go ahead and complete the, you can see how dense was the scar and now how clear it is. And depending upon if it's a chemical injury wherein you don't want to do a full thickness graft, or if it's a healed scar because of keratitis, you can go ahead with a full thickness scar as well. You can see the visualization has improved so much. You can do a rhexis, complete the procedure and put the IOL in the capsular bag. So in conclusion, in a case with a corneal opacity and cataract, we want, particularly in a one-eyed individual, bad vascularized scar. If you do a keratoplasty also, the risk of rejection is very high. In such a case, if you can manage with a cataract surgery, and particularly when the opacity is slightly paracentral, little bit covering the central area, in such a case, by enhancing visualization by all the means that I have discussed, which is the main aim of presentation, using viscoelastic on the surface as well as inside, use of window illuminator or chandelier illumination can improve your surgical expertise. And of course, doing a small pupillary sphincterotomy in such cases, in cases like this, really is very useful in improving and giving a long-term visual outcome in such a case. So thank you very much once again.
Thank you, Rajesh. That was an amazing talk, which really needs a good clap. I'm going to take questions with their permission of expert panel with him. Do you, now for a central opacity, you say you can do sphincterotomies, but if it's an eccentric large opacities, earlier they used to do optical iridectomies to improve some vision. Is there any role for it or no role for it?
See, if you are doing a cataract surgery, optical iridectomy should not be done because you will have a pseudophakic and a phakic area, and that will create a lot of confusion. So sphincterotomies are, even if you have a peripheral opacity coming partly in the center, you can do sphincterotomy in the opposite side so that you can have a separate pupil so that the patient can have good vision. And just one more point I would like to add here is that we should implant, in 99% of such cases, we should implant spherical IOLs. And some of these patients, or a large number of such patients, do require RGP contact lens for the best quality of vision. And many of such patients, they have 6/9, 6/6 partial vision also after putting RGP contact lens in such cases.
The other question which I want to ask you is that if a patient has a corneal opacity, say he has had history of redness and treated and all that, your gut feeling says it could have been an old viral keratitis. Would you want to treat these patients? And if so, how would you treat them pre-operatively?
Any doubt of a viral keratitis in such a case, any trauma, any surgical insult can cause recurrence.
Yes.
So in such cases, it is always advisable to use prophylactic acyclovir 400 milligram twice a day, and then go ahead with the surgery.
Oh, thank you. For how long? Pre-operatively 1 week before?
You start 1 week before and continue for
6 weeks.
2 weeks,
2 weeks.
not necessarily 6 weeks, because the basic idea is that if
activity.
any trauma, any surgical insult can result in recurrence. So during that period, you have to cover up with the prophylaxis of acyclovir.
Thank you very much, Rajesh. That was a lot of
Thank
learning. Wonderful set of videos.
Thank you.
We shall we'll go back to our earlier sequence. We now invite Dr. Sudipta Mitra, who's a senior consultant at Silverline Eye Hospital, Kolkata, and a very dear friend. And I'm sure she's going to tell you today why women rock nowadays. So she is going to talk on enhanced monofocal clinical experience. On to you.
Very good afternoon to all of you, and thank you OSARC under Dr. Chitra Ramurthy ma'am and OSWB under Dr. Sugato Paul for having me here. It's an honor to be here in this August gathering. And the topic on which I'm going to talk today is enhanced monofocal clinical experience. I have no financial interest in anything that I'm going to say today. Well, what do we think when we think of an ideal monofocal? The features and the benefits. The features IOL, which would have a spherical aberration to essentially 0, so that we get a sharp quality of vision. low induction of chromatic aberration, so we get high image contrast, less amount of glistening or no glistening rather to reduce light scatter, and less capsulophimosis so that there's no decentration and minimum degrees of power. And all this for a high quality vision as a result of insertion of the monofocal lenses. Now, what are the advantages of a monofocal? Well, in a monofocal, not only can the spherical part be corrected, but also astigmatism can be corrected, which can enhance the outcome. Better vision in low light conditions, if we consider with a multifocal lens. A monovision, which can be by installation of two different lenses in two different eyes. So the advantages of monovision can be to tackle both short and long-sightedness at the same time, and the best way to reduce the need for glasses, even if we are opting for monofocal lenses, can be obtained through this monovision. But there are some cons as well. The post-operative, the patient can only return back to get a vision for distance. But because of the loss of accommodated power, patient has to rely on glasses to do work at different other distances. The post-operative life thus does not become very convenient. Patient has to adapt to it. And the monovision that I just talked of gives distance vision in dominant eye and near vision in the non-dominant eye only. But there is nothing as intermediate vision that the patient gets. So how close can we see with a monofocal IOL? Well, we can see from 1 meter to further distance. And after 0.8 meter, the visual acuity actually drops. So that's a minus point. We think monofocals are actually suitable for patients who are willing to wear glasses for near vision. So what are the options? Well, multifocals. But we've been seeing over the years, I'm sure many of us here who are constantly using different type of multifocals, there's a lot of research with a focus on improvement. Now, why this is so? Because there is no agreement on the strength of different type of multifocals. And there are three major controversies. First of all, is it worth the expense that we do in a multifocal after there's a loss of contrast sensitivity? Whatever IOL we are putting, a trifocal, a EDOF or whatever, there is always a loss of contrast sensitivity. We all know, whatever may be the percentage. So is it worth the expense? Second, whether it is possible to really get the full range of vision. I am very sure maybe it's different in hands of skilled experts, but I'm very sure that most of us must be having one at least unhappy patient where patient wants glasses even after a multifocal. And third is how to grasp the best strength of a multifocal, which one to insert in which patient, a trifocal in which, a EDOF in which. So that is the main part, which is a controversial when we are doing a multifocal. So I'm not against multifocals, but these are the points we have to consider. So just to enhance the monofocal vision, to defy the monofocal conventions with a revolutionary IOL, I'm going to talk of extended range of vision IOLs. Now, these IOLs leverage a proven IOL design. They are of refractive technology with no rings, no zones, with higher order sphere surface, and visually indistinguishable from the single piece IOL. They have the same base geometry and they reduce the spherical aberration to near zero. Now, regarding the design, since this is on technology, IOL is not based on zonal design as is shown here. As you can see in this, this is the zonal design, but it is based on spherical aberration design. And there is a increase of power from the periphery of the lens to the center. And if look at the periphery of the lens of a monofocal and an extended range of vision, we'll see it's more or less the same. Only the center part, there is an increase of power. So this is how it actually looks in a monofocal, and this is an extended range of vision, monofocal IOL. The added advantage what we get is it provides intermediate vision, which is comparable to a spherical monofocal IOL. And this is the extra edge that we get. Besides that, the distance vision is comparable. The photic phenomena, the glare, starburst, whatever it is, are comparable to the monofocal IOL in the same platform. And it reduces the spherical aberration also equally. Now, coming to the technology, I'm not going to actually bore you with it, but the technology that they say is the higher order sphere. Now, we know this always brings some higher order aberrations, but here they say it's not there. Why? Because the sag, which we all know, is responsible for the asphericity that is induced whenever a surface is made aspheric. The sag or the sagitta is most important. So this is how it is tuned such that the desired power profile is obtained. And so a higher order asphere, even after being used to define the complete surface of the eye well with one formula, and there is no abrupt change, no zones or steps. So there's a smooth, continuous increase of power from periphery with continuously changing shape in the central of the lens. So that's the technology. And if you can make it out, this is dotted lines. There's a central part, so which is comparatively of the same thickness. The difference is so small that does not affect the general shape. The increased power of the eye well is in the center of the lens, and thus which is caused by a local increase in curvature. Both lenses have same thickness in the center, as I said, and this is the dotted line which makes eye well extended range of vision. So what we actually get is a bigger, sweeter zone. So this is the light line is of that of extended range of vision eye well, and the darker line is that of a simple monofocal eye well. These are some of my references. I have no financial interest, but this is a study which is shared from Johnson & Johnson, which says it gives good vision under low contrast. So what we are aiming, please don't look at the percentage. We are looking at something extra from a monofocal to an extended range of vision eye well, and this is what we get. 20/20 and beyond distance vision under low contrast conditions. This is what is important, and this is why I'm talking about this enhanced monofocal. And the rest of it, the binocular vision, the contrast sensitivity, no statistical difference in the halos, glare, starbus. I have already talked about it compared to the monofocal. Now, coming to the clinical experience, why do we need this excellent range of vision? This is the reason for driving. As you can see, you can drive even without your specs if you have this extended range of vision IOLs, and reading price tags when you're shopping and you don't have your glasses, watching TV. Nowadays, we are mostly indoors, cooking, eating, playing cards. You can pursue your hobbies well, like playing piano, even without instruments. And this is how we have to adjust when we are not having a extended range of vision, to when we are reading tablets, when we have extended range of vision IOLs, and also getting down the stairs, especially for old people who have to avoid specs for this. Now, this is a surgery, and this is an experience of a surgeon where extended range of vision IOL. If you look at the design, first of all, let me tell you, the cartridge is the same size as a monofocal IOL, so there's no extra effort which has to be given. The same way it has been loaded. And if you look at the IOL, you can never find out if it is a monofocal or extended range of vision. No extra effort is required. It is smooth delivery and it's excellent. Of course, this belongs to a particular company. We also have an Indian company for it, and it unfolds in the same way as a monofocal IOL of the same platform unfolds. So everything is exactly the same how we do a monofocal. It is just an extra edge in the visual part. So now this was a particular case of mine, which I would like to share with you with permission of Chitra Muthu ma'am. This is a patient's talk. What I'm sharing is 58-year-old lawyer who was given a extended range of vision IOL. He was a tall man, of course, and with a history of glaucoma. So we could not get rid of this part. So we did not give him a multifocal. There was a history of glaucoma in the family. And this is what he discovered, that he does not require spectacle for his professional work. He is still wearing spectacles, if you please notice. So he has power in the other eye. He has power for very near reading, but this is what he says. Can you hear that? Just a second, please. Sound excuse me.
While she's getting that thing ready, I have a question for the expert panel. Would you think that the enhanced, all that she has said, let's be realistic. I think it is just a very good monofocal IOL with some extra near advantage. So would you want to use this enhanced monofocal IOLs in glaucoma patients or retina patients with some micro monovision correction? Or you feel it has a larger scope of role? Anybody on the expert panel? Yes, Dr. Sudipta. So, okay, yes. Passing the parcel nahi hai. We all want your right answers.
Yeah, the biggest advantage of the ions is the lack of loss of contrast.
Yes.
And that obviously is helpful in the eyes with a compromise like glaucoma or a retinal. Whereas we cannot use those lenses, the actual EDOFs or the multifocals
Yeah.
in those situations. So there is a possibility of using this group of lenses in the glaucomatous or the retinal situation.
Yes. So in patients where we cannot place a multifocal but want to give them a little add, then we can use these lenses. There is again a small change.
The sound, please, if the sound is connected, but please the volume, please. Khane deya nahi.
What you spoke for 10 minutes has convinced us to go for your enhancer. We don't care about that man. Let him be.
Correct, that's right.
Everybody.
Probably we can proceed.
Dr. Ajay Paul is now as if he's going for a race now. So he told me to bring his talk forward. I wanted him to hear other good speakers, but it's our loss.
I've heard everybody. Don't worry.
Everything, yes. So
Thank you.
I've
Thank you
already
very much.
introduced Dr. Ajay Paul in the morning when he had not come in. And we look forward to learning a lot from him in flat and challenging situations. On
Thank
to
you,
you,
Dr.
Doctor.
Chitra, Dr. Satyajit, and Dr. Shugoto for having me in this session. I'll be talking on a subject or a machine which I suppose only 1% of them use it. I see some flack surgeons here, but then we'll be showing some difficult cases which is also applicable for small meat. I have no financial interest. Shugoto should be here. Ciao.
While we are, if Dr. Jayanshu, are you ready with your presentation? Oh, both of them are in the front.
और इसमें लगाओ नहीं लैपटॉप ही चाहिए
आप आ जाइए हाँ
डुप्लीकेट नहीं करते लूज कनेक्शन yes
okay
thank you. I'll be speaking on difficult cases. I have no financial interest. As you know, flax has emerged as a useful adjunct, especially in challenging cases. So capsulorhexis and nucleus management is helpful in these challenging cases because of its reliability, predictability, versatility, and variability. Now, first, straightforward, go to this subluxated cataract with vitreous in AC, a traumatic cataract. As you see, I have done the flax here. There's a vitreous here, so I have plucked it with high molecular viscoelastic. I've taken off the rhexis. Now this has helped me because the tilt was minimum in this case. I've got a good round rhexis. But how it has helped me because I've got it right at the position where I want it. I've got the visco dissection. I'm doing it. I'm straightway going with the capsular forceps. I know there's vitreous here. So right now, as is my way of doing it, I do little bit of, again, continue with my visco dissection and then go with the CTR right in the beginning because I want to stabilize this back before I go because I know there is vitreous here. Once I go in there, so bimanual technique, I just put in, so got that lens. And then this is a soft cataract I have made into 4 quadrants. So it's just an easy right down the walk down the park. So I just go ahead and remove those nucleus, whatever I call it, a bit of cortex. And once I've done that, I go ahead with removal of the cortical matter. Now I see this whole lens is moving. You can see the CTR there. CTR is gone. So I continue the vitrectomy. I realize it. And then I put in a bit of triamcinolone to clear that vitreous that is popping out by cut IOA method. And then once I've as we had seen last year, because whatever vitreous is popping out, I just need to clear it first. And then once I've done that, the CTR goes back, and then I try to go in, and still I see that the vitreous is still popping out. So I thought that I need to put the CT segment right there. So there goes my CT segment, and the usual way, what we all do, the technique there, I push it, and then the railroad technique goes in. I just need to get that CTR and the bag right in the center before I remove those cortical matter over there. And though the flax has helped me to get the rexis right in the center and got those cortical, the cortex and the nucleus. So I continue with the vitrectomy there. Once I've done a little more vitrectomy, then I go in again, put that CT segment, center it, and then tie it, give us just a single knot there, and then continue with my, as you can see, I just pull it, got it centered. Once I've got it centered, see, I just put a knot there. Once I've done that, I go and remove this rest of the cortex that is there. It's just a tangential way, because once you have the CTR there, it may be difficult, but just go and swipe it sideways, go to the center. And once I've done that, I've got the lens right in the bag. And once I've got the lens, because many a times in these cases, I do put a multi-piece lens with a optic capture, but in this patient, I went and did put a because I thought that this is not a progressive one. This was a traumatic cataract, traumatic subluxation. Once I've done that, so end of the surgery there, I've got to finish it, and I tie it and finish it. Now, this is again a case of nanophthalmos. We had talk of so much of biometry. Look at it, how I have gone wrong. This was a plus 18 diopter, 18 diopter spherical. This lady was wearing 39-year-old. Look at this, 15.87 is the axial length. I need a 60 diopter of lens. So IOCare came to our help. They did manufacture one lens, and then I'll be coming to it how we went with the flax, because flax machine, it has the inbuilt, there is some curvature that is already there, but in this machine, as you see, the corneal and corneal anterior dome apex doesn't fit with the whatever the message is fed. So we go in manually, just see how we are going in manually and fixing that. Just yeah. So that's it. The anterior corneal curvature there, we put it manually. This both horizontal and vertical, and same thing for the posterior corneal, because that's what the machine identified it initially, but we have the option of doing and fixing that all manually, because all else the laser will be fired somewhere different and a different zone. So once we have done that, once we have followed it, so we just go in for a simple 4 quadrants. There's a lot of lateral movement because the eyeball was small, and that's it. Once we have done that, we'll just go ahead with the just a 4 quadrant, and once we have finished it, you can see this is what we landed up with. This was an extremely shallow anterior chamber. I just stained it to get that to see, and just took out that. This is a soft cataract. See, we had done a good rexis there. The rexis went off. I thought that we may not have a complete. Go ahead with the visco dissections. Look at it. I'm working right in the beginning at IOP 40, but as the surgery went on, I saw that there was a lot of thrust. I had given a mannitol in this patient, and then started working at IOP 60. And just as we are going ahead with the surgery, the AC was becoming more, so the posterior capsule was coming almost near the, and on a tip, I was almost near the cornea. So I just fearing that I was using high molecular viscoelastic also. Then I was working at 70 IOP, and that's when I finished the surgery, and then putting in the lens. Again, I put in viscoat. Well, I have no proprietary interest, but then viscoat is in this. And look at this lens, especially it's a Rayner design lens, and it has got a button of 60 diopter. I don't know what would be the aspheric. This was first time I was using. I think some of you might be having some experience. So look at, I'm trying to put the lens, and somehow I see I cannot, though I put in viscoat, but I'm not getting that space. So I just place it there and gradually just tucking it in. The rexis still kept on, and just tucked it in. The inferior thing went off. There was a lot of thrust, and again I put in those this coat there, and then The trailing haptic also goes in, and there it is. Just stabilizes center, so there's hardly any space. All this time I'm working in viscoat in the anterior chamber. Once I've gone this, you can see that disc over there. And just at the end of the surgery, I thought that let me do a iridectomy. I think we've done an iridectomy here. There is the iridectomy, and there, and then the surgery. And this is post-op day 1 and post-op day 7. There was a little bit of corneal edema that cleared up. And look at how the angle opened up from 27 degree, almost 44-50. The iris fell down. And fortunately or unfortunately, you can say, in spite of using the Barrett's formula and everything, we ended up with -7. That was the first, within first 1 month. The patient again regressed, is now in -3 or -4. It will regress to -3. Now we are thinking what we'll do in the second eye. Second eye I'm supposed to do on next month. So we have just minused it. So it was 60 diopter. The same thing. We have now planning to put around 53 or 54 diopter in this lens, because all those measurements, I mean, didn't work. The Barrett's and everything, which still end. Now this is a white cataract subcapsular. This is the last case I'm showing. See, did we see this is a fibrotic, the flax done. Look at it. See, this is the fibrotic cataract. The whole fibrous subcapsular fibrosis is there. We're trying to separate it, and see the fibrosis part has cut here, but it has not cut totally. Then we decide that we need to dissect the anterior capsule, the rhexis margin. There we have dissecting it out, gradually dissecting it out. So there it is. Once we have done that, we have just cut that the capsule, the fibrosed area there. And once we have done that, we have got those all those broken up nuclear material with the femto. And once we have done that, it becomes easier working at IOP 50. Once we have done that, see, and then at the end of the surgery, try to again negotiate that fibrotic band, and there we just try to cut it, and then we realize that probably would not be able to do anything about that fibrotic band. And then again we try to put it and cut it at the rhexis margin. Once we have done that, and put the lens in the bag. Thank you. I just showed those three difficult cases.
Wonderful surgical demonstration. While with him on stage, the next speaker.
Just one question.
Yeah, one question.
One, for the nanophthalmos case, what was the visual outcome, post-op visual outcome?
Which one?
The nanophthalmos case?
That I said, patient ended up within the first
Yes.
1 month, it was -7.
No, with vision, what was the
The
vision?
vision is around 612.
Oh,
That's what, because that's why. So she had a macular OCT shows a bit of, macular is
One
not that.
question I have is, you have used capsule hooks in this particular case.
Which one? The first one, the
First
subluxated one.
Did you feel that the integrity of the femtorexis and the manual rexis was any difference at all?
There's no difference, no difference.
The second question, the expert panel or any of the senior
Just-
doctors can tell, in the non-ophthalmic eye, if the sclera was also thickened on a B scan, would
We-
you all suggest that a sclerostomy is mandatory or not? I want the answer from all the experts here in the audience.
We did consider that
I-
option before, and then took some opinions, and they
Yeah.
said you can just
can
put a
do
mannitol
without
and
it,
go
yes.
go ahead with it.
Never considered so far. It definitely, if one eye has a history of effusion, then the second eye probably need to do a sclerostomy.
So it's not mandatory.
Mm.
Yeah. The different trials have also
Yeah.
said that with sclerostomy and without sclerostomy, the
The
results
results are
similar.
the same, similar.
Same.
Putting a
One more-
mannitol is what maximum we could do.
One more thing is the disc was normal in this case.
Yes, this
Disc-
hypermetropic
yes,
disc can.
This was normal.
Yeah.
So regarding the biometry, just want to mention that Barrett sometimes ended up with hypermetropic when myopics are priced. I think the Olson formula is better in that case, because
The-
that
we-
predict the ELP much better than
No, we have
Barrett.
we put the Olson in the other eye.
Yeah.
The same axial length is coming to 54 diopter.
Yeah,
So
exactly.
we'll be putting in.
Exactly.
We'll be putting
Olson.
in 54 in the other eye. That's what they are going to give us the
Thank
next.
you,
lens.
thank you. Superb
Thank you.
presentation.
Thank
We
you.
shall now go on to our next speaker, Dr. Jayanshu Sengupta, who's a senior consultant at Priyamvada Birla Arvind Eye Hospital, Calcutta, and he's going to tell us more on the EDOF lens options. which is something very, very important for us to know, and which is actually what has come close to replacing maybe the trifocals or maybe an equal stand.
Thanks, ARC and OSWB for, yeah. Hello, audible, right? So thanks, ARC and OSWB for allowing me to present on this podium. So today we will be having a small talk on EDOF-IL options. So mine is not changing, right? So grossly, the presbyopia correcting lenses are of three broad categories, as we all are aware of. The multifocal IOLs, which include the refractive and the diffractive designs, the extended depth of focus IOLs, and the accommodative IOLs, whether they're intracapsular or sulcus fixed. Now, the origin of the concept of EDOF is not with these lenses. It was way back in 1984 when an apparent accommodation and depth of field was related with the related to the pupil diameter. And in today's world, the role of EDOF technology lands in giving us a decent distance vision with a good intermediate vision and a workable near vision. So if we look into the basic optical principle, what is happening is in a multifocal lens, we know we create multiple foci, but in the EDOF, we are actually having an elongation of the single focal point, and that is actually helping us to increase the depth of focus. And this way, we are eliminating the overlapping of the near and far images, and that is what is helping us to eliminate the halo effect as is observed in the traditional multifocal lenses. Also, with the because we are creating a continuous range of focus without a asymmetric IOL power distribution, we are avoiding also the secondary out of focus images, and that actually is reducing the photic phenomenon that is associated with this group of lenses. So basically, it's a perfect balance between these three things: the quality of vision, depth of field, and the dysphotopsia. So if we are increasing the aberration magnitude to increase the depth of field, we will land up with overlapping of the perceptible images, and that will actually hamper the quality of vision, and in return we will have a compromised distance vision. So the models on which these lenses work upon are the spherical aberration, as we know from the central and peripheral part of the lens, the chromatic aberrations, that is the different colors of the light, they focus differently on the retina, and the pinhole effect. So these are the basic models on which the EDOF lenses will be working upon. Now we have, based on these optical models, nowadays we can call some group of lenses as pure EDOF lenses, where there is an elongation of the focal point, and which helps to eliminate the overlap of the near and far images. On the other hand, we have the hybrid EDOF models, which are actually having a low near at. So there is a multifocal lens, and that is having an EDOF component in it added to it. So they can be either diffractive, refractive, or the diffractive and refractive variants. So here the target is to decrease the halos and glare by decreasing the near optical power, and to replace it and to substitute with a little bit of EDOF effect and give a compromise between the true multifocal and the true EDOF lenses. So the technologies on which these lenses are working upon are the small aperture design, the bioanalogics, but they are not they're actually withdrawn currently. We have the diffractive and the non-diffractive, and in the non-diffractive, we have recently the wavefront reshaping lenses which have been added. So in refraction, as we are seeing, we are creating focal points in the zonal asphericity. We are changing the power gradually within the region to shift the focal points, and there we are having light bending because it is changing between different optical media, and we are controlling the speed of the light. In the diffraction, we are creating we are splitting the light into multiple foci, and in the wavefront reshaping, the wavefront is actually stretched, and it is not, the light is not split, so it is actually stretched, and we are having an extended focal zone. So the pure EDOFs, we have the Minivel and the Vivity Alcon, which is based on wavefront shaping, and the hybrid EDOF, we have the diffractive, which is the Techni Symphony, which has a posterior achromatic diffractive surface. And then we have the hybrid EDOF in the form of refractive, which is the suprafob from Apaswamy, and we have the hybrid EDOF refractive diffractive variant, which is the synergy from Johnson & Johnson. These are the common lenses that are available. There are a host of other lenses in the platform. So here we will just go into the little bit more into the reference shaping. So what is happening is we have the surface transition elements of 1 micron high, and this actually creates a wavefront which stretches the wavefront and creates a focal range at the back of the retina. And this way we are stretching and as well as shifting the focus from the back to the forward of the retina. And that is what is giving us the good intermediate vision without compromising the distance vision. And because we are not splitting the light with the help of diffraction, the utility of the light utilization is best amongst the all group of lenses, all group of multifocal lenses, and it is actually comparable to the monofocal lenses. So the clinical performance, we can say that till date we were worried about the pupillary, all these EDOF lenses were dependent upon the pupillary size, except the wavefront shaped lenses. These lenses were susceptible to tilt and decentration. Now the new generation of lenses are more tolerant to the angle kappa. We are obviously, though the incidence is less, but still there are possibilities of glare under mesopic conditions with even with the EDOF lenses. The biggest question was the monofocal like CDVA with the EDOF lenses, but this has also been addressed with the new generation of wavefront lenses. So the only concern that remains is, as has been pointed out before, the loss of contrast with all these group of lenses, and that is the primary area of improvement that is to be taken care of. So we now can have a good or excellent distance with a good intermediate and a functional near, but it is not for prolonged close-up walk-up at close range. Thank you. Thank you for patient hearing.
Thank you very much, Doctor. I want you to be there in this question which I have to ask, since you are the expert panel too. Would you suggest these extended depth of focus lenses in post-LASIK eyes, keeping in mind that the spherical aberrations and the chromatic aberrations are being taken care to a better extent rather than the trifocals?
Yes, it was initially, I was also thinking that whether we could use these lenses in the post-LASIK situation. So I went with a couple of, theoretically it is true that we should be able to use the EDOF lenses in post-LASIK eyes, particularly the wavefront reshaped lenses. But in the practical experience, we found that all these patients had a very good distance visual acuity. They had they had an intermediate vision at 90, accepting around 1, and they did not have any working near vision at all. So,
but actually, Synergy has a near vision at 33
it has a
centimeter.
near vision add. So it has a near vision add. The Synergy is again a hybrid lens, is a hybrid multifocal lens, which has a EDOF. It has a near add as well as it has a refractive component. So if that is taken into account, because the posterior corneal astigmatism is also changing as simultaneously, it is very difficult to have a predictable outcome with this group of lenses. So in whatever experience I have had till now, I am not comfortable as yet in using any of these lenses in the post-LASIK. But obviously there are many reports.
Challenge because IOL path calculations could rarely be off even with the best of formulae. But in my experience with the Synergy lenses, they are quite happy. They are drivers by profession, and they don't want trifocal with the diffractive rings disturbing them. And they want to do a lot of reading. They're happy. They are all being correspondents and in big schools and doing very well professionally. They are quite happy.
Yeah,
but
there
then,
have been
having
reports.
said that, I believe that the Indian multifocals are also doing superbly well.
Yeah, absolutely.
So they are
Absolutely.
very happy. The trifocals and all that is also very good. I think we are on the same plane only.
Yeah.
Actually. Yeah. Thank you.
Thank you.
We shall now go on to our next speaker. Who's a senior consultant at Disha Eye Hospitals and Research Center, and he's going to be talking on trifocals versus continuous range of vision.
Ah.
What is that in each differ? I think he is going to bring out the points which we were just superficially hinting at, and we will get to know the right answer.
Good afternoon. Thank you, AIOS ARC committee, and especially Chitra ma'am and Satyajit for including me. My topic is trifocal versus CRV. What is that? Each offer. So the CRV, this is a newly introduced in the market. The mechanism of action, how it works, basically not clearly understand. And I have no financial interest to disclose. And I have a disclaimer also. I have a limited knowledge as it is a new lens, and lack of studies and publication, and too much of bias studies or sponsor studies. So the concept of multifocal started in 1983. That's Kenneth J. Hoffer. He saw a decentered IOL. That IOL has a two part. One is the aphakic part and the pseudophakic part, and he can from the aphakic part he can see you can see the near portion, and the phakic part, pseudophakic part, you can see the near, and the aphakic part is can see the distance. So first multifocal came in the 1983. This is a fusion of two optics plus 18 diopter and plus 20, and the quest carry on. And early of this century and 2005, there is a multifocal started, and there's a first started the Restore +4, and then they come with the +3 and +2.5, and gradually it is realized that only the near connection is the correction of vision is not important. So with the changes of lifestyle change and quality of vision, which is required from near to intermediate distance, and one 6 feet 8-inch long, he needs 80 centimeter, at least one arm length for reading. And even in the 5 feet 6 inches long, if some work like in driving, seeing the dashboard, he needs 1.5 of his arm length, that is 80 centimeters. So you need to have a continuous range of vision for your better quality of life. So the quest started trifocal. After the bifocal, the the fine vision launched the physical lens in 2010. After then, Zeiss launched in the 2012 with the first trifocal. These two lenses was underestimated that time, but the momentum gain when there is a launch of Alcon, launch in the Alcon Panoptics lens in 2005. And that the same year, that's a EDOF lens, that is a Symphony, was introduced. But these all the lenses are basically a diffractive IOL, but they have an over advantage. There is a less chromatic aberration and less photoptic phenomena compared to the previous bifocal lenses or multifocal lenses. And these new lens synergy, which they called it as a CRV lens, continuous range of vision, that launched just a few months back. And I have a limited exposure to the lens, but and there is a limited literature also available, but we can guess some amount of our experience regarding all these lenses. Astigmatism correction in this case of lenses is a very important. There is a published data. Only 5 diopter of astigmatism can reduce from 2020 to 2030. So any type of these type of lens, either you go for the CRV lens or trifocal lens or lens, the astigmatism, addressing the astigmatism cylinder is very, very important, because if you have a little amount of astigmatism, you will not get ultimate result. So trifocal is a basically distant, intermediate, near. This is a standard trifocal, but intelligently that the Panoptics claim this is basically a quadrifocal. It is not a trifocal. That the previous lens, like at least a tri or the EDOF fine vision, they came. This is basically distance, intermediate, near, and the Panoptics, it's basically quadrifocal. That this is and so what is a CRV? It is they claim it is a continuous range of vision. is they have a more than 3 focal lengths, or 3 focal length is not sufficient to maintain the CRV. That all question not answered yet. So is it is a CRV, it is a only the marketing strategy only, or something else? It is like a flax versus robotic surgery. Some claim it is a flax, as Dr. Rajapal shows the surgery. Some market as a robotic surgery. And Chitra madam knows that who are doing the LASIK, the contour axis versus the contour vision. There's some marketing the contour so much that the LASIK become the smaller part. They marketing the contour so much in the, it's already happened last 2 years in the Delhi and NRC area. That is that people understand that contour is the main LASIK. It is not the LASIK, it's the main LASIK. So this is whether this is the only the marketing. Let's see the what is the trifocal set. This is a 2 steps, 2 height, and you can see there's a highlight. This is a 1 step, and this is a half. This is a 3.5 addition, and this is a 1.7 addition. And the Alcon came the trifocal. This is not a quadrifocal ends. This intelligently, because if you maintain these, there will be too much of noise. So they make this strategy they call is a enlightened technology. This is a 2-step basically, and they blunt 1 step. They matches with this. So actually, what happened in the trifocal is the distance is 0 near. If we consider x 40 centimeter near and the 80 centimeter intermediate, then distance is 0 definitely. And they divided the area 60, 40. 2/3, that is a 60, and 1/3, this is a 120. But, and they chopped this as the 120 is actually not necessary. This just the chop this area, this flatten that area and transfer to the distance. And that's why the panoptics lens using the light 88%. What now go to the defocus curve. If you see this, the techniques versus symphony lens, that you can see the symphony lens perform well up to the -1.5 to 2, not more than that. This is a logmar 0.2. That is that means a 20/25 vision, and it goes up to the 1.5, maximum 1.75. That is a EDOF lenses. And now you can see the panoptics. This is a defocus curve of the panoptics, and you can see up to the almost 2.75. It is maintained the 20/25 vision. So it is a good enough, and a panoptics also give the continuous range of vision near from 1 to from distance to up to it can add up to 2.75. So if I go for the synergy, so you can see what they claim, they can maintain the 20/25 even crossed +3. That means it has a near vision at that 30 centimeter. So in my experience, I have so far implanted 68 Symphony. I have a Panoptics fan. I have implanted 164 Panoptics. Synergy only 21, and at least a 122. So far, I understand the distance is equally good with all lens, and I will give the plus more distance in the Symphony, Panoptics, and Synergy, and near vision for Symphony at the 40 centimeter. Symphony does not have the, until unless you do the monofocal, keep some myopic refractive error in the distance. Panoptics has a good near vision as a 40. Synergy has a good near vision as 30 to 35 centimeter. That is no one actually provided so far. And at least has a good near vision as a 35 to 40 centimeter. Intermediate, I think this is a fantastic lens. Symphony is a fantastic in the intermediate. Panoptics also up to 42 centimeter, very good. But in Synergy, in my experience, is some kind of drop at the level of 50 centimeter. After that, this is a very good, but I feel there is some drop in the vision at the level of 50 centimeter, but it is very good to 52 centimeter. But this is at least a trifocal. This is 70 to 90, even 100 intermediate distance.
And this is a very good for housewife, therefore the kitchen work. And this is a very distance where you need 100 centimeter. So this is my experience for so far. I think I want to know more about who are using more CRV and have a synergy lenses. And this is so far only one study is available that is published in peer-reviewed journal, but all are other than this, all are sponsored and biased. That they have the same experience. They have this quite a panoptics. They have compared the head-on panoptics versus synergy. This is a almost same result, but the synergy has a much nearer correction. That is at the 30 centimeter. Thank you so much.
Thank you. Wonderful analysis of the whole thing. And I totally agree with what you say that that extra near is there, but the trifocals are wonderful. And I think the results, patients being very happy with the multifocals today is largely because of our improved biometry, that we are able to very accurately implant the right
Exactly.
IOL.
We have a good biometry machine, and we have
Yeah.
tried now, in many cases, we have tried multiple. Previously, we never tried that
Yes.
cases.
Yes. Thank you. Thank you very much. We shall go on to the last speaker of the session, an extremely capable surgeon. And I think we should not go for lunch, hear him and then go for a lunch. And I would also be very obliged if all of us come back soon after lunch to hear all those very extremely dramatic, challenging cases which are going to be shown to us in the next session. We should watch that. So I would invite Dr. Harshul's talk would be on the Zoom link. Dr. Harshul is the member ARC Central Zone, is an extremely prolific, versatile surgeon and his gifted hands. And he's also the chairman of the Scientific Committee of the Rajasthan Ophthalmic Society and making great inroads and transferring science in that region. And he is particularly famous for the amount of impact he has made in life beyond ophthalmology, bringing out the huge talent which is there in the ophthalmologists of our country. So let's hear from Harshul about how he would play his phaco parameters for the fullest. Harshul, your 4-minute video we will take in the next challenging case session because we need more attendance in the hall. People have gone for lunch and I want that video to be seen by many of them. Okay?
Yes, ma'am. Yes. Can you hear me, ma'am? Am I audible?
Yes, yes.
Okay. So at the outset, I'd like to congratulate and thank entire West Bengal Society. And thanks to Chitra ma'am and Satyajit bhai for organizing such a nice event. It's so nice to see good friends like Dr. Arup, Dr. Sunil, Dr. Ajay Paul, and everybody there in the hall. I couldn't be there physically, but virtually I'm there. So the only thing is I'll be missing the delicious Bengali sweets there. Okay, so let's move on to my topic, which I'll be speaking on the phaco power modulation, the use of the phaco power modulation in the modern cataract surgery. We all know that the goal of cataract surgery in the modern cataract surgery is to perfection in nuclear disassembly, performed with just the right amount of the phaco energy, not too much and not too little, because excessive ultrasound energy can result in endothelial cell loss, corneal edema, and wound burn. So we all know that in phacoemulsification, the frequency of the all the phaco handpieces remains same. It varies from 28.5 kilohertz to 40 kilohertz. But what varies is the stroke length of the phaco tip needle. And this variable stroke length, depending on the percentage which we set in our phaco machine, it causes the mechanical impact on the nucleus, cavitation, fluid and particle waves. And so basically the heat is created in the eye, which can damage the endothelium and other ocular structure if not used judiciously. So the single most important factor in achieving clear corneas and sharp vision immediately after cataract surgery is the amount of phaco energy delivered in the eye during procedure. So this we can modify by using phaco power modulation and to minimize the phaco energy use and maximize the efficiency of cataract surgery. So let's see what's the difference in the various type of the phaco settings there. So in the continuous, we all know in the phaco continuous mode, as the surgeon passes on the foot pedal position 3, the energy it linearly increases from to the maximum level which is set. Whereas in the phaco pulse setting, if we press the foot pedal to position 3, there are pulses so that the energy is, basically is decreased. The amount of energy delivered, it depends on the duty cycle, which I'll be talking about. So, but it also linearly increases as we keep on pressing the foot pedals. So there are pulses, but the energy also linearly increases. Whereas in the burst mode, the phaco power remains same in each of the burst. But as we press on the foot pedal position 3, the duration between the burst, the pulses, the burst decreases. So that in the end we have, when we press down on the foot pedal completely, we have the continuous energy delivered in the eye. So let's see that in the pulse mode was first introduced by White Star AMO machine to decrease the energy delivered in the eye. So all the surgeons who are starting phaco or who are also in the beginning of the career, they should know the concept of the pulses and burst and hyperpulse and all those things, because it's difficult to tell each and every setting, because every machine has got different settings. But if you know the concept, you can use these settings in the concepts in your machine. So basically in pulse mode, we can set the pulses depending on the machines which we have. But basically the pulses, if we suppose we have 2 pulses per second, it means we have 250 millisecond of pulse, which is on time, and 250 millisecond of off. Again, 250 millisecond on and 250 millisecond off. So these are the 2 pulses in 1 second. So we have, 50% of duty cycle is there. That 50% of the time it's on, 50% it's off. So if we have 4 pulses, so we have 125 milliseconds of the on and off time. If we have 10 pulses, we have 50 milliseconds of on and off time. So that's how the pulse mode is there. But remember that increasing the pulse per second, it does not change the absolute phaco time, because that will remain same. Only thing is that the number of pulses will increase, but the amount of energy will remain same if we increase the pulses. So amount of energy changes with the duty cycle. So by default, the pulses, one duty cycle is the on time and off time. That makes one duty cycle. So 50% duty cycle is like 50% of the time it's on, 50% it's off. So we can change this in modern machines. We can change this duty cycle to 20% or 30% or 40%, whatever like. So if we have a duty cycle of 20%, it means the 20% of the time the energy is delivered, and 80% of the time there is no energy which is delivered. So there's a cooling period which is there. So, but in both the cases, the pulses are same, 4 pulses per second, but duty cycle is different. So in the traditional pulses were in previous machines were till 20 pulses per second, but we have machines now which have hyperpulse mode, which can go up to 125 pulses per second. So how we can take advantage of this pulse mode is, as I said, when the energy is delivered, that causes the jackhammer effect, and it repels the nuclear pieces. But the off period, it brings the pieces towards the phaco probe. So if we keep the pulses low, it can help us in holding the lens during chopping. So if you have to do chopping, direct chopping or like this, you need pulses, lower number of pulses. But when you need to sculpt, or you want to remove the quadrants, you want it to work faster, that time you want more pulses so that it acts like a saw. Now coming to the burst mode, as I said, in burst mode, the difference is that the energy delivered with each burst is same. It doesn't increases linearly, but the width of the burst, the off time, it decreases. So how we take advantage of this is that in the burst mode, if there is a higher off time, it's good to hold the nucleus again for chopping or bringing material in the center. Whereas if you want to do sculpting, it's good to press the foot pedal more so that we have the less, spacing between. We can sculpt it nicely. So this is it shows is the continuous phaco energy which is delivered, and this is the pulse mode. So in pulse mode and hyperpulse, the number of pulses in hyperpulse it increases further. So the cooling period is more in the hyperpulse mode, and heat buildup is way less than the normal pulses. So again, looking at the duty cycle, as I said, the on time is where repulsion is there, and the off time is where we want to aspirate the nuclear fragments. So that's how we use this. Then there are other ultrasonic modalities, like in machines we have torsional and elliptical and all those technology available to decrease the amount of the energy which is delivered in the eye. Just quickly have a look at the how I use this. So this is the brown black cataract here. So I go in this center, and here my pulses are less here, and I'm using pulse mode here, so that when I hold the nucleus, I need a good hold there for chopping. I make a central hole there and hold the nucleus. See how effectively I can hold the nucleus and chop the entire nucleus in one go, and then I get a good crack in the anterior posterior. So this hold is important, and to get this hold, you should bury the phaco tape nicely in the nuclear, and you should change your phaco settings properly so that you have a high vacuum and a good grip there. Again, chopping it into smaller pieces. So what you need, of course, is the ultrasonic power modulations. And apart from that, you need to use the technique of chopping, which is least damaging, like you should do direct chop for nucleus disassembly, which causes least energy delivered and least trauma to the endothelium. Again, so it's divided in smaller pieces, and look at the end of the emulsification, look at the corneal incisions and cornea, everything is, of course, you need to use chondroitin-based sulfate OVD to protect endothelium. And you should always do specular count if you have the specular with you. And this finishes the case. So I think if we use all the phaco settings which are available in our machine judiciously, we can of course have a wonderful results on first post-operative day. Thank you very much for giving this wonderful opportunity. And any questions, I am happy to answer.
Thank you, Dr. Harshal. Thank you. You have explained in so detail, so well that we don't have any questions. We'll connect with you after a while after lunch for your video on challenging cases. Thank you so much. I would like to thank the expert panel also for chairing this session, and would like to request those who have not had lunch to please have your lunch, and then we'll start again at 2 o'clock.
Thank you so much. Thank you.
Thank you. Thank you, Harshal bhai.
Thank you.
Dr. Subhashish Nag, sir. Dr. Amitabh Bishwas. Dr. R.C. Paul.
I started Capsule access and got my first hiccup. The bed was unstable with gross subluxation.
The session will be moderated by Chitra ma'am, myself, and Dr. Sagnik Surya Das. So we'd like to call the first speaker, Dr. Hari Shankar Nag. Dr. Hari Shankar Nag. इनका शुरू कर दीजिए, पहले लेट हो रहा है.
A gross subluxation was noticed. The remaining bag turned out to be a flat posterior capsule plate with fused anterior posterior capsules in the periphery.
Zoom link चालू है ना? भाई Zoom link चालू है. Zoom link चालू है.
Good afternoon.
Go ahead.
Thanks, ARC, Chitra ma'am and Sugatada for giving me this opportunity. I'll be presenting a case of hard cataract where I plan to
Can't see
do,
your video. Now it has come.
where I plan to do phaco through a clear cornea alone under perivalvular block. After making my incisions, I stain the capsule under air bubble with trypan blue. Then I inject a dispersive viscoelastic first, followed by a cohesive viscoelastic doing the soft cell technique. I initiate my
Life is so much unpredictable that you can't control everything Sometimes it goes asleep, sometimes you get back. But everyone should remember that bad things does not So one should take a deep breath, stay patient, and try to level best to overcome hurdles. A 60-year-old female patient having
Then before going for nucleus management, I ensure nucleus rotation. In this case, I plan to do a modified direct chop where I do a small trench in the center and then do a mid-peripheral chop. I'm using a sharp tip chopper for this procedure. Initiate my trench, then I widen the trench so that I can introduce the phaco tip into the deeper nuclear material. After doing my trench, I rotate the nucleus and trench it little more on the other side. Then I impel the phaco tip into the deep into the nuclear material introduced my chopper and tried to chop the nucleus into 2 heminuclei. I tried to do a multi-level chopping by fixing my phaco probe and introducing the second instrument much deeper into the nuclear material. Rotate the nucleus and do the same maneuver from the other side. Then after making 2 heminuclei, I start chopping each heminucleus into smaller pieces. Every time trying to chop the nucleus as deep as possible so that I can break the posterior plate. After chopping nucleus into different pieces, when I start emulsification, I see that the pieces are still attached to each other at the posterior plate. Since I have a bigger rhexis, I catch hold of the nuclear pieces and start eating from the equatorial side. And gradually, I'm able to continue with my nucleus emulsification. Well, emulsifying the nucleus, I have changed my second instrument and I have taken a dialer. Gradually rotate the nucleus. Since the pieces are attached still at the posterior plate, so slowly lifting up each of the pieces, bringing them at the supracapsular plane, and slowly continuing my eco-emulsification. While doing the last piece, I'm a little careful. While removing the cortical matter, I try to do the tangential pulling of the cortex rather than the radial one, so that it puts less stress on the zonules. I implant the IL under viscoelastic, then do a good viscoaspiration so as to remove the dispersive viscoelastic, and then finish my case. Thank you.
Thank you very much. That was a very daring, wonderful surgery. Excellent.
Thank you, ma'am.
I would want 2-3 questions from the expert panel. I'll ask them all together. Dr. Debashish, Dr. Subhashish Nag. This question is there any role left for divide and conquer in these kind of very hard cataracts or stop and chop? Or is it only phaco chop, direct chop which is needed? Number one. So for the younger people there sitting in the audience, and if there is a case where it becomes, they have not chopped properly, it becomes like a ball of a flower petal kind of thing. How do you manage that? And the third question is, how much of your chopping is longitudinal and how much of it is torsional nowadays? Very brief one-line answers for all three.
Dr. Siddharth Bose. Okay. We
Good
want to
afternoon,
request
everybody.
you, Dr. Harshul Tuck will be presenting before you, and then you can come. Dr. Harshul, you are ready? Take it.
Yes, I am. Yeah.
Okay. Give us 2 minutes. Go ahead, sir.
Basically, rhexis should be large, and I would point out that stain it even if the red glow is good, because you don't know when you are in the soup. And direct chop is the way to go these days, but it is up to the surgeon's choice. And when there is a bowl, you can go in for visco dissection and take it out and do a supracapsular phaco if the need be under viscoelastics like viscoat. And what are the...
How much is longitudinal and what component is torsional?
When you go in for a chop, it should be longitudinal. Don't use for a beginner. I think it should not be a torsional chop because the hole becomes difficult. Use the maximum possible vacuum and go in for a longitudinal chop to begin with when you're doing the direct chop.
Maybe we can just say, just to impale, you make just bury in with
Right.
the longitudinal chop and then move on to torsional.
Absolutely.
Yeah.
Absolutely. ma'am. Thank you.
Thank you. Thank you very much.
Once again, we would like to welcome Dr. Harshul Tuck, our ARC member, very eminent ophthalmologist in Rajasthan. He'll be showing us a challenging case. Go ahead, Dr. Harshul.
Yeah, thank you so much, Dr. Satyajit and Chitra ma'am, for giving this opportunity. So I'll be showing you a case which had black cataract and a thick fibrotic anterior capsule like this. So the problem here, as you can see, that the real problem is to create a good capsular axis and a safe capsular axis in these kind of fibrotic anterior capsule. So I go ahead and stain anterior capsule with trypan blue, and This is under topical anesthesia. And so once it's important that you stain it well. And once stained, you try to go and make a opening from the area where you can open it in the where fibrosis is less. So I go ahead and use cystotome here. Now remember that these fibrotic plaques is difficult to just go ahead and do rexes with the cystotome. So you should always try to use the micro scissors to cut through these fibrotic areas. Because if you try to pull them, it may extend in the periphery. So I go ahead and give a cut here. And this is the area where the fibrosis is less. So I go and try to make capsule rexes here. So it's really difficult to tackle these kind of plaques, and a lot depends on their size and position, where are they located. So we need to make another extra side port here. And again, once I reach this fibrotic area, I go ahead and give a snip here with the micro scissors. So your micro scissors should be curved like this so that you can easily move around the plaque and cut that area. So with great difficulty, I come to the end point here. So this is the last area where again the fibrotic, it's all fibrosed here. So I use a bimanual technique here to give the final cut, use micro forceps to hold this plaque and cut with the scissors. So really these thick fibrotic plaques, they become very challenging. But the good thing is that these fibrotic anti-capsule, if you cut with the scissors, usually they don't give way. They are thick and fibrotic. So you can safely do the rest of the phacoemulsification through the cut area. So this is the final cut which I give here. You can see these are all fibrotic areas. Edges are fibrotic, so they are stronger as compared to the normal rexes. So once I take off this anti-capsule plaque and just make an adequate opening here. Now the next challenge was of course the black and leathery black cataract. As you can see, I go ahead and try to rotate the nucleus, and in that process you can see the pupil, the iris was also a bit floppy and it came down. So the technique which I also use is the drill and chop, drill in the center, weaken the central area, then rotate the nucleus. So weakening the central area makes it easier to chop the nucleus. So don't be in a hurry to go and straight away chop the nucleus, weaken it in the center. And once you have weakened it in the center, then go ahead and hold the nucleus, and you can see I can chop the nucleus into smaller pieces. And once you chop it in smaller pieces, take all these pieces like a piece of cake and this. But the pupil comes down here, so you should always be there in the center to do all your maneuvers. So I'll go ahead and do bimanual irrigation aspiration.
Harshul, we had 4 minutes.
Yeah.
Which is
Okay, so I implant the IOL and this finishes the case.
Wonderful
Thank you very
video.
much.
Nothing mediocre can ever be expected from you. You're just too good. I just have
Thank you so much.
a discussion for the expert panel. These fibrotic cataracts are of two kinds. One which has to be cut with 1-hour scissors and removed. The other one is not done by me, but I've watched a video of Deepak Meghur, wherein he has made a nick on the capsule and gone underneath and peeled the subcapsular plaque from the entire fibrotic area. And once it came off, then it was just a routine rexis to complete. So the subcapsular plaque under the overlying capsule had what had caused it to pucker up like that and look very fibrotic. So he said, he discussed in that there are these two variants, one where you tease it off and one. So what are your thoughts, Harshul?
So the case which I showed, ma'am, you saw that there was no subcapsular fibrotic plaque. It was all at the entire
surface.
capsule which was fibrotic.
Yes.
So whatever you do, you need to cut through these fibrotic plaques. The only
Yes.
thing is you don't have to pull it through them.
Yes.
Otherwise, it may extend in the periphery.
Yes, yes, yes. Wonderful, wonderful. Any comment from the expert panel?
Most important is don't pull it at that point of resistance. Don't pull it. And another way it can be done is using a cutter. Make a small nick and complete it with a cutter.
Yeah, cutter can be used. Yeah, very true. And I also use the radio frequency capsulotomy probe also, which comes with the artery phaco machine. So it also cuts through these fibrotic plaques. So it depends on the situation of the plaque. If the plaque here was central, I could cut, at the edge of the plaque, so I could complete the rexis. Otherwise, if plaque was there at the 4 to 5 millimeter, 6 millimeter, I would have to go through with the radio frequency probe also, you can cut like that.
Yes, yes, yes. Very good. Excellent, Harshul. So thank you.
Thank you so much, ma'am. Thank you. Thanks for this wonderful opportunity.
Yeah, yeah. No, rexis margin, once you cut it, you mean there are multiple nicks. Actually, it is always safer when you are operating with multiple nicks than one nick comparatively. But for a young surgeon, I would say that you go do if chopping is difficult, you could convert it to SICS and deal with the moment.
No, these fibrotic margins are very strong.
Very strong.
So this fibrotic plaque, once you cut through these fibrotic anti-capsule, the margins are stronger. It's not like, it's not like a can opener kind of opening.
Yes, yes. Yes, thank you, Harshul. We shall now go on to our next speaker, Dr. Siddharth Bose, and who's a consultant at Eye Microsurgery and Laser Center at Kolkata. And he is going to show us a very interesting case. Sure.
Good afternoon. I'll be presenting high myopic cataract with 120 degrees of zonular dehiscence on the nasal side, as you can see. I've already presented this case in OSWB OPL, so please don't mind the music and the meme videos that will be in the frame. Audio वॉल्यूम को कम कर दीजिए. Most of the surgery goes really well. This is the main incision. I'm making the capsular rexis here using the forceps. I thought it would be difficult, but I managed it well. Following that, I put in capsular hooks to secure the bag. This was pre-planned before the surgery. After that, it was a hard nucleus, but I was able to chop it nicely, not much of a problem. Since whenever we put any hooks in the eye, the whole system goes up. So to protect the endothelium, we need the viscoat, chondroitin sulfate and sodium hyaluronate combination. The pieces are being managed easily. The case up till now was easy. It's not challenging as of yet. It will be challenging from now on. This is the last piece. Now trouble starts when I start doing the irrigation aspiration. You can see the vitreous starts coming into the aspiration cannula. On top of that, I pull it out also. So I do a little bit of local vitrectomy at the area and I continue the irrigation aspiration. But again, you can see here vitreous is still coming. There is one tag that is always popping out. So at this point of time, I plan to attack from behind with the pars plana scleral port. I did a little bit of pars plana vitrectomy to clear off that area of vitreous. it feels better now. I complete the irrigation aspiration. After that, I put the capsular tension ring into the bag. The hooks are holding the bag steady, so it's easier in this case. I put a 3-piece IOL into the bag now. It's a very thick minus 3.5 diopter IOL. Goes into the bag easily. I think I should have put a segment also, but still you can see the tags are coming out. It becomes a cat and mouse chase at this point. I'm cutting it with the cutter again and again. Again, it is coming. Finally, I could manage to get it all. And the final visco wash I did from different ports. And I finish up the case. All is well that ends well. I'll show you the first post-op day picture. This is it. Luckily, fortunately, there was no peripheral breaks or anything in this patient. So I was safe.
Yeah, it is a very well done case. When vitreous does come, it is always becomes necessary to keep going back and cut whatever vitreous is coming. But surgery got done. It's just that past planar route in a very high myopic retina, the retina is thin, you could have choroidal effusion or choroidal detachment. Was it necessary to go in the past planar when you have already done anterior vitrectomy? Is a thought when I wanted to share.
Ma'am, the problem with this case was I only showed part of the video.
Yeah.
For 15-20 minutes, I was struggling with the vitreous tags. I was removing it, again it was coming back, and that's why I decided to go through
the
past
past planar.
planar.
Yes, I agree.
This was a very beautifully done case and
Yes.
managed very well.
Very well.
But just a very few takes that I think you use triamcinolone acetonide to stain the vitreous.
Yes.
This is one point. Next, you cannot, you really do not afford to hypertony, though the eye is very myopic. So you must have a anterior chamber, tension maintainer, maybe the anterior chamber. I use it in the anterior chamber. Why? Because vitreous is coming from behind. So you tamponade it from the anterior chamber and suck it out from inside, as you have already done a pars plana port. So put the AC maintainer or the irrigation port in the anterior chamber and have the vitrectomy in the posterior chamber. That will make things simpler. Thank you.
Actually, by doing a past planar vitrectomy, the loss of vitreous is less.
Yes.
Rather than a lot would have come in front and the area of dialysis would have increased too. So it's a wonderfully done surgery. I think he needs a clap for being so daring.
Ma'am, one question, should I have put a segment in this case? Because the IOL
No,
was
not
more or less.
necessary. No, not necessary. This is an iota. It's not small area of dialysis.
Just 2 clock or 3
Yeah.
clock hours maybe.
Yes, 120
Manage
degrees
CTR only.
approximately.
We shall now go on because I'm going to rush so that I cover many of you. The next person is Dr. Kushal Banerjee. I think the 4th person should come and stand on stage because we have to finish. Dr. Kushal is from a consultant from Disha Eye Hospital, Kolkata, and we look forward to another interesting case scenario.
Very good afternoon, everybody. It's puja session coming, and it's an invitation with open arms from my little daughter and all of us in OSWB to all the people who are from outside Bengal to come and join us in the puja holidays. I take this opportunity to thank the whole AIS ARC team led by Chitra Madam and Satyajit sir and our own OSWB team for giving me this platform to speak in front of this August gathering. Now, we all are aware of this marvel of human engineering, and also we are aware of the tragic fate it met with. But that day, had there been enough amount of these lifeboats, the story could have been less fatal. Here, we have an 89-year-old, very frail, restless old lady with rock-solid cataract, rock-hard cataract, very poor corneal cell count and phacodonesis, and other eye was FA kick done outside. So straightway started with the plan of SICS with PCIL and CTR. But soon I switched to can opener after getting the feel of the zonular weakness. Then suddenly, when I was loosening the nucleus from the capsule, the zonule started giving in. And the nucleus started dangling down, leading towards the sink. I struggled to lift the dangling nucleus above the iris plane to prevent the impending nucleus drop. Throughout the process, all my instrumentation was parallel to the posterior capsule as much as possible, keeping the idea to least disturb the anterior vitreous phase. After a lot of struggle, finally I managed to lift the dangling nucleus above the iris plane, as I was hell-bent to save this Titanic this time. After lifting the nucleus above the iris plane, I slowly removed with a sandwich extraction after coating the endothelium with adequate viscose, followed by good amount of anterior vitrectomy. Adequate vitrectomy is done to remove all the amount of vitreous from the anterior chamber. Then I followed it up with sclerolimbal side pockets or side ports at 180-degree apart. This was needed to keep my instrument parallel to the iris plane, which is needed for the retrofixated iris IOL implant, which was the changed plan of action. And pilocarpine helped in meiosis and tightening the iris muscle. Once I placed the RF ICL above the iris plane, I aligned it along with the side port, enclaved the haptic notches with the iris one by one. My right one was a little bit more towards the pupillary plane, which led to a little bit of beaking of the pupil. And once the RF ICL and haptics notches were entangled or enclaved with the iris, I checked the stability of the RF ICL and closed the wounds. On the 7th post-operative day, our old Ajji or our old grandmother was quite happy with 6/9 parts vision, and she gave me blessings, and she was more eager to get the other eye done for them. And already last month I had done her that case. So exhausted pre-operative workup is a must, though I misjudged the amount of degree of zonular weakness in this case. We should always expect the unexpected, keep all our backup procedures ready at hand. We as anterior segment surgeons should train ourselves with the basics of the pars plana vitrectomy and the secondary IOL procedure. And last but not the least, keep our VR friends close, because at the end of the day, they're going to bail us out. Thank you very much, and my acknowledgements.
Thank you. Nice presentation. It's just that my thoughts to the expert panel, I want their opinion. I felt there was a little more than necessary fishing of the IOL to bring it forward. And the vitrectomy also, no, you should
While doing
the
vitrectomy, it should have been sutured first. It had become
sutured and
hypotonous.
And more for the iris clip, it can happen in anybody's hand. That ovalization, you need to push in the right equal amount of tissue on either side, which I know. I mean, it is. You said no, it got a little peripheral. You can't.
Yeah, madam, I sutured the wound. We didn't show it over here. And little bit fishing, I took little bit liberty because my thought of point was she was not at all allowing anybody to touch the other eye, because the other eye has been aphakic outside. So I had a motive that at any cost I will have to put an IOL in her so that she get convinced, and she ultimately got convinced for the other eye.
Yes, very good, very good.
Thank you, ma'am.
We shall now go on to the next speaker, Dr. Sanjeev Banerjee, consultant Jisha Eye Hospital, Kolkata. What all Jisha? Huh? Okay, very good.
Thank you, AIOS ARC and Dr. Chitra Madam for giving me this opportunity to present here.
Trouble in, trouble out. I prepared myself well for the trouble outside, but was less ready for the inside difficulties. The small pupil and a near total cataract were noticed. Capsule was stained, and the Malugin ring was inserted to expand the pupil. Most of the cortex was absorbed, leaving a small nucleus and opposed anterior and posterior capsules in the periphery. I started capsulorhexis and got my first hiccup. The bag was unstable with gross subluxation. Irregular fibrosis of the anterior capsule was making my progress more difficult. The flat, hard nucleus was viscoprolapsed into the anterior chamber. Phacoemulsification was then done. A gross subluxation was noticed. The remaining bag turned out to be a flat posterior capsule plate with fused anteroposterior capsules in the periphery. Integrity of the rexus margin was checked. CTR was introduced carefully. Entrapped cortex was aspirated as much as possible. A multipiece IOL was then placed. Malevin ring was taken out. Triamcinolone was injected in the anterior chamber to look for any vitreous prolapse. Fortunately, there was no further surprise from the internal trouble. All along, while I was deeply concentrating to tackle the internal troubles, a set of dedicated co-workers were smoothing out the outside trouble. The patient was a severely compromised kyphoscoliotic female, unable to lie down in a supine position. This being the reason for refusal of surgery from many places. To hold such a person with cardiac and osteoporotic comorbidities without further aggravating the conditions was the biggest issue. Proper advices from a team of orthopedic, cardiologist and anesthetic colleagues gave me the courage to take up the challenge and deliver a successful outcome. It's always a team game rather than individual brilliance. Thank you.
Very nice video.
Thank you.
It is just that could a CTR have been placed earlier? See, these are all just discussion points with the expert panel so that more thoughts come. Could a IOL scaffold have been used?
That was my first
Yeah,
thought, that these kind of cataracts are typical for IOL scaffold to be used. It gives you a lot of advantage, but very well done. I would say
Very
it's
well
an excellent
done.
surgery.
Very well done.
Thank you.
Very good. Excellent.
So actually, I had to finish the case in very rapidly because
No, you did very
so the
well.
patient.
Yeah.
That's right.
Very good. Congratulations.
Thank you
We
very
go on
much.
to our
Thank
next speaker, Dr. Manas Rar, who's consultant cataract glaucoma surgery from ASGI Hospital, Calcutta. And he's going to be showing another interesting case. Yeah. Deepa Saha. Dr. Deepa Saha, yes, please come. She's a medical director from, I may be wrong, from, is it ADEA Diabetic? Okay, right.
Yeah, yes, yes. Thank you for the opportunity. I'll be presenting a video on phaco in a microspherophakia. So this is a retroillumination slit lamp image of a microspherophakia, which is looking like an eclipse in the eye. This 23-year gentleman presented to me way back in 2016 when I was in Arvind Hospital, Pondicherry. He was having microspherophakia in both his eyes with lenticular myopia of around -16 diopter, and he was not comfortable with his contact lenses. So one eye was operated by the legendary Dr. Chi Sun Fek when she was there in Pondicherry in 2016, and later on I did the other eye. So doing the other eye was a great challenge for me, not only because the patient had microspherophakia, but also as the other eye was done by the legendary doctor. So my plan was to do a phacoemulsification and after that fixing the bag with a CTR and 2 capsular tension segments. And for that, I am marking the cornea exactly opposite to each other, where I'll be fixing my capsular tension segment. And then starting with Hoffman's pocket. And dissection is being done with the crescent. It basically preserves the conjunctiva. And staining the capsule, basically, it reduces the elasticity and helps in doing the capsular a little bit easier. And starting my capsular with the cystidome, you can see that there is pincushion effect. And after raising the flap, I continued it with the utrata forceps, and then soon shifted to microrhexis forceps to maintain the chamber, as we know that in such cases that antechamber will be quite shallow. So my aim was to do a capsular of around 4 to 4.5 millimeter, as I know that once I place the CTR, the bag is going to expand a little bit. Then I supported the bag with 4 iris hooks. So one can place the capsular hooks as well. And after that, I'm doing viscodissection to create space for the passage of the CTR. So the one arm is going inside, followed by the trailing arm, and then the soft cataract is phaco aspirated with lower parameters. Never allow chamber to collapse. Bivenal irrigation aspiration maintains the chamber in such cases, and it is preferred. And before placing the lens, make sure that the iris hooks are not too tight. And if one of them is too tight, make them, loosen it up. Otherwise, while placing the lens, it can give way. Then a single piece lens is being placed in the bag, but the game is still not over. I have to fix the bag with the CTS. So this is the CTS now. I am inserting a straight needle of a double arm 90 Polian suture through the eyelet. And then the one straight needle is introduced in the anterior chamber. Viscoelastic is injected just below the iris to create space. And then a 20 gauge needle is introduced through the Hoffman's pocket from a distance of around 1.5. And that's taken out in anterior chamber, and the straight needle is docked inside. Similarly, the other needle is also placed and will be taken on a similar manner. 20 gauge needle goes inside. You can see that the second instrument, I am depressing the lens back complex to create space for the passage of the 20 gauge needle. And this animated video further explains, once we have a lens in the capsular bag, it can be depressed a little bit to create a space for the passage of your 20 gauge needle. Then the CTS is placed in the capsular bag. One is gone, followed by the second one in a similar manner. I made the video a little bit fast forward. And then at the end, titrate it, suture it gradually and slowly, making sure that the IOL stays at the center. Removal of viscoelastics. And this AC is well found. This is 1 week, and this is 2-year post-op. Thank you.
Thank you. That was another amazing surgery. The question here is just for the sake of noise. Dr. Deepa Saha, yeah. The placement of CTR, just for the sake of discussion, could the CTR, 4 hooks were there, could the CTR have been placed afterwards?
Yeah, that is one point. Another, I was, when blue ring was used, generally it goes into the vitreous cavity.
Yes.
Did you take any extra precaution? In this case, even you had a good red glow after that also. And second point of discussion is whether this is the right procedure or a iris claw.
Iris claw.
Mm.
Yeah.
We don't have an answer to it. It is a
We won't
point
have
of
answer.
discussion.
I think an individual skill set, and definitely is it birth doing all this is the question. If you could salvage the moment with an iris claw, that's all. But very well done surgery.
Thank you, ma'am. Thanks.
Just 1 minute. I think I'll have to leave Dr. Subhashish. So I think I'll take this opportunity to, I have my flight at 5 and I have to leave. So I take this opportunity to thank every single person in this audience. I hope my eye reaches to all of you. And I'm so honored. You won't believe I have total my gratitude to OSWB and to Dr. Sugato Paul for helping me visualize my dream, because the last 2-3 years of the 3 years which I have in 2 years were webinars. I'm sure some of you might have watched the webinars, which I used to do at least 4 in a month, very laboriously. The webinars are still running, but now we are able to do started the physical meeting, and seeing this kind of attendance is so encouraging, like I'm sure all of us enjoyed. I enjoyed watching all these videos, and I have no words to thank you all. And I've always looked upon West Bengal as a state very close to heart for the kind of hospitality I have received and the orations and all which was given to me. It just reflects the generosity of the people in West Bengal towards me and my family. And thank you so much. And I would wish that I continue to have your support in all my future endeavors. Thank you so much.
Thank you, Chitra. Only can I request, because this is a home round, and I hope we have lived up to your expectations. And she was telling, we should have a very good meeting, because after during my RC chairmanship, this is one of the first meetings in Kolkata. And then we sat down together and we said, we must do it for AIOS. And as Chitra is so close to us, and so is Satyajit, yesterday he promised he will be all out for AIOC 2024. But before that, let us give her a standing ovation. I request all of you. She really works hard. None of us can match up to her level of work, and I'm sure you will see it in the coming years. And I just hope you will lead us for another stint of your chairmanship. I just hope, please keep that in mind. Thank you.
And thank you for your kind word. One thing you all don't know, that ma'am's father was admitted yesterday, and still she's here. That's what dedication is, and hopefully she will continue.
And we hope we could live up to the expectation. We have given 200 plus. And thank you, Sipla, also. Sipla have been so generous in the support in this meeting. Hip hip hooray. Have a safe flight, ma'am. We will keep in touch. Thank you. Yeah, we wish him very early recovery. Someone to accompany her? Is okay? Okay, we'll carry on. I think Deepa, you start, Deepa.
Hello, good afternoon all. Thank you AIOS and OSWB for making me part of this. Now today in challenging cases, I have brought 3 cases. These 3 cases I faced in a week. First is a phacolytic glaucoma. Second is a fibrotic capsule in a mature cataract. And third was an uveitic mature cataract. Now, this is my first case. Here, an old patient, 80 years old, came in the OPD with an intense pain, redness, headache, and vomiting. Now, on examination, I found this type of picture. The AC was filled with this liquefied lens matter, that is the pseudo hypopion. The IOP was 50. So after giving anti-inflammatory drops and try to reducing the IOP, I was thinking of when should I plan for the OT. Now I called the patient on the third day and the IOP was 24. And on the fifth day, I planned for the surgery. Now here, the important point we have to remember, as the IOP was more, so there was corneal edema. And the important thing we have to remember that we didn't know from the beginning what is the status of the pupil, what is the status of the zonule. And as the IOP was more, there is more chance of rexis extension. But in this case, it was uneventful and it continued as a normal phacoemulsification. This is my second case, a mature cataract with a fibrotic rexis. So what should I do? Now, when actually I am very comfortable with the cystitome. So when I start doing the rexis with the cystitome, the whole system was moving till I can manage to create a flap. And here, one principle we had to follow. Wherever we get stuck, we have to stop there and cut the other end and continue from the other side. You can see here I can't go forward. So I plan to stop here. The fibrotic capsule was all around. So I cut the other side and tried the rexis from other side, and again I was stuck. Again I cut. You can see it was very much thick. So now I thought I could try with the faucet, though I told I am not so comfortable, but it was about to complete, but it extended. Now I tried to cut with the Vanners, but it was so thick, I can't. Now what should I do? So I plan to convert it in SICS, and the case was uneventful. Now, this is my third case. It's a uveitis cataract. So after controlling the uveitis, it was a uveitis cataract and mature cataract was there. Silochio lysis was tried. Then after staining the anterior capsule, silochio lysis was tried from other end. Now here for pupil dilatation, all the pharmacological agents failed. So I plan to do the stretch pupilloplasty. And it was a little bit dilated. Then I tried to complete the rexis. It was adequate size and it was complete. Minimal hydrodissection and rotation done. A central trench was done. Now here, to give less stress in the zonules, I separate with the dialer, and emulsification was done. The second half is emulsified. Epinucleus removed and IOL was given. Thank you so much. Thank you for your patient hearing.
Thank you so much, Dr. Deepa. Dr. Love, you would like to make any comments on the first in which the IOP was raised? Any comments about using mannitol?
Yeah, pre-op mannitol helps, and even the cornea becomes clearer with that.
So she said there was, she had little idea about the status of the zonules and the status of the lens. Would you like to comment on that, of what differently could have been done for her to know anything more?
No, I think it was quite well managed.
She managed it well. Thank you very much, Doctor.
Thank you.
We would like to call Dr. Surya Gupta.
उस लैपटॉप में भी है एक्चुअली नहीं उस लैपटॉप में भी है आपका लैपटॉप तो आपका लैपटॉप ले ना उसमें भी क्या हुआ है वो ग्रे वाला
Surya, you want Swati to come before you?
Yeah, that's fine. Actually, it's there in their laptop also. So, video तो download में है. यहाँ पर हाँ, the PPT खुला है तो. Swati can start. I can.
Swati is standing next to you.
तुम कर लो.
Her audio will work that side only. Surya, yours can play from this side. Acha, ठीक. स्वाति मैम को हेल्प कर दीजिए.
Mayday, mayday, emergency, emergency. Mayday, mayday. Mayday.
Okay. First of all, I'd like to thank OSWB and Team ARC for giving me this opportunity for sharing a challenging case. So it's an honor. So let's start. Not every day is a smooth sail. Well, some days are May days. So my case here, this was in hypermetro female with a shallow AC, PI done, and pupillary dilatation was paracentral, but achieved a central rhexis. Thereafter, hydro was done and the lens saluted. I had a premonition of the iris not behaving well, so I decided to prolapse the nucleus into AC for enhancing the safety. And my premonition came true. The iris started prolapsing, so much so that my phaco probe to enter. I tried releasing the iris with the help of a second instrument. Alas, the iris started bleeding.
Mayday, mayday, emergency, emergency. Mayday, mayday.
Nevertheless, the turbulence was managed and phacoemulsification started. The nucleus now decided to go back into the bag, and the pupil was getting smaller, so I decided to drench and infuse a little bit of adrenaline, but the iris was misbehaving. I gave a blob of viscoelastics on the iris to flatten it, but it was not listening, and then I decided to displace some viscoelastics from underneath the iris from the main node itself. This led to an allogeneic iododialysis. I went ahead with iris hooks, and now chopping was done and phacoemulsification completed. Cortical IA was done. And IL implanted. The iris hooks were removed. I now ironed the iododialysis, the iris, to assess the extent of iododialysis, which was temporal in 1 to 2 clock hours. So I decided to resuture the iris at its position, that is the scleral spur. So changing gears, I changed to superior and made a scleral groove temporarily, 1.5 millimeter just behind the limbus. So a 10O proline was inserted through the scleral groove and dropped in through a 26 gauge needle inserted from the other side. The 10O proline was passed from under surface of the iris, and this was then taken out. Now this was reinserted from the same wound, opposite paracentesis, and taking care with the help of a second instrument so as to not bite any corneal fibers. This was reinserted just 1.5 millimeter beside the first suture bite, and again taken out from the scleral groove. But this was a day of turbulences, and the needle had bitten a small portion of the cornea, which I tried releasing with the help of sideboard, with spatula. It was a struggle of almost 5 minutes, you can say, but finally the Vanna scissors helped me do that. It helped me release. So the sutures were tied slightly looser so as to allow the iris to reach back a little to its normal anatomical position. Viscoelastics were washed, and this was the post-op picture of the patient 1 week post-op. To sum it up, turbulences might happen, but the landing was done successfully. Thank you.
Thank you, Dr. Swati, for that beautiful presentation. Thank you very much. Expert panel, do you have any comments for that?
Sometimes if you decompress the anterior chamber, that misbehaving iris may go back because you had a nucleus prolapse, then some visco would have been pushed, and that is leading to high AC pressure and the iris getting.
I did that, sir. So when I was trying to, first I gave a blob of viscoelastics over the iris just under the main entrance. But then next step, I tried to, take out viscoelastics, but that actually led to the iatrogenic iodine.
But decompress from a different wound, not from
side.
this.
So I had
Diametrically opposite, maybe, which part which you are not going to use. Just use it for the
I had
decompression.
tried actually everything. So in the editing part, maybe that was awesome. But yes.
Thank you very much, Dr. Swati. We'll like to call Dr. Surya.
And as the ACE presenter, Dr. Surya gets his presentation ready, I would just like to point something about beautifully done the last video, in which the iris was taken, the bite in the iris was taken by the needle, the suture needle. And the 26 gauge needle was used just to support it. Many a times we see that from the 1.5 millimeter through the sclera, we go through the sclera, through the iris, and then we dock. That creates a larger hole at the iris. So the better way is just to support the iris with the opening of the 26 gauge needle, to support it only and not pass it through and cause the perforation by with the suture needle, not the 26 gauge through the iris and then you dock it and not bring it out. Just help in docking with the needle, don't pass the needle through. Thank you. Now it is all yours.
Go ahead, Dr. Surya.
Yeah, sorry for the delay and thanks for having me.
Now, all situations in ophthalmology during surgery are not man-made. Some are natural, and the point is we have to identify those situations to salvage what is left. So I was called into the surgery by one of my juniors. If you can reduce the sound, that the rexes had extended in a immature cataract. So when I got this case, she had made only one port. So I went and made all the other ports. Now I was not particularly tight at this stage. So I decided to salvage as much of the rexes as possible. So the rexes was rounded off. Now in these situations with extended rexes, what I prefer is to, dial the nucleus in front of the anterior chamber and then proceed with phacoemulsification. So I was dialing the nucleus out of the back. It's a fairly soft cataract. It's not a hard cataract. The patient is under the block, but the patient was complaining of a little pain. The eye is still soft. So I put in viscoelastic. Now the first sign of trouble was the pigment started coming out from the side port. So I decided to, bring the nucleus a little bit more anteriorly over the anterior capsule so I could finish phaco. And when I was doing that, if you could notice, there's a small bubble here. Now I know that vitreous is coming from the port. So I abandoned the thought of doing phacoemulsification in this case. My primary concern was to get the nucleus out to avoid drop and get the help of a VR surgeon. So extend the main port a little. And then try to take out the nucleus with the help of a simple wet test. But the nucleus was not as soft as it looked. Even though I had made around a 5 millimeter corneal incision, the nucleus was having difficulty being expulsed out. But still, never lose hope. Keep on trying as much as possible. So the vitreous from the wound was cleared, but at this stage I was not feeling very comfortable. So I decided, let me first stitch the anterior chamber. Let me close the anterior chamber first. And then I can proceed with vitrectomy and complete the rest of the case. Hanji, jo bhi mila haath mein pehle. Because the patient was complaining of pain in a blocked eye. I was not very comfortable with the situation. So put in 3 sutures. After the case finished, I can always replace these sutures or with 10-0 or whatever. So I go in and start doing vitrectomy. Now the eye is now slowly becoming quite hard. And the patient is literally screaming in pain. So now I know something majorly is wrong. The glow is still there. But then you can see stuff flying out from the back. You can see small clots. So at this point, we decided to stop with the surgery. We rushed the patient out. We gave him IV 2 units of mannitol. And the next day, the post-op picture was this. We had huge choroidals. This is the post-op picture, thankfully, with air. So my point with this video is that we could recognize something was wrong, and then we abandoned the surgery right in the middle and then decided to proceed with mannitol so we could salvage. And the patient, thankfully, has got some amount of decent vision. He had a history of glaucoma, irregular medication, so he has optic atrophy in both the eyes. But at least we didn't have a massively expulsive hemorrhage where we had to, eviscerate the eye. Thank you. That's my case.
That was a nice learning video. Any expert comments?
And mannitol means 300 ml of mannitol if there are no contraindications. 200 ml is fine, not 100 ml. In the beginners, we feel we should not just 100 ml of mannitol. No, at least 300 ml or 250 ml of mannitol is a must. 100 ml of mannitol will not serve you. A mayday saved again. You saved the eye.
Yeah, that is what was, I was thankful.
Surjo, it is not the challenging, but you have to inquire about the preoperative history properly. So this challenge will not happen if you have got any pursuit about the history, any uncontrolled glaucoma, so that you have to be very cautious about it. So our challenging cases sometimes happen with some negligence. Sometimes, I think so. Thank you very much.
Please go ahead.
If you have anticipated that it's going to be a suprachoroidal hemorrhage,
No,
choroidal
I
hemorrhage,
didn't
if you
anticipate.
have, say,
Okay.
when you have seen that the rexis has run away, So you thought that it was a case of probably a hemorrhage occurring inside. What would have been your next step of the mode of action?
No, I don't think at the point the
No,
rexis
no,
extended, you didn't know what is happening.
Yeah, I was called in the surgery that there's an extended rexis in a cataract which was being done one of my juniors. No, it was.
No, it was not.
No, I wouldn't have done the surgery then. So there's no point in doing the surgery then.
If your point is that then the surgery should have been abandoned at that point of time, perhaps.
Now, if the eye was hard, you have to give preoperative mannitol and then proceed with surgery. That is a given. The eye was soft. I was called at the stage that there's an extended rexis and immature cataract. I don't get the question actually. In the other eye?
Abandon the surgery and think of doing it for the second time, and the same intraoperative hard eye occurs. How can be so sure that it will not occur the second time when you close the eye and do it for the second time?
Would all of this have not happened if the rexis had not extended?
Probably
And then we would not be
probably
talking
the
about
trigger was
negligence surgery.
probably the trigger was extension of the wound leading to a low intraocular pressure, and that would have triggered the suprachoroidal.
My assessment of the case was, since this was a case of glaucoma, the sudden decompression of the nucleus caused the expulsive.
And
patient was 62.
See, commenting after seeing video is very easy, but one thing what could have been done, I feel, is rather than going for a SICS or prolapsing in the AC and then trying a phaco, small pieces of chopping would have saved the situation with phaco in the back. Small chops.
Would little vitrectomy have made the eye softer?
I was not hard at this point.
You said slowly it was becoming hard.
Yeah,
Intraoperative.
Yeah, when the vitreous started prolapsing from the main port.
Problem started after AC, the nucleus was prolapsed in the AC,
Exactly.
and then after that.
That may cause choroidal issues and lead to the sudden lowering of pressure.
Okay, thank you very much, Dr. Surya. We
mostly.
appreciate your presentation. Dr. Shibashish Das. Doctor, please go ahead with the video.
So, good evening, everyone. From the start, I would like to thank ARC and OSWB for giving me the opportunity to present this. So today we'll be discussing, I'll be showing a video on the rexis runout. So as we know, in a wide intumescent cataract, rexis may run out. I'm not going to the details of it may happen to anyone. My go-to procedure is I make a two-step rexis. That is what I follow for all my hypermature cataracts. I make a small rexis, I target a smaller rexis. I take out some amount of cortex with my irrigation aspiration from both the sides. Then I proceed to a bigger rexis. Now there are a few opinions, like few surgeons who prefer to take out with a 26 gauge needle before proceeding with the rexis. And I don't think that there is one single correct way. It is whatever is suits in your hand is the correct way to go forward. So I am more comfortable with this technique. So even after in this case, even after I had made a round smaller rexis, and after doing irrigation aspiration from both the sides, I still ended up with a rexis runout. So after completing the IA to some considerable extent, I make a small nick with a Vanus, and I make the bigger rexis with my capsular rexis forceps. So the way I manage this case, it has some amount of divided opinion. Many, I will get to that point. There are some surgeons who prefer this technique, and there are surgeons who do not prefer this technique. So when we are extending into a bigger rexis, even in the slightest of the doubt where you're feeling that you're not in complete control of the rexis, you can always fill it up with viscoelastic. Try to fill it up with viscoelastic multiple times. Even if it is 3-4 times, you need to stop and refill with viscoelastic, but you should be in complete control. So here at this point, at a sudden jerky movement, here I lose my rexis and it runs away. And this was like 2-3 years back when I was still a little less experienced than now. And I pushed viscoelastic in the wrong, I should have pushed it over where it has run away, but I pushed it in the opposite direction, it worsens further. At this point of time, I'm panicking a slight bit. I'm trying to pull it back. I do not know whether it has run out completely. And now I realize that it has run out completely and I cannot salvage it back. So when I'm pulling it back, I'm seeing this tag of rexis is disturbing me. So the best way, whenever a tag is, if you have, even if you're doing a spiral rexis and your tag is leaking out of your main incision, the best way is to cut off the tag because the tag will cause more traction. So I make a small nick with my cystitome and I was trying to complete the rexis with whatever small amount is left. And after folding the rexis on itself with a small pull, I could complete the rexis. So we have a run out on one side. Now, in this case, what I do is I make some small relaxing nicks in multiple. Now, this is something that many surgeons don't prefer, but it is, in my opinion, what I feel is that I already have a big nick on one side. If I'm doing a low parameter phaco, if it has to extend, it will extend. But if I have smaller nicks on the other side, it is on the same principle as we think that can opener gives a little more, like if my bag is extending with my fluidics, because I'm doing phaco inside the bag, I'm not taking the nucleus out of the bag. So if it has to, if I'm trying a phaco inside the bag, if my main extension has to extend, it will extend. But if I have a few more relaxing nicks on the capsule, so it to somehow it transmits the whole extension on the bag when the bag is dilating with the fluid. So it somehow gives a little more cushion and less chances of my main rexis, which has run out, to go out throughly. So in this case, I could complete the case without a rexis which has run out and making it more complicated further. Thank you.
Thank you so much. So Vashi sir, you agree with the nick part?
Personally, as you said, I would be on the other side. I wouldn't have done the nicks because that beats the purpose of the integrity of the capsule. You would have not, you would have tried to do the phaco in a direction where the stress is minimum on the side where the rexis tends to run out. And like people have tried to bring the nucleus in front of the iris in these cases and use viscose sort of things also. So these can help. But then, as you said, it is the courageous and the brave who are, destiny supports. So you get away with it most of the time.
So you said you did this surgery when 2-3 years earlier when you were not so experienced. You still go ahead with doing the nicks?
Yes, I still go ahead with do the nicks if I'm planning to do the phaco inside the bag, because I feel that what is the purpose of a circular rexis is that it has a large amount of integrity. When my rexis has already run out, I have lost that integrity in itself. So if I can make multiple nicks, if the bag is expanding a little bit, it has a few more spaces. The whole pressure does not come to one point.
Physics sounds logical. The physics sounds logical, but I don't know how safe it is to.
I also found a video on YouTube, as we have access to YouTube nowadays. Dr. Udadevan also posted a recent video of some surgeon who has also done the same thing on the same principle that if you're planning to do a phaco inside the bag and you have one point which has run out, you do not know the extent of your extension. If you have multiple nicks, the same principle as a can opener. If the bag is extending a bit, if you have multiple nicks, then the bag has still some buffer spaces to expand through those nicks, and one will not run out completely.
So you're beating the whole purpose of making us learning a rexis. We could have just done nicks everywhere. And
No, the main purpose is that a round rexis is always the best because it has the best integrity. But if my rexis has run out,
we can still do phacoemulsification in a can opener, right?
In reduced parameters, if the nucleus is not very hard, it is possible.
Okay, thank you very much. We'll move on to the next speaker, Dr. Shovik Dan, who will be presenting his challenging case.
Hello, everyone. Hope you all are enjoying this session. I'm Dr. Shovik. Thank you, AIOC, for giving me this opportunity. And without wasting your too much time, here goes my presentation.
It is so much unpredictable that you can't control everything to be going smoothly on your own way. Sometimes it favors you, sometimes you may trap. But everyone should remember that bad phase doesn't last forever. So one should take a deep breath, stay patient, and try their level best to overcome the hurdles. A 60-year-old female patient having complicated supra-hard cataract with old capes in her back of cornea. Her best corrected visual acuity was 6/60 in left eye. She was elected for phacoemulsification under topical anesthesia with pupil retractor. So I began to do the case in the conventional way by syneculisis followed by trypan blue injection in the anterior chamber. Then I did some amount of stretch pupilloplasty in a gentle manner for smooth introduction of the malignant ring. After that, malignant ring was introduced as planned. But while doing the capsulorhexis, I noticed there was a significant amount of genular laxity present in the genular bag complex. This finding was undiagnosed preoperatively as there was a 360-degree posterior signing, very little amount of controlled hydrodissection, perform a bimanual nuclear rotation just to avoid further stress in the already compromised genular bag complex. Now, my modified plan of action was to introduce MST capsular hook to stabilize the bag while doing a phacoemulsification and put a capsular tension ring before introduction of PCIL in the bag. After putting 4 MST hooks, I started phacoemulsification using soft cell technique. After central debulking, an attempt to direct vertical chopping was tried using a sharp chopper. But as you all see, the nucleus is very, very hard and leathery. It was not a cakewalk to separate its posterior plate. I tried and ultimately succeeded to break its posterior plate and gradually started to emulsify nuclear fragments. As the jonules were compromised and the posterior capsule was not stressed and it is undulating too much, I thought it was better to inflate the bag with viscoelastics before removal of the last fragment. So I changed the chopper from the sharp one to blunt one for the safety of the challenging situation and set the parameter moderately low. But with all of my precautions, I could save the posterior capsule. I tried to seal the rent with viscose and bring all the unemulsified fragments in the central area by using a Sinski hook. Then I eventually emulsified all fragments in a slow and controlled manner in low parameters. Now the table has been turned against my side. In absence of posterior capsule, there was no role of CTR and capsular hook. And I have to put a multipiece IOL in the sulcus in this case. The hooks were removed, triamcinolone assisted, limited anterior vitrectomy was performed. But after completing the anterior vitrectomy, I discovered there was an extension of the rhexis margin. The cause may be accidental stretching of the rhexis margin or injury by a sharp chopper during the phacoemulsification. As the extension was in the superior part, I opt for putting multipiece IOL in the sulcus. But during the IOL delivery, it unfolds in a reverse direction. Using a McPherson forceps and dialer, I eventually managed the IOL. Then, after putting visco in sulcus, I put the fast haptic in sulcus. But while dialing the second haptic into sulcus, the fast haptic was entered through the torn rhexis margin inadvertently. I rescued the fast haptic from the vitreous cavity with the 2 dumbbell and eventually placed it over the iris plane. To overcome such tricky situation, I decided to use a holding forceps to grip the haptic, hold and gentle pull and then control release of the haptic in the sulcus plane. Now the IOL was stable. I removed the malignant ring and completed the case in a routine procedure. After 1 week of post-op, the IOL was very much stable, centered, and best corrected visual acuity was 6/9.
Finishes off in style. India lift the World Cup.
So, whatever may be the situation, don't lose the hope. Be patient and try to give your level best to achieve maximum possible outcome. Thank you.
Thank you so much. That was a wonderful presentation. That brings us to the end of the challenging case video session. I'd like to invite the expert panel for the next session. Dr. P.N. Biswas, sir. Dr. Ashim Kumar Ghosh. Dr. Chandrima Paul. Dr. Rajesh Majumdar Chaudhary. Dr. Tuhin Chaudhary. Dr. Krishnendu Nandi. And Dr. Bhaskar Roy Chaudhary. Moderating with me today will be Dr. Saurabh Bose. Please come. Dr. Tulika Ghoshal. So we'd like to call the first speaker for today, Dr. Sayan Das. Dr. Sayan Das. Dr. Sayan Das will be speaking on phacopterygium, sequential versus combined, the reasoning.
Okay, good afternoon. So I'll be showing just a few reports in the literature regarding cataract and pterygium happening together, what to do. So the first paper deals with patients with unilateral pterygium, and they found that corneal astigmatism was significantly higher in pterygium affected eyes, and it depended on the length, the width, and the total area of the pterygium. This article showed that after we remove the pterygium, the anterior corneal curvature actually steepens. So the pterygium is in effect flattening the cornea, mostly in the horizontal plane. And there is a myopic shift of the spherical error by 1.5 diopter. Tang et al. Showed that the corneal astigmatism decreased by 3.28 diopter after pterygium surgery in patients with pterygium. And this was a similar article showing a median pre-op keratometric astigmatism of post-op keratometric astigmatism of 2.25D change and a 1.3 diopter change also. The pre-op was 2.25 and the post-op was 1.3 diopter. Now, this was an interesting article. They divided pterygium in two groups with the cutoff being pterygium size of 2 millimeter. And after pterygium excision, the horizontal and mean K values steepened significantly in patients with pterygium more than 2 millimeter, but not in patients with less than 2 millimeter pterygium. So what they did was they derived a regression equation with which they could predict in subsequent patients the change in mean K after pterygium removal, and that was to an accuracy within 0.5 diopter. And they said that this regression equation can be applied in future patients with undergoing simultaneous cataract and pterygium removal. Now, Joshi et al. Compared results between simultaneous and sequential surgery, and in the simultaneous group, the mean K was higher post-operatively. There was an overestimation of IOL power, and the mean post-op AC was also higher compared to the sequential group. Koch et al. Showed the changes in biometry before and after pterygium surgery, and they showed also that the preoperative calculated IOL power is higher than postoperative calculated IOL power. And they also concluded that when simultaneous cataract and pterygium surgery is planned, IOL power should be at least 0.5 diopter smaller than the calculated power. So there should be an undercorrection with the IOL power. Now, there has been, I could find two reports about stabilization of keratometric power and astigmatism following pterygium removal. So this paper showed that it takes 1 week, and the other showed that it may take as high as 6 months. So in conclusion, pterygium usually causes flattening in the horizontal axis, and this depends on the length, width, and area of the pterygium. A sequential cataract and pterygium surgery should always be preferred. And if we plan combined surgery in patients who are unwilling for two-staged sequential surgery For small and atrophic pterygium, there is no need to adjust IOL power calculation, and the pterygium may or may not be removed. For larger progressive pterygium, we should plan a combined surgery and undercut IOL powered by 0.5 diopters to compensate for the steepening of the cornea which happens after pterygium removal. Thank you.
Thank you, Dr. Sen, for that nice presentation. For paucity of time, we'll move on to the next presentation. Dr. Manish Singh will be speaking on co-managing glaucoma and cataract guidelines.
Shayan, what is your own experience? You have described all the literature.
So the same thing. If it's a small atrophic pterygium, I don't do anything. I give the patient an option. But if it's a large progressive fleshy kind of a pterygium, and I always go for a primary pterygium removal.
This is very common, and this we know that either progressive.
It's very difficult to convince patient for two-stage surgery. It's very difficult.
But when it has crossed already the pupillary area, what will you do?
No, sir. I mean, we have to remove the pterygium first, and if there is a little bit of dense opacification in the cornea, we may try a little bit of superficial keratectomy and clean up the area as much as possible.
The idea is that if it is crossing more than 3 millimeter from the limbus, then you should go for two-stage procedure. So up till 3 millimeter of the length of the pterygium, you should go for single-stage procedure.
Sayan, which procedure of pterygium operation has been done in your series of cases you have seen?
So this is not my series.
I am just telling that you have just described.
Yeah,
this.
I have.
You should give some information to the next.
I do a conjunctival grafting primary. In recurrent cases, if there is lack of conjunctiva, I have to do an AMT, an amniotic membrane grafting, and I don't do auto blood. It doesn't work in my hands, and fibrin glue is costly, so I have to put sutures.
Okay.
So remember that if this combined surgery means that cataract with pterygium, in all these cases you should never use mitomycin C. Okay.
Yeah.
So suppose that if you put
Mitomycin C, I think people no longer use for pterygium.
But still now people are using it.
Using it. Okay.
Thank you, Dr. Sen. Before Dr. Manish starts, I would like to request Dr. Biswas sir, Dr. Asim sir, to please come on the chair here. Dr. Chaudhary, Dr. Rajesh Chaudhary and Dr. Tuhi Chaudhary, because I also have to leave. So on behalf of the ARC, I'd like to request you all to please come over here and moderate the session. Can you please come here, sir? Sir, please come here. Sir, we need you on the chair, sir. We need you on the chair. Please, sir. Aye, sir. Aye, sir. Please, sir. हो गया आपके लिए भी चेयर है भाई आइए okay. आइए So on behalf of the Academic and Research Committee East, I'd like to thank all of you. This was my second term as ARC East, and I'll be now standing for Member Scientific Committee. But I would like to thank all of you from the bottom of my heart and the Ophthalmic Society of West Bengal for bringing up such a wonderful program. My heartfelt gratitude to Dr. Sugato Paul, Dr. Subhashish Nag, and the entire team of West Bengal for this wonderful program. A heartfelt gratitude to all of you for having spent your entire Sunday here and making this ARC program so successful. Thank you very much. Thank you.
Well, before Dr. Satyajit sir leaves, so thank you so much. Satyajit sir, thank you so much for having us. So, So we'll start the next presentation, that is a co-management of cataract and glaucoma, respected seniors and dear friends. And thanks to Dr. Satyajit and Chitra madam for having me a part of this program. So we'll be very briefly highlighting the key points which we should think whenever we are managing a cataract and glaucoma. And nice to see so many young ophthalmologists here. These two diseases, they very commonly coexist because they have a same prevalence in same age group. And what is important for us to think is that when you have a patient who is having both cataract and glaucoma, which needs more attention? It is the cataract which is the priority, or it is the IOP control which is the priority, or both of them are equally important. And based on that, you decide how you go about a case. Among all the options we have, phaco with trabeculectomy or phacotrabeculectomy is the most popular option when you're going for a combined surgery. Certain cases like you have a bad uveitic glaucoma, neovascular glaucoma, or patient had a previous retinal surgery, you may straight away consider going for a shunt implant also. There's some newer options like the MIGS, the non-penetrating glaucoma surgery, goniosynovitis. These are very rarely used, but I'll just touch them just for the sake of completion. So we'll discuss mainly about phacotrabeculectomy. Again, as I was telling you, how you decide. So you see the stage of the disease. So suppose I have a patient with early glaucoma, well controlled on 1 or 2 medication. I don't need to do a trab. I can just straight away go for a cataract surgery. On the other hand, I have a patient with very advanced glaucoma where fixation is involved, needs 3-4 medication. Just doing cataract surgery will not be enough because post-operatively IOP fluctuation lead to progression of the disease. So these cases, you need to combine a trap. Number of glaucoma medication. General rule is up to 2 medication. You can consider going for a cataract surgery only. If you're having need 3 or more medication to control glaucoma, mostly you can do a combined surgery. Also the type of glaucoma, as I highlighted, if you have a patient with neovascular glaucoma, uveitic glaucoma, these cases, you definitely need a glaucoma surgery. Target intraocular pressure. For example, now MIGS has come into India. MIGS is generally recommended for patients where the target IOP is high teen, say 18, 19, 17. So if you need a low target intraocular pressure, trabeculectomy is the best option. Preference of surgeon is also very important. Some surgeons are comfortable doing a combined surgery. Some surgeons are more comfortable doing a one-side surgery. Some surgeons are more comfortable doing shunt. So that preference also has to be considered when you are taking these cases. For example, this is a patient who already had a failed AGV, have a failed trap. This was initially planned for a diode cyclophotocoagulation. We thought, why not we try one more AGV? And this worked well. You can see the second AGV. So again, as I was telling you, a preference of the surgeon, what particular surgery you have been doing and you are comfortable, that is also important whenever you're deciding a patient with glaucoma. We'll take some case scenarios. Say a patient where you need less than 2 medication, well controlled over last 1 year. Patient needs early visual recovery. Old patient, they can't come for multiple follow-ups over a period of 1 month. Or angle closure glaucoma where the cynical closure is less than 180 degrees. You can safely go for cataract surgery. But always tell the patient that you may require a trab later. Always remember to monitor the intraocular pressure post-operatively. Whenever you're doing cataract surgery, please do a clear corneal cataract surgery. Avoid doing an SICS. In case you really need SICS, do it temporarily so that you leave the superior conjunctiva for future trabs. Remember, in an open angle glaucoma, don't expect more than 2 to 3 millimeter of IOP reduction. So if you have a patient with glaucoma, open angle and cataract, and doing cataract surgery, you expect a 8 to 10 millimeter. That's a very unrealistic expectation. But in an angle closure glaucoma, definitely the IOP reduction can be significant and it's quite variable. In general, we avoid multifocals and trifocals in glaucoma patients because that leads to compromise of the contrast sensitivity. Gonoscopy can give you a very good clue which patient cataract surgery will do well. For example, this is angle closure glaucoma patient already PI done. You can see that pattern of the iris. It's like a volcano, but this is called as the Mount Fujiyama sign. So on a gonoscopy, if you see a wart like this, a volcano-like a pattern, if you remove this lens, definitely the angle is going to open up and there will be improvement if pressure. So these cases, you can consider straight away going for cataract surgery, monitor the pressure. If trab is required, it can be done on a later stage. As I was telling you, IOP reduction in angle closure glaucoma can be variable. Some studies have shown 4 to 5 millimeter. Some studies have shown as high as 20 millimeter. So in your particular case, you have to monitor IOP. 30% patients, you can have increase of pressure also after cataract surgery. 25% patients have shown that the glaucoma can still progress after cataract surgery, even in angle closure glaucoma. So once you have done a cataract surgery, don't forget that glaucoma management is equally important. We are seeing a lot of challenging cases. Cataract in glaucoma patient also is a challenging case. You can often have miosis, flabby iris, zonular weakness is often associated. So be meticulous with your surgery. If the pressures are high, use pre-op mannitol. Using a dispersive and cohesive viscoelastic material will definitely help you in your surgery. Now, there are certain cases where the cataract is very, very early. The cataract surgery is not important. Maybe the vision is 6/6, 6/6 part. Your glaucoma is extremely advanced. These cases, just go for trabeculectomy. Wait for 6 months, let the bleb be formed properly, and then go for cataract surgery. Don't go for early cataract surgery, because what happens once you've done a cataract surgery in a post-trab eye, there will be some inflammation and that will lead to fibrosis of the bleb. So when you're doing a two-step surgery, always wait for at least 3 to 6 months and then go for a cataract surgery. But again, I'm telling you, most popular option is the phacotrabeculectomy is the ideal option, because you are taking care of both the diseases at the same time. And since you're doing a trab also, post-operative IOP fluctuation will be less. So especially advanced glaucoma where the fixation is involved, consider going for a phacotrabeculectomy and not a simple cataract surgery. One side, two side is very much a surgical preference. I find two side more comfortable, but if you see the literature, most literature have shown that IOP reduction is similar. One side takes less time, two side probably has a lesser fibrosis because there are two different sections. We already discussed about the certain cases where you make and straight away go with the shunt. I'll share a case where we did a trab first. Then after 2 years, you can see a superior bleb. This was a young boy, just 7-year-old, already had a failed bleb. Patient had a complicated cataract. So in this case, we thought of going for a going for a glaucoma shunt along with the cataract surgery. So first you have to place the plate, then go with cataract surgery. Once you have done the cataract surgery, you have put the lens, and then you can insert the tube. Since it's a pediatric eye, you have to keep the tube slightly longer compared to what we do in adult eyes. And then we cover this with sclera and suture the conjunctiva. So these cases, definitely shunt can be a very good option. MIGS surgery is becoming popular in India. Now, a lot of centers have started doing in India. Now, trabectomy is available, eye stent is available, Kahook blade is also available in India. Cost is a very big factor because eye stent is around 1.2 lakh, Kahook blade is around 13,000. But the problem with them is that although it's relatively safer, but the IOP control is much, much less compared to what we get in a trabeculectomy. And they are mainly recommended for mild to moderate glaucoma. Phacogoniocyclosis is also a good option when you're doing for just cataract surgery in a patient who had an acute angle closure attack within 1 year. Like this particular patient, we had an acute angle closure attack just within 1 month. We did a PI, put the patient on maximum medication. Still, we were not able to control the pressure. And since the eye was inflamed, we didn't want to go for a trabeculectomy. We just went ahead with cataract surgery. You can see the pigments on the lens. Pigments can be seen on the lens because of previous acute angle closure attack. Just go for cataract surgery. Once you have done the cataract surgery, implanted the lens, then you can tilt the microscope, and then using the Swan-Jacob lens, you can visualize the angle, and mechanically using the spatula, you can separate these synechias. These work very well if it's an acute angle closure attack within a month or so. In chronic angle closure, the problem is these synechia can reform. But anatomically, you can open the angle and can improve the filtration. So conclude, I say there are multiple options. Phacotrabeculectomy is still the best option, but you have to decide on case-to-case basis what is the best option for that particular patient. Thank you so much.
Thank you, Dr. Manish, for teaching us how to balance the management of the two, walking the tightrope. Panelists, for your expert opinion, please.
Is there any role of associated iridotomy or iridectomy with, in case of angle closure glaucoma or with trabeculectomy? What is your experience?
So role of iridotomy in a patient
at the time of surgery.
Time of surgery. So if we are doing a trabeculectomy, we'll generally do a iridotomy also, because the standard practice is you should do iridotomy which is larger than the size of the stoma. So post-operatively, if you have a shallowing of the chamber or if there is a flat chamber, the iris will not block the stoma. That is the standard practice we have been following. Once the express shunt came into the market, there was not possible to do a iridotomy. A lot of people had temporarily stopped doing iridotomy even in trabs also. And they showed that whether or not iridotomy is not important for overall success of trap. It is useful only when you are trying to prevent the complication, but the flow may not depend on the iridotomy. But the standard practices, we do iridotomy in all cases with traps.
Thank you. Over to Dr. Rupak Roy.
Thank you, AIOS, for this opportunity. Can I have the slides, please? Yeah, I'll be speaking about cataract management in presence of diabetic retinopathy. So cataract surgery in a patient with diabetic retinopathy, here I'm talking of patients who have significant cataract and also has coexistent diabetic retinopathy. So what are the challenges? The challenges mainly are the progression of the retinopathy post-cataract surgery, progression of maculopathy, and other associated complications. So as you all know, diabetes subjects have an overall increased level of inflammatory activity as comparison to non-diabetic subjects. So the moment you go inside an eye with a diabetic retinopathy, there is a chance of increase of inflammation. So what are the broad guidelines that we all should follow? We should treat the macular edema first. So if you have a patient with macular edema and cataract, try to treat the macular edema first before trying to treat cataract. If it is a case of proliferative diabetic retinopathy, do treat them with a complete pan-retinal photocoagulation before doing the cataract surgery, and always achieve systemic control. So if you look at published literature, we see there is about a 10% risk of macular edema developing after cataract surgery in patients with diabetic retinopathy who did not have any macular edema before the surgery. Similarly, if you see, the risk of pseudophakic macular edema is also around 4 to 6%, which is way more as compared to a non-diabetic eye. So basically, I'll be talking about treating macular edema with significant cataract. If the cataract is not significant, please treat the diabetic retinopathy first. But if there is a significant cataract, you have to treat both together. So we'll discuss this in a case-based scenario and how to approach. Before going to cases, always do an OCT. Even if you feel there is no macular edema, it has been found in studies that at least 30% of cases, clinical examination alone can miss macular edema. So always do an OCT before doing a cataract surgery. Some centers like Disha do it routinely for all cataract cases before doing surgery. That is an excellent practice. Some centers cannot do due to some cost concerns, but if it is possible, always do an OCT before doing cataract surgery. So we have a scenario like patient has cataract and no retinopathy, but the patient is diabetic. So the recommendation would be treat the patient with topical NSAID like Nepafenag for 60 days after cataract surgery, even if your surgery is uncomplicated. We coming to the next step up level. If you have a cataract with retinopathy, but there is no diabetic macular edema, there is no macular edema, but the patient has retinopathy, this patient should be given prophylactic Nepafenag at least 7 days before the surgery, which should be continued again post-surgery, and always do an OCT 1 month after the surgery to assess the macular status, because as we have seen before, around 10% of patients will develop macular edema post-surgery, and you need to treat those patients. Scenario 3 is a cataract with a center involving macular edema. So we can have 3 options here. We can either treat the patient with anti-VEGF first, or we can combine your therapy during the cataract surgery, or we can do it 2 weeks after cataract surgery. But the preferred option for most of the surgeon nowadays is to combine it with the cataract surgery, because it can be done in the same setting, and the patient also is happy because vision increases due to cataract surgery. So ideally, we have a lot of agents, but ideally for a treatment naive patient, we should always start treatment with an anti-VEGF agent. We have many like ranibizumab, bevacizumab, and aflibercept. So ideally, we should start with the ranibizumab. Which one to choose sometimes can be a difficult question. Protocol T from the DRCR network has clearly shown us if the patient has good vision, there is no difference between these anti-VEGF agents. If the vision is poor, aflibercept probably works better. Nowadays, we also have the option of Peganax or brolucizumab, but we should not combine cataract with a brolucizumab injection because of concerns of inflammation. Scenario 4 is a cataract with a refractory DME, which we have treated earlier with anti-VEGF agents but has not responded. We can consider anti-VEGF switch or give a triamcinolone or a Ozurdex. Out of all these options, Ozurdex is the most preferred option because of its longer duration of action, less IOP spikes, and most important thing is many of our patients of diabetic retinopathy might have glaucoma also. So patients who are having glaucoma, which is stable with one medication, can be given Ozurdex. So this is an important take-home point. Patients with glaucoma who are stable with single medication can be given Ozurdex. Scenario 5 is a cataract with a proliferative diabetic retinopathy where there is no clear view to do a laser. Here you essentially combine your cataract surgery with the anti-VEGF agent. One thing we have to remember is that anti-VEGF agents can increase the traction in the retina. So do a careful USG to rule out any retinal traction. If there is no retinal traction, you go ahead with the cataract surgery and anti-VEGF and try to finish the laser as soon as possible after the cataract surgery, whenever the situation permits, maybe within 2 weeks. Scenario 6 is a cataract with ischemic maculopathy. Here you can see a ischemic macula. These are the patients who are ideally treated with intravitreal steroids along with cataract surgery. Previously, there was concern whether anti-VEGF agents exacerbate macular ischemia. Nowadays, we have realized it does not, but still steroid is the go-to drug if you have a macular ischemia. Cataract with VMT, if you have a OCT like this, cataract surgery should be combined with the vitreous surgery. Pharmacotherapy will not really help in these situations. Is there any role of laser in the present era of anti-VEGF agents? So yes, there are. We can do laser to the areas of focal leakages or circinets before the cataract surgery. And sometimes even after multiple injection, if you see no improvement, we can do rescue macular modified grid laser. One last thing just that I want to highlight is sometimes a patient of a diabetic retinopathy who did not have a macular edema comes to you post-surgery with a macular edema. It is important to differentiate whether this edema is due to diabetes or is it a pseudophakic macular edema. So now this is a patient who is post-cataract surgery, developed macular edema. You don't see much in the macula, but if you see carefully the FFA, you can see the disc is hot or the disc is stained. So if the disc staining is there, it most likely is a pseudophakic macular edema. On the contrary, this is a diabetic macular edema. You see the disc is silent. So the key differentiation point between a diabetic macular edema and a pseudophakic macular edema would be look in the disc to look for disc staining. Why this differentiation is important? Because the pseudophakic macular edema's treatment is entirely different from the diabetic macular edema. Pseudophakic macular edema, there is really no role of anti-VEGF agents. First choice of therapy should be NSAIDs. Then, if not responding, we should go on to intravitreal steroids. We have a galaxy of excellent cataract surgeons here. I don't really want to go into this, but from a retina surgeon's point of view, who need to treat patients after the cataract is done. So to all my cataract colleagues, it is preferable if you put an acrylic lens, hydrophobic lens, and do a large capsular access so that our view post-surgery is better. Square edges and in the bag implantation is always preferred. Thank you very much for your kind attention.
Thank you. Very good, excellent presentation. And you have covered everything regarding the diabetes and cataract combined.
Thank you, sir.
So no stones unturned. Everything is taken care of.
Yeah, Rupak, please also differentiate, tell us about sometimes the diabetic most commonly associated with NION, arthritic NION, non-arthritic NION preferably, and they also sometimes associated with macular edema. So that has to be differentiated from the diabetic macular edema also.
Yes, you are right. Sometimes this pathology can give rise to macular edema. So I think in those cases, the location of the macular edema, the distribution of the hard exudates in a star pattern, these are the pointers towards a primarily disc pathology.
Thank you.
Thank you, Krishnendu.
Thank you, Dr. Ram. Our next speaker is Dr. Purban Ganguly, and this topic is an oculoplasty approach to cataract surgery. Over to you, sir.
Thank you. I bring you, can I have my slides? Okay, I bring you warm regards from RIO Kolkata. Now, when we are planning for a cataract surgery, a lot of things are in our mind, whether the IOP is controlled, whether the iris is floppy, so on and so forth. We have dealt with these things. But now what I'll tell you is about the stepsons of the cataract surgery, the things that we usually do not care about when we proceed for cataract surgery, the lids, the orbit, and the sac. Now, first stepson of cataract surgery is blepharitis. This is an article published in Eye where they are telling that blepharitis is the most common cause of cataract surgery cancellation on the day of the surgery. Now, about blepharitis, one thing is cataract happens in senile people, and with advancing age, the occurrence of blepharitis increases. And another important fact that I want to share is in cases of post-op endophthalmitis, in 82% cases, the organism in the lid margin has matched with the organism found in the vitreous tab. And with a patient with cataract surgery, whatever IL we are putting in, we have to take into consideration post-operatively, there will be more irritation, prolonged inflammation, and the visual acuity will not be whatever is appreciated in day one. So there are two kinds of blepharitis. We all know anterior blepharitis, which is a usually simpler thing, posterior blepharitis, which has got a multifactorial existence. Now the blepharitis wisdom, the first wisdom is that anterior and posterior blepharitis can coexist in our patient. And the second wisdom is that we cannot get rid of the microbial colonization from the lid. So prolonged use, continuous use of steroids and antibiotic ointments before and after surgery will not help. The long-term treatment is the maintenance of lid hygiene. So this is an interesting paper where they had two groups. One group routinely after cataract surgery, the lid hygiene protocol was maintained, and the other group, it was not maintained. In the group that it was maintained, the post-operative irritation was significantly lower. So what are the culprits? The first culprit is restriction of water application. I tell all my patients to use water, filtered water or drinking water to clean their eyes. The lids has to be cleaned. The topical drop precipitation increases the blepharitis symptoms. Second is the use of the reduced blinking rate that happens after cataract surgery to reduce corneal sensation. And the third most important thing is the khulja sim. Whatever we are trying to expose the eyelid with a speculum more and more, or thoda ho jaye to superior sclera will be exposed, but then we are actually causing damage to the levator. And whatever after putting even a panoptrix inside, if the lid is not opening properly, amar chok choto hoye gache. My eyes have become smaller after cataract surgery. Now, whatever we have put in inside, the result will not be happy, and the second eye will definitely not coming back to us. The third is entropion. For lower eyelid, second is entropion. For lower eyelid entropion, the entropion has to be corrected before cataract surgery. But for ectropion, lower eyelid ectropion, it's a little bit of dicey. The textbook says that whatever is the malposition of the lid has to be corrected. But if it's a mild grade of ectropion and the advanced cataract is there, we might proceed with the cataract surgery. But for an upper eyelid ectropion, it has to be corrected first. Hordeolums in chalazi, I'll not go into it. Do not touch an eye with cataract with an hordeolum. They have to be removed before surgery. Now, eyelid tumors. The fifth stepson, the most important thing is that conventional teaching says that the eyelid tumors have to be corrected, then we should go in for cataract surgery. But now we practice in a developing nation with all our, predicaments. Now, what kind of lid tumors we can wait and we can do the advanced cataract done? For this kind of lid tumor, a fungating mass with discharges going out, with a chance that there might be suppurated bacterial infection, let the lid mass be settled first, then touch the cataract. But for the one over here, it's clean looking mass away from the lid margin. Patient do not patient do not want to remove that thing. You can proceed, then you can see that the patient is already pseudophakic. But the other kind of mass, the mass is there on the other side, do not proceed because the lid margin has involved, it is fungating.
This one, melanosis. Melanosis in the lid, very common thing that we get in a patient with cataract. This kind of melanosis, even in the lid margin, it doesn't look bad. If the patient is willing, there you can do a conjunctival swab preoperatively and proceed. The second kind, okay. If the patient wants, you can do. But the third kind, never ever touch it. Let the lid tumor be settled first. This kind of melanosis, racial type of melanosis, we do get. These are benign. You can proceed for cataract surgery. But this is very treacherous, involving the lid margin. Looking good, but it might not turn up good after cataract surgery. This kind of mass, which is away from the lid margin, long-standing. Now, this kind of mass is very dicey because you probably need skin transplantation over here. And that skin transplantation might be accepted, might not be accepted. If it is not accepted, we are landing up into probably a post-operative ectropion. So better to do the cataract surgery with the individualized, customized consent that, okay, if the patient agrees, if the cataract is of advanced grade, we can proceed. But for the other kind of mass, never ever. We should always deal the mass first, and then we should go in for the cataract surgery. For the misdirected cilia, I have quoted from one of the very famous Bengali movie, Chhadobeshi, which got remade into Chupke Chupke. Even after putting up a panoptrix inside, we have to remember a few misdirected cilia can ruin the game. And definitely, I think Rajesh sir will agree with me that simple epilation is not the solution to it. It has to be dealt with in a proper way. So wisdom from the stepsons. First thing is that we have to look into the adnexa. We need to have a peaceful cohabitation with the blepharitis. The blepharitis will not go preoperatively, neither will it not come back ever after operation. The proper counseling and lid hygiene maintenance has to be there. We should not touch eyelids or adnexa with mild signs of inflammation. Individualized approach for benign and eyelid malignant tumors is required for a country like ours. Thirdly is most important, the consent for a person with a coexisting adnexal pathology where you are proceeding with a cataract surgery without treating it. An individualized, personalized, customized preoperative consent is required. Otherwise, we can land up into soup in today's legal situation. And last thing, I think one thing which Rajesh sir will agree with me, oculoplasty referral is not a blind lane. The cataract definitely will come back to you. Unlike the 90s movies where the stepsons used to tolerate all the oppressions from their mother, these stepsons do retaliate. So we have to keep in mind that the lid pathologies, the sac pathologies, the stepsons of the cataract surgery needs to be addressed only if we have to have a happy patient post-operatively. Thank you.
Thank you, Purban, for that fantastic, succinct presentation. And I love the filmy references. Over to Dr. Rajesh Mujumdar.
Hi, Purban.
Thank you, sir.
Your presentations are always, an audiovisual treat. You're totally mesmerizing.
Thank you. Thank you.
I don't think I have anything much to add, but obviously there are a couple of pointers which, if I may, I think, a lot of practitioners here, they use multifocal premium grade IOLs. And for those practitioners, I think the take-home message is to ensure that the tear film remains pristine, because otherwise any problem with tear film will affect the biometry, and it will lead to a very irate and unhappy patients eventually. As far as the upper lid mass is concerned, I probably would err on the side of caution and remove that, because I feel a pressure again on the globe will affect the corneal curvature and it will affect the post-operative outcome. My principle as far as the lid lumps are concerned, as you said, it's infective, it has to be treated properly. I do not really, I draw a line when it crosses the posterior lip of the lid margin. If it's crossing the posterior lip and is touching the tear film, then it's obviously causing an, malflow over the globe, and that needs to be tackled as well. And last but not the least, I think in a case of thyroid eye disease, you have to be very careful, because even in a dormant case, cataract surgery, any intraocular surgery can lead to recurrence of the inflammation. So, you know,
Thyroid
those
eye
things.
disease, I did not include because I thought of it should be dealt with separately, but we should not touch a cataract with an active
How to,
thyroid eye
how to
disease.
proceed for thyroid eye diseases with a hypermature cataract that has to be operated immediately? So how to proceed and how to take care of the eyes during operation and the
Sir,
post-operative?
that will depend at which state of the thyroid orbitopathy we are talking about. If it is a hypermature cataract with mild grade of proptosis, then we can proceed for the cataract surgery after controlling the inflammation. But if it is a hypermature cataract with a protruding eyeball and a chance of, keratitis, exposure keratitis there, then first let us do an orbital decompression. Maybe second day after orbital decompression, we can proceed for cataract surgery. But before
Is
treating
there any
that,
role of steroids with
hardly, sir. A person with that is I think Rajesh sir can add on to that. But a steroid will only it's a small time solution.
Ashwinda, I feel that obviously in this kind of situation, you need a team effort. You need your endocrinologist on board. You need to, of course, control the thyroid status properly. And of course, I feel that there is a need for and role for steroids as well, because, sometimes decompression may not be your, easily available technique. So steroids, intravenous steroids do have a role, probably, in my opinion.
Thank you. Thank you, Purban. Over to Dr. Rupak Vishwas now. He's going to address peripheral retinal lesions before phaco. When to treat. Over to you.
First, I would like to congratulate ARC for this excellent meeting. It is actually an excellent meeting with so much of, heartwarming gathering of all those young faces and combination of all ages. You have seen Manish has presented very well, Purban, Rupak, all of them have presented a nice talk. So there's a basic principle of, presentation. When you don't have a good talk or good topic, they try to confuse, gathering. So they will not understand what you are going to talk. So this is the principle. Probably I am going to follow you. But again, I'm promising you, I'm not going to, at the end, I'm not going to confuse you. So I have a lot of data in this, but again, this data you don't need to remember or memorize or anything else. I will, analyze the data on your behalf, and I'll try to, demystify to some extent what are the things is lying actually behind us. This is my financial disclosure. Now, why need to address the peripheral lesion when you are planning for a cataract surgery? This is to prevent retinal detachment. Any doubt in this process? I don't think anybody has any doubt. So let us go and find out what are the reasons for retinal detachment following cataract surgery. So if you go for this, the majority of those, this is almost a meta-analysis which shows for 10 years, there is almost near about 30.36 to 0.3. So 0.3 to 0.3% of over a period of 10 years, the incidence of rhegmatogenous retinal detachment following cataract surgery. And that goes down over a period of, that goes down every year, 0.1 to 0.2% every year. Now, what happens, the majority of there's some loose connection here. Can you just help me out for this?
Just hold on, Rupak, 1 second.
না আমার হাত নাড়ার সাথে এরা আমার ল্যাপটপ ভয় পাচ্ছে না কিছু আগে থেকেই হচ্ছিল so now the basic problem is now if you think that ঠিক আছে আমি বিবেকানন্দের মতো করে বলি now the vitreous loss if you think of this the vitreous loss increasing axial length males gender preponderance all the gentlemen please remember and trainee operating. These are the major cause of retinal detachment for these kind of pseudophakic RRD. And the cause increases almost 10 times compared to the, age group. The effect of YAG laser following cataract surgery, yes, there is definitely correlation between YAG laser and, rhegmatogenous retinal detachment, pseudophakic RRD. And this is more common, more association in the Asian population rather than the non-Asian population, and more with the extracapsular rather than the phacoemulsification. So this is just for the information. So this is I'm talking about, this is a meta-analysis in 2022. Now, go back to 1995, they are also the same kind of picture they are telling, the confirmation of an increased regmatogenous radial detachment of the posterior capsular rupture and the anterior vitrectomy, the major cause. The risk factor in after 10 years also remains the same. So even after 2026, also mainly the posterior capsular tear, zonular dehiscence, regmatogenous radial detachment in the fellow eye, increased axial length, and male gender. So 1995, 2006, 2022. So all the basic pathogenesis for the pseudophakic regardi is the vitreous disturbance. So which is actually the basic cause for the retinal detachment. So with this background, this is how the pathogenesis in this whole process, nowhere actually mentioned about the retinal pre-existing peripheral lesion. So it's okay, I'll just proceed with this. So now see the other part of it, the long-term natural history of a retinal, lattice degeneration in the retina. So what happens? The incidence of
Podium, please. If that works. Sorry, Rupa. Just try it on the other podium. Lose a chair.
It change color. So in this, if you go to the natural history of now the lattice degeneration from the other part now, see from the lattice part, what happens? The incidence is only 1% over a period of 11 years, and only 1.4% of the regmatogenous retinal detachment is associated with lattice. So go back. And on the contrary, so what happens? The failure, why the failure of prophylactic retinopexy in the fellow eye occurs? So when you have a other eye retinal detachment and this eye you did a peripheral laser for those treated lesions, and if the acute posterior vitreous detachment occurs, then almost 94% cases there is a development of tear. Now, where those tears occurs? Those tears occurs in the 50% of them, out of those 94, 50% occur in the normal retina and 50% occur at the margin of the retinopexy. So even if you do a retinopexy, when the acute PVD occurs, you are not getting away from those doing the retinopexy. So this is the basic principle. And then subsequently, they develop regmatogenous retinal detachment. So patient education here lies the most important. So if the patient are symptomatic, the most important term here is the symptomatic. If the patient is symptomatic and development of the tear, that is the crux of prevention of retinal detachment in pseudophakic retinal detachment. So this is a high risk category of patient who have. So if you have a other eye having a giant retinal tear or high myop, aphakia, pseudophakia, these are the category of high risk category. So the fellow eye incidence of retinal detachment is around 12%. And if you treat them, it increases, the risk reduces to 10%. So of which again, here also this study also says 50% of the retinal break occur in the normal retina and 50% in the treated lesion area. So setting up a partial PVD. So when you are doing a when you are doing a treatment for pre-cataract surgery peripheral lesion, that time if the PVD is not there, after cataract surgery, the prevention of PVD, which is the most important, or during cataract surgery, the procedure should be taken care so that the PVD occurs, the chance of PVD occurs less. That is the posterior capsular tear or the anti-vitrectomy. These are the most common causes. So prophylactic treatment, also the asymptomatic retinal break and symptomatic retinal break. So asymptomatic retinal break, the chance of progression to the tear or regmatogenous RD is around 10%, Whereas this is around at least of 3 to 4 times if the patient is symptomatic. Symptomatic means patient is having a flashes, floaters. These are the symptoms which is main cause. So even the AO recommendation also, if your treatment is mandatory, when you have an acute symptomatic horseshoe tear or acute symptomatic dialysis or the treatment, traumatic retinal break or treatment rarely indicated when asymptomatic operculated tears or atrophic hole. No treatment when asymptomatic lattice without hole. So, I mean, I will just finish it off this way. And treatment only if associated with HST with the asymptomatic hole. And there are a few area gray zone where asymptomatic dialysis to be treated or not. So if these are all data, I'm talking about the American data. So even the Asian and American data is actually different, but here the data from the Indian perspective, and this is, I'm extrapolating the data from the, pre-refractive surgery treatment. So there the recommendation is also again, all symptomatic horseshoe tear and operculated holes, symptomatic lattice degeneration to be treated. All asymptomatic lattice degeneration can be observed, and eyes with atrophic hole and lattice degeneration can be considered for the treatment if other eye has also development of the retinal detachment. So this is an example. This eye is having a rhegmatogenous RD, other eye having a tear and has been treated successfully. I acknowledge the contribution of Dr. Krishnendu and Dr. Tawhid for this. So to take home is that, so when you have, if you can prevent the posterior vitreous detachment or the vitreous disturbance, that is the key for preventing pseudophakic RD. But again, the treatment is according to the peripheral lesion treatment, be it preoperative or a pseudophakic cases. So this is all symptomatic cases to be treated and asymptomatic cases to be followed up as of now.
Thank you for the insightful talk, Rupak sir. We have Dr. Krishnanu Nandi in the panel. Sir, your insights on this.
Sir, supposing a situation, a 65-year-old male with bilateral multiple lattices, who no symptoms, no family history, wants cataract surgery. So what will be your recommendation? Should we go ahead with the laser first or on the cataract?
What will be your recommendation, Krishna, first? After this talk, whether anything has gone to anybody. So yes, even with the multiple, if there is no PVD, you can go ahead for the cataract surgery even without doing that, doing the peripheral treatment. But again, the most important is that here in these kind of cases, most important is that prevention of the PVD. So by if those patients are, one more important point. Now, how long after this rhegmatogenous retinal detachment occur? So this is the window, if you know the window period. See, যখন cataract surgery হলো আর তার কতদিন বাদে কি rhegmatogenous, this is around 11 months, 11 to 12 months. So you have a window period of almost like 1 year. So if you have a complicated cases which have the PC rent or you have done antivitrectomy, so those are the cases to be followed up very precisely to prevent rhegmatogenous retinal detachment.
And most importantly, the lattice which are present, they may not cause the retinal detachment after cataract surgery. The PVD induces itself can cause another tear formation. That may be the cause of retinal detachment in those patients. So even if we do the barrage laser preoperatively, that does not sufficient enough. We may have to see the patient again after cataract. The risk is very less. Risk is very low.
If you actually tell till the PVD completes. So once the PVD is completed, then the risk significantly goes down, actually. And if the patient is not developed PVD or a partial PVD is there, then the lifelong risk is there. Yeah, the same principle here also. If your posterior capsule is opened up now and the vitreous is antivitreous phase is disturbed, so again the same principle, you need to follow them up because the vitreous, if the PVD occurs, so the basic reason for development of rhegmatogenous retinal detachment is development of PVD, which is causing retinal tear and rhegmatogenous retinal detachment. It is not the pre-existing lesion which is actually causing the. There are some component, but that is the very minimal amount of the component.
That's why YAG laser has to be done very carefully with minimum laser power, minimum laser and maximum gain that should be the aim. If you give more power, if you disturb the vitreous, then there is chance of detachment afterwards.
Yeah, but again, the lot of controversy is there whether the the vitreous body collapses and the fluid comes, so that also induces PVD. So again, anything which is the posterior capsule is open, so there is a possibility. Sir was telling about to do a little bit of less size and less energy to do the PR capsulotomy. But anyway, whenever you do a capsulotomy, the posterior capsule is open.
The
So
hypothesis
even if you
is
do
that
small or
when
large.
the vitreous movement is exaggerated, it is called attrition phenomenon. It is written in the many textbooks. I do not remember exact name of that author. That is the attrition phenomena occurring in the vitreous body when the thrusting of the laser energy maximum for capsulotomy, that may cause this type of
One principle is
tear.
one principle, like what Ashindo was telling, it is the vitreous phase, turbulence on the vitreous phase. Other one is the long term. When you have the posterior capsule is open, the fluid portion of the vitreous which comes to the anterior chamber, and thus the vitreous body tends to collapse, which causes induction of the PVD and leads to retinal detachment.
Thank you for the nice discussion. So the last talk of the session is by another very well-known, our own retina person, Dr. Anuruddha Maiti sir.
Thank you. At the outset, I'd like to thank ARCIS for giving me this opportunity. Well, I will be talking on a very common procedure, or rather the most common procedure, ophthalmic procedure nowadays. That's the intravitreal injections, the do's and don'ts. We have a very nice guideline from AIS along with VRSI. The basic recommendation is to have an informed consent from the patient in his or her language, informed about the options available. Nowadays, we have a lot of options, whether it's a biosimilar, the off-label medicines, every option should be given to the patient, explaining the pros and cons. Injection should be performed in a sterile environment, quite unlike in comparison to the Western world, where they perform the injection in a OPD area. Here in India, it is always recommended to perform intravitreal injection in OT. It should be done by ophthalmologist. This is also quite different from the Western world, where nurses perform the intravitreal injections. Here, it should be done by ophthalmologists who have the knowledge and the training of performing safe intravitreal injections, and also should have the ability and the facility to manage any adverse events that may arise from such an injection. Now, first is a procurement and storage. This comes mostly for the off-label medicine, that is Avastin. The purchased drug should be from an authorized distributor. We should check the cold chain log record. It's not possible from vial to vial, but periodical checkup is required. It should be stored in the hospital in an exclusive refrigerator at 2 to 8 degrees Celsius. It's a common habit that the anti-VEGFs are kept in the refrigerator, where the food is also kept, the pathological samples are also kept. The refrigerator should be exclusive. That's the guideline says. And the temperature display should be there, power backup, and a temperature log. There are various options of preparing the Avastin injection. We are not going to the details. The mostly practiced method is withdraw the bevacizumab directly from the vial using 30 gauge needle by strict aseptic technique in a sterile OT and inject. Now, what is important is, this is emphasized by VRSI, that before starting injecting the first Alicard, we need to send a sample for culture and sensitivity and wait for 48 hours to obtain a negative culture. Once you get it, and then only you are supposed to give. This is the ideal way. I don't know how many of us practices this method, but that should be practiced. Preparing intravitreal drugs for endophthalmitis. There's a very nice intravitreal drug preparation chart given by CIPLA, and this should be mandatory in all our OT, because it's not possible to memorize this preparation for the nurses, and it's not possible for the doctors to guide always, but this chart really helps. for treating endophthalmitis. Now coming to the pre-op preparation, selection and precaution, the need and a choice for an intravitreal injection should be tailored to individual patient. Which patient will need anti-VEGF, which patient needs steroids, should be properly explained. All patients should be screened to ensure a patent NLD duct and a negative regurgitation test. If there is a blockage, we need to treat first and then proceed with the intravitreal injection. Surgical procedural timeout to verify the patient's name, intravitreal agent, and lateral edge. Sometimes we are using intravitreal injection like CAMS. You need to perform 15 injections, 20 injections. You have to be very sure about the patient's name, type of the injection, and the eye to be performed. Bilateral injections are not recommended in India. If you need to perform in both the eyes, at least there should be a gap of 3 days. Uncontrolled diabetes should be treated first before giving the injection. Antibiotics, it's still a controversy, but in India, the routine use of antibiotics for a day prior and 3 days post injections is practiced and recommended. Patient preparation consent is mandatory. And especially if you are using an off-label bevacizumab, it should be included in the consent and explain to the patient that this is an anti-cancer drug, not recommended to use in eye. Each patient should be given a cleaned OT gown, protective gloves, and booties. Now, time of using this allocated bevacizumab, it should be used not more than 15 days. Now, steps of the injection, already mentioned that it needs to be needs to be done in the operation theater. The 10% povidone iodine to clean the skin and the periocular adnexa. Mandatory cleaning and draping is required. A drop of proparacaine eye drops and a 5% povidone iodine to be instilled and kept in contact for at least 2 to 3 minutes. And in this time, you can measure the calipers, make your injection, take your injection, make it injection free, a year free. And routine anterior chamber paracentesis is not recommended, but sometimes in patients, if you feel the intraocular pressure is very high, you can do it. You can see the perfusion with the indirect ophthalmoscopy that is practiced by some doctors, although it's not a mandatory requirement. Post-injection cul-de-sac can again be flushed with povidone iodine, or what we do generally after giving the injection, we press it with a cotton bud tipped into betadine. Regarding the site of the injection, any site is good enough. There is, it depends on the discretion of the surgeon, in which site, inferotemporal, superotemporal, any site is good enough. So this is the draping done. Then we shift to the procedure. Measurement is very important depending on the phakic status. And that's it. So post-operative precaution, the proper lead hygiene should be explained to the patient. Post-injection IOP monitoring is very important. In some agents like steroids, we really need to monitor if the patient is outpatient, outstation patient, then he or she must be asked to visit a local ophthalmologist over there. Symptoms of infection like pain, redness, dimness of vision, swelling, and discharge should be explained and written in the discharge. So you are safe medico-legally that you have warned the patient about the symptoms of infection. Avoid washing of eyes for at least 24 hours. The patient should be re-examined within 3 days after the injection. Good examination of anterior segment to see cells and flare. With the newer medicines, we are a little bit apprehensive on the inflammation part. So obviously the next day examination, or at least within 3 days examination, is very important. Fundus examination is very important because that's not a routine practice done. We should examine for the exudates or any flare up of vasculitis or any hemorrhage that can happen following an intravitreal injection. Check the intraocular pressure at each visit, and if required, we need to treat it. And patient should be instructed to avoid the headbutt for 1 day and swimming for 3 days. In case the patient is due for injection in the other eye, it should be done at least at the interval of 3 days, not the next day. Now, intraoperative and postoperative surprise. The first one, it's the Ozurdex. Instead of implanting into the vitreous cavity, it has went inside the lens. It is due to the faulty technique. Sometimes the wrong indication gives a very bad scenario when the vitreous hemorrhage with TRD is there. You give an injection and there's a worsening of the signs and symptoms. The tractional detachment worsens at the crush syndrome. And obviously endophthalmitis, we don't know the exact reason, but definitely the sterilization failure or any improperly performed technique may be responsible. So there are few don'ts. We should not buy Avastin or bevacizumab from a non-Roche distributor. We should not transport the partially used vials in ice packs, which is also a very common practice. We should not inject Ozurdex in glaucomatous patient. We should not use anti-VEGF in recent MI or CVA patients. Do not use intravitreal injection in acute external infections like conjunctivitis or blepharitis. And also to be avoided in pregnancy and breastfeeding mothers. Here, steroid still can be used, but anti-VEGF needs to be avoided. So the take-home message, the intravitreal injection has definitely caused a huge revolution in the treatment of various retinal disorders. It has become the most common used intraocular procedure worldwide. And it is extremely safe procedure if you maintain the pre-op protocol, proper injecting technique, and post-op monitoring. Thank you.
Thank you, Dr. Maiti.
And mostly the bevacizumab. So do you recommend us to use bevacizumab?
I personally don't use it, but institutions like AIMS, LV Prasad, many bigger institutions and the smaller setups also uses injection Avastin. So this is a recommendation given by VRSI for intravitreal bevacizumab. And this had come when there was few cases of cluster endophthalmitis in 2014. These guidelines had come in 2016.
And do you recommend to aliquot those bevacizumab vial, or do you recommend to use the bevacizumab vial in a single day, or we can keep it for 7 days? How long we can use it?
See, it depends where you are practicing. Previously, I was practicing in a hospital where there was many patients where we could finish the vial in a single day. But in a smaller practice, it is not possible to finish in a single day. But in those cases, I think in those setups, aliquoting in a proper way should be the ideal choice, if you really have to use it.
Okay, and suppose we have endophthalmitis, unfortunately, after giving bevacizumab, so how we are going to tackle with those cases if the patient says you have used off-label?
I think that is the most important part. The consent part should mention it is off-label use. It is not recommended for eye use. In spite of that, if the patient prefers to choose, because you are not giving one anti-VEGF, you are giving the choice of anti-VEGFs. The patient who is choosing it, I don't know whether it will stand in the court of law, but this is what is the recommended by VRSI.
In your opinion, Anirudh, because you are now doing a good retina vitreous work in West Bengal, so do you suggest that bevacizumab still to be used because it is a 30 milliliter volume ampoule, so that you cannot take a small fraction and giving to the patients? That may cause some endogenic of the endophthalmitis chance is much more.
Sir, I personally don't use it.
Thank you.
There are places and there are patients who cannot afford other than Avastin in our country. That is the fact. I think AIMS has a proper pharmacy lab where they are doing aliquoting procedures, and
I think that it should be stopped, in my opinion, because Avastin is not recommended. So that why should I use for
Sir, in countries like
intravitreal
US, the
injection.
most used intravitreal is Avastin. So in India, how can we stop it?
Prashad uses it, but why Dr. Ashim Ghosh will use? Because I do not earn the money, earn the money only. I do the good for the patients who will be benefited or who will be
Sir, I think
losing
this
the
is not about the
vision
money.
after
Rather, it is for
endophthalmitis.
patients who cannot afford it. Now that Vivacizumab acts pretty well, we all are aware. It's a controversy we will continue. I think we should shift.
I have used bevacizumab when there is no ranibizumab and nothing else in RIO. So CGHS patients used to bring vials. I took the consent from them.
Single vial for a
Single
single
vial.
patient.
I used to give 24 to 30 patients in that particular day. I used to call the poor patients and I have done. But I have never
I
found
think
any
still if
endophthalmitis.
it is the most safe method is to
Now ranibizumab is also available biosimilar. It is cost only 7,300. Sir, some institutions are being given bevacizumab single dose with a 10,000, 12,000.
15,000 also.
How it is possible for a patient to be victimized?
That time I am talking about 2004, 5 at that time. So that was the, but I have found 2 to 3% cases there is reaction, inflammation in Avastin after I've given Avastin injection. But otherwise everything, all the, but after treatment. After treatment.
Sorry, sir.
The debate will
regarding the
continue.
injection, I want to mention that you just go parallel to the and then you push in.
Sorry, sir. In the interest of time, I'd like to move on. Thank you all for a very interactive session. I'd like to request Dr. Rajesh Majumdar Chaudhary to stay on the dais.
One session left, Noah, please.
I'll be the moderator of the next session, Enhancing Ophthalmic Practice. Thank you.
Thank you, Tulika. May I invite my co-moderator, Dr. Nandini Chandok, as well to join us on the panel. And I would like to request Ashimda, please stay back. You are again our expert panelist. We cannot let you go so soon. And may I invite our other members of the expert panel, Dr. Kajal Prasad Ghosh, Dr. Devashish Bhattacharya, Dr. Ajoy Pal, Dr. Amitabh Biswas, and Dr. Love Kajugari, please, to join us on the panel. Yeah. May I, we have senior practitioners here. Dr. Yasin, why don't you join? We'll not ask you to ask any question. Please come. You will add gravitas to the panel. Okay, so we have Dr. Arup Bose talking about a very important topic, which is managing unhappy patients. Thank you, Dr. Bose.
First of all, I'd like to thank AIOS ARC for giving me this opportunity. I'm going to talk about a very, very difficult subject, I must say, and thanks to Sugato and Dr. Chitra, Dr. Satyajit, and the team for such a wonderful conference. Even after doing an excellent surgery where everything has gone right, we have been talking about things going wrong, but even if everything has gone right, many a times the patients are actually not happy. So I'm going to share with you my experience of 32 years, to be very specific, 20 years of multifocal surgeries and what I've learned from them. The 10 cases I'd like to discuss what the patient's perspective was and what I've learned from them. My first patient is a 30-year-old female receptionist who was working with me for the last 4-5 years. She was hyperopic by 3 diopters in the right eye, 4 diopters in the left eye. She had posterior subcapsular cataract in the both eyes. The focus was uneventful. The vision was very good. It was hydrophilic multifocal lens in both eyes. The patient got married 6 months back. Only few days back, she came to me with complaints of awkward feeling and dimness of vision, particularly while driving her scooty. That is how the right eye looks. There are only few spots. I'm not sure whether you can see it or not. There are only few spots in the center, posterior capsular opacities. But the left eye, as you can see, the lens is decentered. So this is probably a slightly eccentric rectus and it's a hydrophilic lens. So the patient came to me after 2 years of implantation. She got married, she went to Patna, she came back to and showed me. Now, this sort of decentration with a slightly eccentric rexis can occur even after 2 years. And the lesson I've learned out of it is in all cases of multifocals, give some extra time to target a very well-centered and right-sized rexis because decentration can occur years later of implantation. The second case was a 64-year-old chemistry professor who was operated 9 months back in the right eye, 11 months back in the left eye. There was no significant systemic or ocular illness. It was an uneventful surgery, both eye vision very good. He came back after about 11 months, panicked. Not could he read, not could work on his computer, nor drive, and this is how it looked. You should be very cautious that in cases of multifocal, even very small dots of posterior capsular opacifications causes lot of dysphotopsia, and all these cases should be treated early. And contrary to what Rupak and others have said, that you should target a very small rexis, here it should target a larger rexis so that most of the rings are kept exposed. So very low threshold for eye laser capsulotomy is required in multifocal lenses. The third case was again an entrepreneur, 52-year-old female teacher at a government school. The patient was 6 diopter hyperopic in both eyes. The good ocular surface, healthy disc macula, that was one of my old cases, 17 years back I operated. I was very sure that the patient is going to be very happy post-operatively, but things happened contrary to that, and the patient was very unhappy. This is how I look, perfectly centered lens, lot of rings, and what I could see is the patient works in a government hospital where the lighting condition is poor, and the patient can neither see what is being written in the blackboard. Patient can neither see the faces of those who are at the back, nor could read in that particular lighting condition. So you should always ask the patient, consider the job profile and the working condition of the patient when you are planning for multifocals. Fourth is one retired hyperactive female treasurer of an international NGO operated 20 years back. She happened to be my mother-in-law. Uneventful phaco in both eyes, YAG laser done, resumed refractive lens. That was the only lens available that time. She was never satisfied with the surgery, and she still uses 2.5 diopter addition for all on their work. This is how the eye looked. Well-centered lenses, large capsulotomy done, but the patient couldn't read. It was a big eye-opener for me. It was one of my very old implantations. You must always check the pupil before implanting a multifocal. The pupil in this patient under scotopic condition was 2.5 millimeters. Now, multifocal can work good in these cases. The fifth case is a 68-year-old retired male, operation for 8 years, mild diabetic for 2 years, smoker, right eye operated uneventfully. This corrected vision, which was attained in the right eye, was 20/40, which is not improving with glasses. Left eye was still cataractous, extremely unhappy with the outcome, not ready to get the other eye operated. This is how I looked when I just did a cursory slit lamp examination. Only few spots, as you can see, a few white spots thin on those sides. Otherwise, the eyes looked healthy. When I put fluorescent on the surface, I could make out what has gone wrong. It was a case of epithelial basement membrane dystrophy. And if you do not eliminate these things, this can be easily removed by scraping and putting lubricating eye drops. You should always stain and check whenever in doubt. Second, sixth case is a 62 businessman who was again unhappy. I operated within a span of 3 days. In 8, it's not improving. This and that lens, the breakup time was good. Staining, the corneal staining was not there. Disc and macula was healthy. This is how I lived. What I could find is that was unlikely because the higher aberration was more than 3 microns. You must check the higher order aberrations because having a multiple lens, otherwise the patient might not be happy. The second case is a 57-year-old male, again businessman, both are operated within a span of 7 days. Very good vision post-operatively. Surface is good, fundus is good, everything went well, but he came with complaints of difficulty in eye vision. I think it was a very difficult case. I wanted to see what was wrong, what was wrong. I took this snap for a operating microscope and I could see that the patient has got an angle alpha, which is slightly more. That's why he's looking at a distance to the lens, not from the center. So it's very important that you check the angle alpha before surgery, and if it's more than 0.5 millimeters, don't go on for multifocal lens. And what I do nowadays in all cases of my multifocal surgery is, after having done the surgery, putting the lens, I check the plus. As you can make out the plus sign, it's falling right on the margin of the central ring. So if it's falling, if it's not falling at the center, to make sure you lens to 10 degrees, try and bring it to the center and then leave the case. Otherwise, this patient is going to have lots of problems after the surgery. Now, the 8th case is another retired person complaining in minutes, dissatisfied with the outcome. It was a suprafocal multifocal lens. Though the vision was good, I couldn't see anything wrong. Then when we checked the slit lamp, I could see that the patient has got conjunctival chalasis. And all these small things matters in a multifocal implantation, and always eliminate surface issues before you go in for a surgery in such a case. The 9th case, another IT professional, underwent full surgery. It was done very recently, multifocal implanted at 10 days interval. Vision was perfectly all right, 20/20 in right eye, 20/40 in left eye. IOP fundus is normal, but the patient complained of fluctuating vision, difficulty to work on laptop for more than 3 minutes, photophobia, inability to watch TV serials, not at all happy. I did a non-invasive breakup time. It was 8.4, quite good in the right eye. It's 4.5, slightly worse in the left eye. I did a MEVO scan to check the state of the meibomian glands. As you can see, there's about more than 50% dropout of the meibomian glands. To be sure, there is clear film stability in all cases where you are planning to implant a multifocal lens. And the last case is 61 oral active angio, type A personality on acetylopram. The right eye pre-operative vision was 20/30 part. Mildly diabetic, uneventful surgery, 20/20 post-operative. And the patient came with complaints of headache, phobia, discomfort. The last 1 week, I saw a patient in a peripheral chamber where I didn't have the facilities. And when I brought the patient to my main center, did an OCT, I could see that the patient has got a macular edema. History with all the clinical examination in all patients who have a complaint. So, that is why our patient in a premium lens is always a priority. Our natural instinct is always to go in defensive mode, try and avoid the patient as much as possible. Then the patient accept and listen to the complaints. The means try to fix it, and 20 by 100 patient can easily be converted to 20 and a happy patient if you take care of these small things before and after surgery. Thank you very much. Looking for a patient.
So that was a beautifully covered topic. You actually covered all the points with all the cases, especially the angle alpha. So two things that I had in doubt was the rexes, if we are speaking, and these are multifocal patients, how important is flax in these cases? And second, there was a case where you said there was mild diabetic changes. So do we actually put multifocal in mild to moderate diabetes patient, or should we counsel them for
Mild to moderate diabetics, I do put multifocal if the duration of diabetes is not more than 5 years. So that's my cutoff point. And what was the other one you had asked?
flax? How
Flax.
important is flax in multifocal?
Now flax means addition of 45,000. Now, if the patient is ready to invade, flax is always preferred in cases of premium lenses if the patient is ready to pay. But if you are very, very cautious, if you are meticulous, careful, properly have a good deep anterior chamber, use a good viscoelastic, and you can easily make a good round rexis. Because I've been implanting multifocals for quite some time now, I do not have such problems now. Because whenever I get an eccentric or a runaway rexis, I avoid putting in a multifocal and tell the patient that it's not good to put in a multifocal in you because of the chance of decentration where you'll have more problems. Even if the patient has got multifocal in the other eye, it does not make a lot of difference. Even if the patient has got a multifocal in one eye and if you're putting a monofocal in the other eye, it does not make a lot of difference. Patient can still manage. Now, if you have the option, it depends whether you are dealing with a dominant eye or a non-dominant eye. Patients are always happy if in the dominant eye, patient is good at a distance. So if it's a dominant eye, then it's better to leave it emmetropic. If it's a non-dominant eye, you can leave it up to 0.75 diopter myopia.
So I just had one more query. A month back, I did a multifocal panoptic with femto. The patient now has a vision of 6.9 N6. He is still complaining that when he sees the signboard in the airport, it's not very clear. Does the K value have any significance? Because it had a steep cornea of 48 diopters.
No, it's not the K value, it's the amount of higher order aberration. You just check the higher order aberration. If you can have access to that eye trace, just have a look at the eye trace. I think it's because of the aberration the patient is having this problem. Higher order aberrations will be more than 0.3 microns. If it's more than 0.3, the patient is going to have problem under a slightly low lighting condition and at a distance.
Let's hear
Thank
from the
you, sir.
panel now. Kajulda.
Have nicely cautioned us about the preventive steps to be taken before putting a multifocal. But you know, even if I was interested to know from you, even if everything is done all right, there are some unhappy patients. And what you are going to do with them?
Unhappy about what?
Unhappy about everything.
He'll be unhappy with everything. Then I tell you one thing, one very important lesson I've learned, one patient who had problem, particularly I'm talking about the teacher was having difficulty in reading because of it was restored in both eyes, was having difficulty in reading and taking class I've seen the patient after about 15, 16 years, only few days, 1.5 months back, I asked her, how do you feel about it? She said that now I am not having any problem. The light in the class is even worse than what it was before. So there is a neural adaptation. You'll have to keep counseling and telling the patient that things will go all right. I tell you in my experience, I implant about 30% of my implants are multifocals nowadays. And I tell you that I do not exchange lenses at all. For the last, say about 4 or 5 years, I have not exchanged a single multifocal lens. You keep on telling the patient, you keep on counseling the patient. Whenever the patient calls, you try to answer the call, and you'll say that in a span of 6 months, 95% of the patients are going to adapt to the condition that he is suffering from. Thank you very much. Thank you.
No. Yeah, sir.
I think it is the way you talk to the patient and you behave towards patient. When he complains of something, if you are little bit, speak something that may irritate him, then probably he'll become much more unhappy. So it's the way you tackle the patient. If you are soft, nice, listen to the patient, sympathetic, I think half of the problem is solved.
Yes, listening and appreciating that he is having the problem which is there solves most of the problem.
Thank you, sir. So we call upon our next speaker, Dr. Anshuman Goswami, who will be talking about instrument preparation and sterilization.
Good afternoon, thank you so much, AIOS, ARC, as well as OSWB to give this opportunity to me, and special thanks to Shugoto and Dr. Chitra. Of course, she's not there with us right now and she's left for her home. I would be speaking about instrument preparation and sterilization. It's a very huge topic, so I would be sticking to a little bit of basics. And I'm sure it's going to be helpful to those people who are either starting their practice or even those who want to make a protocol for their OT while they're starting their practice into the operation room. Is it better? Better? Yeah, thank you. So I have no financial interest in any of the products shown, and I'm thankful to the institutions and the staff from whom I have learned a lot. It's been a real learning lesson over the last few years. I don't know. I've put everything on fire, it seems. Should I continue? Okay, so all of us learn how to do surgery, and we put a lot of effort in trying to find out how we are going to become expert surgeons. But very few of us even try to find out how the instruments are prepared and sterilized. In the process of instrument cleaning, sterilization, there are basically 4 steps: cleaning, packaging, sterilization, and storage. Can you all hear me?
So I think you can use that mic, it might be better. The 2 minutes maintenance.
Thank you so much. Okay, so coming back to the topic, cleaning is different from sterilization, and you must understand the first thing that you have to do with the instruments is cleaning. That is, cleaning and rinsing the lens matter, the viscoelastics that can permanently block the lumen, saline, salt crystals, blood and blood fluids, which can actually cause pitting of the lens of the instrument surface. And moreover, if the instrument is not cleaned properly, it does not allow the sterilization agent to go inside and seep and do the proper sterilization of the instrument. So cleaning is not same as sterilization. It's the first and most important step towards preparing of instruments. And we all know how TAS presents, and one of the most important reasons for it is presence of OVD in a non-flushed Simcoe cannula or any other IA cannula. Cleaning starts from the OT itself. Our OT technicians have to be trained properly that the moment the instrument is used, it should be cleaned in a saline solution that is present in a small bowl in the operation theater table. This prevents the viscoelastic and the blood from sticking onto the instrument. The other thing which is important is you should try and have a dedicated staff who is responsible for cleaning of the instruments the moment the surgery is over and the instruments are free from the present surgery. Particularly when you have a high volume surgical setup, you need somebody to all the time take over the instruments, do a fast turnover, clean up the instruments before any of the viscoelastic blood and lens matter starts coagulating on it. The other step that has to be done is segregation. So those instruments which are for disposable or sharp instruments are of course to be disposed of. Sharp instruments in a sterile and safe way, not to injure anybody and cause any needle stick injury. And those which are to be reused, amongst them, the ones which have been used in a very infected case like DCR should be put through a enzyme-based cleaning process, and the others can be cleaned with the help of non-ionized water. So we have a lot of sterile solutions used in the OT. I have no financial interest in any one of them. But the important ones to understand is the surfactant-based solution, which helps in cleaning of the surface of the instrument, as well as Cetazyme, which is basically an enzyme-based instrument. And this is basically helpful in cases of organic material being stuck onto instruments like DCR surgery and cases where there are a lot of infection involved. The important thing to understand is whatever detergent you use should be low foaming, easily rinsable or biodegradable, non-abrasive, disperses organic soil, and non-toxic to the user as well as to the environment. The way to clean micro instruments is to use a brush. You can use a soft brush or a super soft brush and nicely clean the instruments, particularly places where there is likely to be secretions from the eye, like from the lids or in the blood and viscoelastic. Remember that whichever instrument comes in a deassembled form should be deassembled and cleaned thoroughly before it's taken up for the next process. The rule of thumb is if it wasn't manufactured that way, it doesn't get sterilized that way. So you have to dismantle it, clean the joints, and sometimes even lubricate the joints if required. Again, with eye surgery, we have a lot of hollow instruments and lumens to be cleaned. And for that, the best way to do it is use non-ionized water and take a large syringe and inject it through the lumen of the instruments that you're trying to clean, like the phaco handpiece or the tubings. And at the end, flush it with air. So this way you are able to free it of all lens matter and other substances. Some of the phaco machines also allow you to put it on a self-cleaning mode using non-ionized water on the other side to clean the process. If you're going to use the same tubing for 2 or more cases, it's best to change it every 2 cases because there is always a chance of endophthalmitis if you keep using the same tubing again and again. The other very good way of cleaning instruments to have an ultrasonographic cleaner. These are special, bucket-like processes in which you put non-ionized water, the instruments, and you put the cleaning through a non-ionized, through a ultrasonic cleaner, and all the small debris are easily freed from the instrument. Once this is done, the tray is also cleaned and the silicone mats are cleaned and dried. This prevents rusting later on. So best is to dry the instruments as well as the tray before packaging it up. So now the instruments are ready and they should be put in the instrument tray in such a way that there's enough space for the steam to pass through. A signal lock or indicator is put and the tray is ready. Large instruments can of course be cleaned in a tub and then wiped dry like the way it's being done out here. Once the instruments are cleaned, the second step is packaging. Packaging can be in rigid containers, peel pouches, wrappers. But the most important thing to understand when it comes to packaging is the packaging method, the instrument used, and the sterilization technique should be compatible with each other. You cannot pack up a substance in a plastic bag and put it to autoclave. So whatever is required and as recommended by the manufacturer, you have to follow it. So packaging, we have these rigid containers. For instance, we have the instrument boxes, and you can see the instruments are nicely laid with a lot of gap in between. And then we have pouches. These pouches can be used both for autoclave purpose as well as for ETO sterilization. And as you can see out here, there are these markers out here which turn their color once the sterilization process is complete. Both marker for ETO as well as for steam are given out here. These are the markers out here, you can see. So they are multi-purpose use. They are very nice. And one important thing to understand, if you're putting any sharp instrument, then it's best to cover the tip of the instrument with a rubber cover before putting inside so that it doesn't punch the pack while doing the autoclaving. These are some of the heat sealing machines that can be used to pack these. And you can, of course, use wrapping. For wrapping, you can use either cloth or you can use porous tissue paper, which is special paper available for packing of these instruments. And this packing can be done in 2 layers. So once the instrument is sterile, the outer pack can be held by the assistant while passing it on to the scrub nurse. Sterilization processes can be done through high temperature and pressure. And one of the commonest things that we all do is autoclaving. It can be done by chemical, by ETO, and it can also be done by low pressure temperature, such as plasma sterilizers. High temperature autoclaves, they can be 2 types, the gravity fed, where the vertical autoclaves are present like this. And basically out here, there is no vacuum created within the chamber. The only thing that is done is that the chamber is filled with steam. So this steam filling may not be very effective, and that's why these are not sterilizers which are usually recommended. But still, because of the cost factor, small setups, it is very useful, and it is definitely, it can always be titrated and checked that the sterilization process is properly done. For this, you have to keep the temperature at 121 degrees centigrade for about 30 minutes and with a pressure of 20 bar. The high pressure vacuum sterilizers basically use a vacuum system which takes out the air from the system itself, and therefore there's a much complete filling of the steam into the system, and the sterilization process is also better. Flash autoclaves, a lot of people have a misunderstanding about flash autoclave. Flash autoclaves are not faster than any other machine. And you have to remember that in flash autoclave, you do not cover the instruments with anything before you put it. They are supposed to be kept bare inside the autoclaver, and they are supposed to be handled by the scrub nurse once it's sterilized. The important thing to understand is it should be used in high turnover places where the phaco handpiece has to be again and again, re-autoclaved, and you don't have too many, but it is not a very preferred method of carrying out sterilization for a routine purpose.
Anshuman, sorry, time's up.
Just 2 minutes. Loading, again, it should be important that there should be enough space out here between the instruments so that there's enough space for the steam to pass through. I'll just skip this. And ETO machines are there, which are used especially in cases where the instrument is heat sensitive and you're likely to damage it if you use an autoclave. The other problem with this ETO is that it's highly inflammable, it's environmentally dangerous, and keeping the instruments for an aeration period of about 6 to 8 days is compulsory after you've done the ETO. The plasma sterilization machines are very high tech and present in usually large setups and not very commonly used in ophthalmology. Thank you so much.
Thank you, sir, for such a beautiful presentation. We'll take the questions after the next talk. The next talk is the most important, and I'm sure all of us have been waiting for this talk, which is on finances and ophthalmology. And for this talk, who can be better than Dr. R.C. Paul himself? So please.
Yes, sir.
So please, we're looking forward to getting some tips, and I'm sure the young ophthalmologists are still waiting for that.
Thank you. Thank you, organizers, for giving me opportunity into talking into something extra of ophthalmology. I am privileged as because it is the last talk. So 90% of, whoever the audience and viewers is not there. So I got some courage to talk on finance. So first, I am not an economist. So what I will be talking in quite few minutes will be talking from my heart, what I do believe. Decision plan basically is not only in finance, in every two aspects, especially for the, I think all are seniors here, nobody is junior. So this is very close to every process. This is plan, execute and analyze. So this is, you have, if you remember a few years back, koi sound? Sound hai bhaiya? दिखता है. So what is there? This is a typical example of plan, executive and analysis. One gentleman thought about, to have the compliance of all Indian laws. We know in a business, just for the corporate social responsibility, if the turnover is more than 10,000 per year, we have to compel 2% of the total benefit into, means donate somewhere for some social work. This is clear. And 30% of our income should go to the income tax. I don't know, probably his turnover is more than 10,000. We believe, we don't know. Should I go for this? Check korbo. Okay. Okay. Sorry. So what he did, according to Indian compliance, this is what is called planning. He started and he invested money into an air channel known as Asta. Probably 90% of has seen. And utilizing the Indian compliance, that will enhance the yoga so that the yoga is tax-free. So he made some businesses. So this is a clip to sensitize you how the planning is important and to execute it and analyze it. So all kinds of oil for, everything is beneficial, everything is helpful for yoga, targeting to women's, targeting to men's, targeting to rich people's, targeting to children's, everything. You see what a beautiful compliance in this government, and he is targeted to start this business after 2014 because our government bring the law of this, that yoga is exempted for, from CSR, yoga is exempted from, the income tax. But these are all fun. Coming to reality, when I searched into the different resources, the American Academy of Ophthalmology provides an beautiful resource. Those who need the financial assistance, they have good economists who can guide you. So in a general guideline, they have provided 7 principal steps how you can think about the, the finance, because this is a crucial time. Probably in the beginning of the life, somebody is completing, their postgraduate training, somebody will be joining fellowship, somebody is going for, family, for a new place for accommodation. So a kind of scenario being changing from one to another. In our language, we see from semi-professional to a professional. So the certain principles what the American Academy guide is, step 1, dare to dream. But yes, caution is this, that dream should be goal-based and realistic. It should be like Ramdev Baba, that I'll invest this much into an Asta TV and I'll get this much into 5 years' time. And it should be realistic. That should not that I will start my practice into an interior of Sundarban Island where the tigers are there and I will expect that 1,000 OPD footfalls in my OPD. And definitely, talking about the budget, yes, so many apps are there, but in reality, we have to think about what is my cuttage of the expenses and the income. Somewhere it should be sustainable. The expense should never be go beyond income. This is the step 2. This is very important, the Insurance Protection Act. Maybe it is gratuity, maybe it is LIC, maybe it is insurance indemnity, maybe it is Mediclaim, whatever. That should you plan from day one in your career. Even if you start, you can start from when you have entered into the medicine. This is very important. And one part definitely we know, especially when the background we do come up, and most of the peoples nowadays, more than 50% is coming up. They don't have the worth, for having the degree, having the qualification. So we go for the different kind of finances, and one of the important finance is the study loan, either by the government or by the bank. So this is the opportunity to shift it, because once you are graduated, once you are an ophthalmologist, so many opportunities comes through the banks which are of the zero interest rate. So what you can do, you can complete your earlier loan, which is will be gathering a huge amount in the interest, and you can pay off completely, and you can come into a newer agreement. So that is utilizing the opportunity what is available into the banking segment. Yes, this is one of the important part that may not be required always, but it is intelligent to have a savings of at least 6 months, whatever the savings is this. Suppose we learned it at the time of Corona, we know what phase even the seniors also has gone. Of course, are not the government officers, but in the private sector, we learned that was not the financial crunch in the government sector. I mean to say, it's not that you were not into the crisis, but this is a big learning for us. So some kinds of saving, and what is being suggested by the American Academy, that minimum should be of the 6 months expenses should be stored off. And this is also important that once I became, starting my career, I should not go for a big investment until and unless I am being settled for quite some time. Otherwise, it brings worry and tension. And this is also very important. This is what is called tax deferred accounts. So we find nowadays Kolkata, you can see 17 crores, 50 crores, 30 crores, whatever. But what we can do, if they have kept one good chartered accountant, that money we need not to be worried about the the black money. And number 2, there are so many things there in the income tax compliance that we can save some money. So this is better to invest some amount of money to a good knowledgeable chartered account. So this is what I talked about, the theory about the American Academy. Now, if I take an example of us, just imagine into the Kolkata Metro or maybe Delhi Metro, what is happening 20 years later. 20 years later, what should be my financial plan? Arup Bosch is there in Mogra. Do you think after 20 years, when your son Siddharth will be coming, the Mogra will remain like this? You will have so many contenders. Yes, your client will be increasing, but not proportionately. This is the reality we have to accept. So in current scenario, suppose we find it, how we can increase and how we can distinguish. I think the biggest investment, biggest financial planning will be how to bring patients, even to government, sir, even to government, because in our Indian system, both government, charity, corporate, social, whatever these things are, though it isn't complementary to one to other. One thing we have to keep in mind, 90% of the ophthalmologists are remaining into only 14 cities in India, state right now in 2022. So how we can expand this challenge, or it is an opportunity, how we can invest in a better way so that we can bring more clientele. So this is an example. I put forward in a very simple chart, is known as, probably all of you know, what is called Vision Center. So on the left-hand side, you can see some of the activity, and on the right-hand side, you have some of the benchmarks. So how do we reach to the benchmark? One is definitely sustainability. It's not that very complicated, calculations. It's very easier for benchmark. We do reach. We did an trial maybe for 6 months or 1 year time into maybe 5 centers or 10 centers, and what is the average footfall we got? And this is the one achievable one, which is very important one. So suppose this is a part of the activity, the consultancy, reflection, and referral. When I was talking, maybe I need 1,000 patients in Salt Lake Center every day after 20 years time. So if I have 5 referral from one vision center, And if I subdivide by 1,000, so this is the number, this is not a big deal. Really, I have to dream, and that should be a realistic one, and that should be goal-based. And also you have to believe there should be a sustainable one, and that should be a replicable one, and there should be an upscalable one. Yes, another program is on the same based on the Vision Center is an D2D screening. When I learned it from, the global ophthalmology, the peoples are doing in some of the project at the time of Corona, that peoples are visiting house to house for screening, I didn't believe. But for last 1.5 years, when I have practiced this and I have found it, and through different, program I have seen, this is a beautiful program with an app-based IT, one health worker from the local community can have an opportunity to visit 50 to 100 houses and can refer jolly well 20 to 30 patients to the nearby Vision Center. That brings the sustainability of the program, that brings the main essence, and to allow the fund capacity, financial capacity, how these people will be sustainable. Yes, weekly adult camp चलता है सर, फ्री भी चलता है, subsidized भी चलता है, paying भी चलता है, trifocal भी चलता है, whatever, all these things, community is based on this. What community needs, they need the information, they need the counseling, and there should be feeling of worth of investing it into the trifocal or worth of investing into an PMMA IUL. So that is the facility, that should be the planning, how to bring it into up. Yes, we have a commitment for the, the young generation, so we do propose 2 bi-weekly school screening camp. Business is not there too much, but this is the commitment. And I think the Rupa Aniruddha all has left. So this is one of the program, we call it, oh, it is there. So you people will be happy at least. From cataract perspective, we are doing it. It is monthly, one of the DR camp, they people has started that how an AI-based opportunity without having too much technical personnel, we can have, the diabetic retinopathy camp. And this is just an standardizations I am calling you. Usually if we call 100 to 200 people's population, if we prick the blood from the history, we get some 20 people, those who have some kind of lesion inside the eye. And with the fundus camera, with the AI calculation, we get at least 10 patients who need some kind of intervention. And out of this, maybe 5, we don't take considerations what is the surgery is this, maybe an intravitreal injection or maybe an laser. So again, there also comes the free, there also comes the paid, there also comes the subsidy. So this is a simple calculations. So if I calculate in a district of maybe Howrah, that there are 10 vision centers, what is the manpower required? So average estimate is, we call it a vision center in charge, maybe an ophthalmologist, maybe an optometrist, maybe an VT. VT may not be very known terms to especially junior. What is this? This is where the, optometrist is not available. Now, so many universities, government universities are there. They will be providing you, certify you for certain criteria for teaching training, and you can come with a good refractionist within 1 year tenure. So they will be easily from the community, they can work into this center. And if they earn in a month 20, 30,000, who else they will be happy for their whole life. And you can create, this is simply giving him for 10 vision centers. I have earmarked it. You don't need to go into this. All total, there are 36 people for the 10 vision centers, namely the optometrist, namely the health worker, namely the counselor, namely the logistic in charge, means we will transport the patient. There is everything has a mechanism, camp mobilizer and social coordinator. So whatever the expense is, simply 6,02,000 rupees. If I subdivide it by 10 vision centers, 1 vision centers come to an cost of, I told you about in budgeting in the second phase of the American Academy. So this is a reality, that is 60,200 rupees per unit. Yes, there is an capital investment, maybe 10 lakhs, 12 lakhs, 15 lakhs, depending on what facility you are providing, and recurring something like, something on maintenance, software, hardware is coming around 67,000. Now, how this will come? Obviously, I can challenge you. You can try it. You can have more than 70,000 in a month. From where? Consultancy of 20 patients of 25 days with 50 rupees comes to 25,000. Chashma ka jo business hai, Kem ka, just purchase one glass. This is a ready-made glass with 35 to 40 rupees from even from Esilar. The uptake is very good with the 200 rupees to the, the community. You can have 100 rupees and this number is all achievable. Sir, we all are doing cataract surgery, so no harm. Even when Washimda going to somewhere place unofficially, I am telling, he won't mind if I take one case to him to give me some percentage. It is not dalali. So it is, enhancing my business, some portions of my profit. If I do share, Washimda shares with me, no harm. So can have some very easily. Our peoples in a month, they take 50 to 60,000 rupees per month from this cataract referral, and definitely anti-BJP and what is called laser. It's not very good business. Maybe right now in a monthly is 3,500 to 4,000 they can earn. But what we are predicting, what we are getting the result, I believe cataract will come down from 50 to 60,000 to 30, 40,000, and anti-BJP will replace this 50 to 60,000. So with these few words, I just thank you again for giving me this opportunity, sharing this opportunity. Thanking you very much in this late hours. Thank you. Oh, sorry. One point I forgot it. This is very close to my heart. It's not about, your working life. At the time of your working life, listen, you should have a retirement plan. That is also into the financial planning. So in my case, I can say what I am doing nowadays. So that is my retirement plan. Why I have chosen? Because I thought after education, health, agriculture is a big chapter in India. We can contribute something. This is tax-free and really I can enjoy my life. I came from a very remote village from that background. And if I can contribute into this faculty, why not? It is the best. Now the choice is yours. Thank you.
Thank you. Thank you, Rohit. Fabulous ideas. I now ask our expert panelists to opine on those two fabulous speakers.
কি বলবো বাংলায় বলছি যে মানে অসাধারণ প্রেজেন্টেশন সবারই একটা দেখা উচিত so that they are not be frustrated and they have to start accordingly and they have to enjoy life because অনেকেই বলছে না স্যার প্রতি বছর এত ডাক্তার বেরোচ্ছে কি হবে আমাদের না খেতে পেয়ে মরে যাব আমি এবার থেকে বলবো ডক্টর রতীশ পালের কাছে যাও তোমাকে সবকিছু অ্যাডভাইস দেবে
আমার তো অসীমই বলে দিয়েছে was excellent and the first sentence was excellent. We know surgery, but we don't know how to sterilize.
Thank you so much.
Angshuman has taught us how to sterilize. Thank you, Angshuman.
Thank you so much.
It's a good recapitulation.
Yeah, what happens is very often the surgeons, after performing the surgery, leaves the place and leave it to somebody else for cleaning the instrument. We are not at all bothered. But now Angshuman has helped us opening our eyes. We should all definitely make it a point to see that our instruments are properly cleaned. Thank you.
Thank you so much, sir.
Question to Rotishda. Now, Rotishda has beautifully explained the way he has planned. Now, only one question to you. Your vision centers are in the periphery. আপনি বললেন অরূপদার কাছে আপনার একটা ভিশন সেন্টারে আপনার লোকেরা ওখানে স্ক্রিন করলো ক্যাটরাক্ট ওই লোকগুলো অরূপদার কাছে না করিয়ে আপনার সুশ্রুতে এসে এখানে কেন করাবে and how do you motivate them or how do you bring them? You have to have this proper channel so that from those catchment area it should come to the delivery center.
Sir, when I have fever, when I have a pain abdomen, how do I choose? I choose he is or she is the best doctor. Even if I am a doctor, even if you are a doctor. Is it right or wrong? True. So fine, believe me, the community, they don't know what is ophthalmology. Believe me, this is a statement. They don't know what is cataract. They don't know what is the, take out of it. They understand little bit. Just I give you an example. In a village, there may be 100 houses, there may be 50 gentlemen, more than 70, having bilateral cataract. Only 2 comes to hospitals or visit a surgeon. Why rest 68 doesn't come? We don't know the chemistry. Now to reply Rupak Mishra's question, this is very important when what we have learned. I have shown in my slide there is an important role of the counselor. So who will believe, who will give the trust, this is the best place, this is the best surgeon, this is the best hospital, this is the best price, even if it is free sometimes. And this is all other support is best. So if the patient believes into it, but if you inform the wrong thing, this is not going to work. So that is the feeling, that is the perception why the people will come. Yes, definitely this. So even see, it is not comparing. Honestly, in this room, we are privileged the patient going to us because patient is selected by some mechanism. We don't know the exact mechanism. That's why the patient come to Arup Ghosh, that's why patient come to Rupak Mishra. So that is the feeling, and that is the job of the counselor as a part from the community. So it ensures, may not be 100%, but 99% it ensures.
Thank you.
I think counseling and communication is the key, because nowadays with organizations like Pristine and Practor coming up, I think we have to bring that X factor, the extra factor, which will ensure that patients coming to us are not even to Pristine. And on that note, in like all good things, this session will come to an end. I'll hand you over to Dr. Shubhashish Nag for the vote of thanks.
Thank you, everyone. At the fag end of the day, this has been a great day. Not just for AIOS, ARC. Of course, it was a big day for them because it was one of the biggest meetings they had planned with us after the COVID pandemic. And we, I think, lived up to the expectation. Thanks are due to the team led by our Chairman Scientific Committee, Shugata Paul, who showed us the way. And as Rotish, who is our leader definitely in the society, who said that it is the belief. It is, we don't know, even yesterday there were numbers, replies here. Thanks are due to them for supporting this event in a big way. We were not sure about the numbers. Chitra madam is so, passionate about it. Hona chahiye, zyada hona chahiye. We must have the numbers. Yeah, it will be. I said, yes, it will be 140. We are targeting 120 to hoga hi. Shugata was more, nahi hota hai aajkal 80, 20, 100 se zyada nahi hoga ye, wo. I said, let us hope 140 tak ho jayega. Even Sipla people were happy, 140 hoga. But see what happened today? 200. I think, let us all give ourselves a big hand. 200 plus. There were a few people who didn't have lunch. I know a couple of them. So the numbers were really great in this physical meeting. And everyone, see, they are not out of our OSWB fold. They are our strongest pillars, I think, the young brigade. And if I have to mention them, each one of the young brigade, that is a big thanks. I'm not naming any particular person. And of course, the science was very much engrossing, and all the masters were there. They spoke the best as they do, and every time, and we must keep up this standard. It is this standard of OSWB meetings that percolates, and definitely if you people must be giving it on FB. I'm not though so much active on it. Facebook and WhatsApp and all that, the news percolates. And so whenever again next meeting OSWB calls in the AIOS fold, they will know that these people, they can deliver. So this is how, you have to have that strong belief. And then after you have done it, you have to go back, analyze if we can do better or what were the wrong things, and then you'll prosper more and more. That is the only way to, I think, grow. So, there's always a space of growing. আজকে সবাই 200-300 ডাক্তার বেরোচ্ছে প্রত্যেক বছর ওর আন্ডারে, that doesn't mean the other person will not grow. There is still a scope for growth, there is still hope. And India is a great country that way. Chance of betterment is always there. The fight is within ourselves. You have to take the fight to yourself. Not, oh, parbe kina, era korte debe kina. No. Whether can I do it? Can I contribute something more to make it better? There is the fight. And I hope we will live up to it. Thank you once again, each one of you. Thanks to AIOS, ARC in their absence. Thanks to OSWB, all of us. Thanks to CIPLA, everyone. Please join us in the next meetings. Thank you.